Now we would like to invite Dr. S.P. Sondhi, sir. Dr. Tanuraj Sirohi, sir. Dr. Rajiv Agarwal, sir. Dr. H.S. Minhas, sir, Medical Superintendent, Subharti Hospital. Dr. Vijay Kher, sir. Dr. K.C. Joshi, sir. Dr. R.K. Aaron, sir. Dr. Dinesh Agarwal, sir. Dr. Pradeep Jain, sir.
Thank you, sir and ma'am, for your valuable presence. And now we request you all to further proceed for lamp lighting. To begin with the conference, on an auspicious note, our students of MBBS batch 2022 are here to perform for Saraswati Vandana.
गाएंगे कैसे? अब करें एक मिनट में आ जाइए
सरस्वती शारदे मां शारदे शारदे मां शारदे सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को विष्णु गजानन जिन चरणों को सेवते हम शिशु अज्ञानी माता जिन चरणों का प्यार दे दिया पारे तार दे माँ सरस्वती शारदे माँ सरस्वती शारदे
Now I would like to invite on. Now I would like to invite on stage Dr. Krishnamurthy sir, Dr. Pramod Kumar Sharma sir, Dr. Saurabh Singhal sir, and Dr. SP Sondhi sir. Now I would like to call on stage Dr. Rajiv Agarwal sir. A huge round of applause, please. Now, I would like to have Dr. Professor SP Sondhi sir for a keynote address to begin the conference. To say a few words about Dr. Mukti Bhatnagar ma'am.
Good morning, everyone, on a very wintry, foggy morning. All of you here, it's an honor to be here. And I have been given a task of talking about Dr. Mukti Bhatnagar. I was requested only last night. And well, Dr. Mukti Bhatnagar I met for the first time as my friend's wife. And then, of course, we had a lot of interaction with her during the time I used to come to the Department of Medicine. So, talking a little bit about Dr. Mukti. First of all, dignitaries in front of me, my friends, my senior and my dear students. Today, we have gathered here with kind of mixed emotions, a sense of loss. We lost her about 6 years back. Deep respect and heartfelt gratitude to celebrate the birthday of our beloved Dr. Mukti Bhatnagar, who not only shaped the medicine department, but the whole of Subharti Parivar. I outline here in next 2-3 minutes some of the facets of her exceptional personality. She was first and foremost a physician and an academician. She believed that medicine is not just a profession, but it is a responsibility towards patient, towards our, our students, and towards society. She remained a avid student throughout her life. She had an open mind, and I was quite surprised a couple of times when she told me, now, Sondi, I'll be doing ultrasound. I said, why should you be doing ultrasound? Is it because I want to learn ultrasound? And then after some years, I found she said, I want to study geriatric medicines. And she went into geriatric medicine. So she was a student throughout her life. Well, as an administrator, all of us remember that she was an excellent administrator. She was pretty strict. At times, many of us felt that she was too strict, but nobody hated her. Every student, every staff member loved her because, she had strictness and empathy together, which is a rare thing. What made her truly extraordinary was her multi-talented personality. She was an amazing artist. I think some of you must have seen in the museum here her paintings. She was an amazing singer. We have heard a lot of her songs, and whenever we used to sing together, she would say, Sondi, you sing a song for me and I'll sing a song for you. So we'll sing songs, enjoy, dance. Of course, she was a very good dancer too. And then in the later part of her life, she was a spiritual leader. She was into spirituality, Buddhism, and all that. So I hope you understand what a multi-talented personality she was. I wish some of you who have not met her should have met her. The reason why everybody loved her was this, that she had a big heart. And sometimes she allowed that heart to kind of dominate her mind. Whenever her students, her staff members required her for some problems, she will bend rules, she will circumvent rules to help them. And that was why everybody loved her. And wherever she is today, I just want to tell her that look at what we have done to the Department of Medicine. And your present head of the department, Dr. Saurabh, was actually trained and mentored by her. And look at we started DNB in 2006, 2007. We started MD in 2010. The first MD batch graduated in 2013. And since then, around more than 150 postgraduates have graduated from this institute. So, ma'am, wherever you are, I hope you're creditable, and we have, in your memory, we have done enough for you, and you should be happy. Thank you very much.
Thank you so much, sir, for the lovely words about Dr. Mukti Bhatnagar, ma'am. Now we would like to have on stage Dr. Jessica for a Ganesh Stuti.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
गाढानुरागाय ग्रन्थाय गीताय ग्रन्थार्थतत्त्वविदे
गानच गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुदैव सदाराध्याय गुरुपुत्र परित्रात्रे गुरुपाखण्ड खण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Thank you, Jessica. Now, to proceed with the conference, we would like to begin with the first session, that is oration. Lessons learned so far. For the session, we'd like to invite Dr. Rakesh Aaron, sir. He's an MBBS from LLRM Medical College, Meerut, and MD also from LLRM Medical College, Meerut. He was the organizing chairman of RSSDI UPCon 2019 at Meerut. Next, I would like to invite on stage Dr. Tanuraj Sirohi, sir, Professor, Department of Medicine, Subharti Medical College. Dr. Amit Sharma, sir, Head of Department, Department of Cardiology, Subharti Medical College. Dr. Abha Gupta, ma'am, former HOD, Department of Medicine, LLRM Medical College, Meerut. The speaker of this session is Dr. Rajiv Agarwal, sir, currently working at Jaswantrai Hospital, Meerut. Dr. Rajiv Agarwal, sir, has received his DM cardiology training and degree from AIMS New Delhi and was the associate professor of cardiology at the same institute. He was also formerly director of Cath Labs, Batra Hospital, and Medical Research Center, New Delhi.
Good morning, everyone, on this foggy morning. It's really probably last 30 years. This is my first lecture, which I am doing at 8:30 in the morning because it's just too early, middle of the night for me. It was Dr. Sondi, Dr. Mukti, who was always in my mind, which I thought I should honor this. Let me be a little bit nostalgic about Dr. Mukti because what Dr. Sondi spoke, he spoke from a different pedestal. I know Dr. Mukti when she got married and joined as pool officer LLRM Medical College in medicine department. And I was a houseman. This was my first month in houseman and her first posting. So we had this relationship all along. I was always like her houseman. And I cherished this relationship till end. I visited her about a month or 2 months before her death and gifted her, I do not know whether it is there or not, a big painting of Lord Krishna. She will call me off and on, talk everything she wanted to talk. And our relationship was very cordial. She was always there to back me up. She was very smartly dressed lady. Let me tell you, she was very smartly dressed lady. Because all of you have seen her in a different phase of life. I saw her just after marriage. She was very outspoken. G.P. Allens, who was professor at head of our college, was like Amitabh Bachchan. Nobody can speak in front of her, in front of him. Dr. Mukti will catch hold of him and say, "Sir, ye aapne galat kiya hai." And we were like shocked, what will happen now? But Dr. Allens was kind to give her that space. She was very, very critical about so many things of Dr. G.P. Allens, and which she never murmured in the background, she spoke on rounds. My family is close to Dr. Atul Krishna also. My father and his father were colleagues. We both come from very humble families. And I vividly recall my father had a very non-gear type of moped, Luna, orange color, which after passing out, Dr. Atul Krishna purchased. And he was moving around in that. My father wanted me to be a surgeon, and he pushed me, being a colleague's son, to Dr. Atul Krishna during surgeries. जाके देख के आया करो. But unfortunately or fortunately, he could not turn me into a surgeon. I was destined to be a physician. I had very exceptional relationship with Dr. Mukti. Whenever I approached Dr. Atul Krishna for one job or another job, this job, he will always direct his staff around. डॉक्टर सुनो भाई इसका काम कर दो, ये डॉक्टर मुक्ति का लड़का है, नहीं फिर उसका फोन आएगा. So that was the kind of relationship I enjoyed with Dr. Mukti, and I am sure she'll be happy what is going on around, the kind of blossoming of a medical college, which I am proud of. In fact, yesterday I was talking to one of my friends in Patna, and he said, "Yaar, wo to bahut acha medical college." I was surprised that the glory of this college has traversed deep into Bihar. I'll end up that under the leadership of Dr. Sondi, Dr. Saurabh, and the family, the department will further grow and make us be proud about that we have something which we can talk about. Now to the chairperson, this is time out, will not be included in my lecture. I'll start formally now. I'm a very passionate cardiologist who enjoy treating patients and treating science and communicating science. Majority of the presentation is basic, just to orient you. If there are DM students sitting here, then raise your hand. I can evolve and upgrade my presentation in between for their learning. Otherwise, this is basically a presentation for MBBS and MD students. This is just to orient you and feel you happy that the first description of angina, which was called Hriday Shul, like a dagger in the heart, which continues to be the classical description of angina, came from Sushruta Samhita, which is way back 600 years before Christ. And you can make out, there is a pointer in it. There is a pointer in it. No, it's not working. The pain travels to the left arm, sometimes also the tips of the fingers. Pain may ascend to the shoulder. Of course, the cause and etiology was not clear at that point of time. We were talking of Vak and Pitta and those kind of things. And we were not oriented to Galen-like physiology or anatomy. And no, it's not moving. Where is that? So you see, Haberden in 1768 described the same thing in different words, but these two definitions are superimposable. So historical. If you have a time, we have English versions of that, read it, then you will correlate quite a bit that there were, on so many occasions, they were right. So, one of the classical problems President Eisenhower, the hero of World War II, he complained at 1 a.m. in the night that there is gas in the stomach, and his wife called the personal physician of White House. He was given antacids, and the first ECG was done next afternoon. So what you see around that several times the myocardial infarction mimicking as GI symptoms, it actually happened to Eisenhower. This is the first president who had an heart attack. We had similar story. I was doing my DM in GB Pant, and Mr. Narasimha Rao became Prime Minister. All the Prime Minister earlier had preventive programs. And I was, along with two of my colleagues, we were on 8-hour duty covering Narasimha Rao, following him everywhere. And he was the first Prime Minister who had a recent bypass done in Texas. He was diabetic, acute kidney injury, hypertension, and a recent CAB. Kind of thing, he became the Prime Minister. And my boss, Dr. Khalilullah, was in charge of overall program. We were following. We implanted AICD defibrillators in house, in PMO, in Hyderabad house. We asked the staff to remove all the bolting things from inside the toilet, so Prime Minister has to go to toilet without bolting inside. We were shown his hands, that how you will put drip. My boss specifically asked me, if you ever inject anything, take the ampule in your pocket, never leave it, because subsequently inquiry, those things will be talked about that you gave a wrong injection. So he said, whatever you do, bring back in your pocket. Don't leave any footprint, because it will be a mess. We had a new Mercedes-Benz ambulance where we can do temporary pacing blindly in the ambulance. First time I saw a tubeless tire where even if you are shot at, they will continue to run. So there are so many things we did, and same thing happened. We were given special passes that allowed to jump in the well if the Prime Minister is in house, because if any one of us jump in the hall, we will be arrested because it's a breach of privilege. Even police can't go. So we threw away those passes. I think that could have been a big memorial and fetched me big money if I had that pass. So there was same thing happened to President Eisenhower, and a legendary man, Paul Dudley White, treated him. He said complete bed rest is wrong. He saved his life, and Paul Dudley White visited White House in a bike. Smoking causes heart attack, life changes, lifestyle changes, low-fat diet. That is the beginning. And there was a huge uproar in America. President has got a heart attack. What is medical industry doing? So at that point of time, I'll show another slide. He died on 23rd of 1905, stopped beating 14 times, defibrillated, and ultimately he died roughly about 55. He had a heart attack, roughly about 14 years, good natural history from that point of time. And Framingham heart study was started after President Eisenhower's heart attack. And whatever you know in cardiology, in prevention, is all Framingham study. HDL is protective, LDL is defective, HbA1c is wrong, exercise is good, weight is lost. Everything, smoking is bad. There was no problem in smoking. Hospitals, there were sisters coming with different 50 kinds of smoking, different kind of cigarettes to your bedside to choose a cigarette. I have that photograph. So smoking was thought to be innocuous. So it's a Framingham study which taught us whatever we know today, that the heart attack, these are the so many variables, and coronary care started in 1960s. Hospital mortality for MI was 30%. Dr. Julian, he wrote a very good book on ECG, created coronary care units, ECG monitoring, CPR, early hospital defibrillation, and result was mortality was reduced to half. And we are doing good. Each decade, the mortality is going down, and broadly, these days, the mortality is around 2.5 to 3%, which is quite reasonable. Something about newer risk factors. Sleep hygiene is very important. Whether it is diabetes, whether it is heart attack, whether it is heart failure, every hypertension, sleep hygiene is very important, and you should be able to look after your quality of sleep. Air pollution is very important. If you have more than 2.5 nanometer particles in this, they can start an inflammatory response. You can have cancers, you can have immunogenic disturbances, you can have diabetes, and probably what we think about that Asians are prone genetically. I think one of the triggers is air pollution, which is so rampant. I was in America in December. The air pollution matrix is just 2520. And inside I have 2 air purifiers in my house. This morning it was 176 inside my house. So air pollution is very, very important and should be talked about, thought about, probably so-called the South Asian burden of CV and diabetes. One of the triggers may be air pollution. And it is epigenetics, and we have to think now beyond traditional risk factors. Light pollution, acoustic pollution, air pollution, loneliness, anxiety, sexual isolation, COVID, respiratory infection, and periodontal diseases. So the spectrum of risk factors is changing beyond traditional factors. We have not finished our traditional risk factor, but it is an upcoming additional risk. This is a normal artery. You know there is intima, media, and adventitia. Whole of the game is played in subintimal space. Between the intima and media is the war zone. And what happens? If you have disease, this is the atheroma, and it starts obstructing the lumen. And when you have triggers, these called shoulders, unfortunately it is not moving, these are called shoulders. Okay. Can I run it? Leave it. ये तो दिखाना पड़ेगा भाई, इसको चलाओ. I'm not moving forward or backward. Yeah, run it. Play it. Can you play? This is a very good, beautiful slide. Any one of this you can play. Actually, I wanted to show you what happens when the plaque ruptures inside the artery, how we do animation. And because if you see this live, it teaches you a whole lot of philosophy, how we treat heart attack. If you don't see this, probably it's theoretical. Can we run it? Yes or no? Run it. So there is subintimal space, and there is a lipid core, which I showed you. And when it ruptures, anyone you can run. There is a lipid core. When it ruptures like a volcano. जैसे ज्वालामुखी फटता है. And the lipid core is most thrombogenic material in the body. And it starts attracting platelets as a healing response. Nature doesn't do it bad for you. The healing has to start. So it first attracts platelets so that healing can happen. If it doesn't work that way, then what nature does, it converts fibrinogen into fibrin threads so that it starts clogging with arteries, and you have total occlusion of the artery, what we call as red thrombus. If it is stopping at platelet level, we call it white thrombus. So in non-STEMI, I am speaking and you just try to fix me up. If you have non-STEMI, there is non-occlusive thrombus. It's a platelet affair. So antiplatelets will work. You won't give fibrinolytics. They are contraindicated. And the hallmark of total occlusion is clinically is ST elevation, where there is a red thrombus. जैसे मछुआरों का जाल होता है, उसमें मछली फंसी हुई होती है, ऐसी फिब्रिन मैशवर्क में आरबीसी फंसी हुई होती है. जैसे ही आप फिब्रिन मैशवर्क को डिसॉल्व करेंगे, आरबीसी क्लियर हो जाएगी. So you restore patency, and that is the concept of fibrinolytic therapy, to restore the blood flow, but leaving a raw area behind where platelets can still adhere to, thrombin can still start working. So you have to give heparin kind of thing. You have to follow up with antiplatelets. I don't think they can run. I am stuck up. You change the slides. I am not moving. Change the slides because change the slide. We go forward, leave these videos. Yeah, let us run it if you can. So the beauty is, most of the time, the coronary arteries are end arteries. And what I mean, is it running? Yeah. You see the injury, as the time passes by, injury keeps on increasing. At point D, you have the mortality reduction and myocardial salvage. As you pass beyond 12 hours, the mortality reduction keeps on decreasing and myocardial salvage is lost. And that is why cardiologists are firefighters. Our whole effort is time related. We have to be in time. We are not gastroenterologists. We are not a general physician where you can say, hold on, let the investigations come. we have to fire and immediately react to. Fortunately, the same approach has come down to stroke units also. Now, there are people who are just doing stroke less than 12 hours, and if it is less than 24 hours, if it is beyond 24 hours, you go to chronic stroke unit because the golden time is lost. भाई चेंज करो, तुमने मेरा प्रेजेंटेशन गड़बड़ कर दिया. So after 24 hours, because most of the muscle is lost, the fibrinolytic therapy or the fibrinolytic therapy or the angioplasty, they lose their edge because you have already lost muscle. These are platelets which are like octopus. The inactivated platelets are like fragments. जैसे आपके चिप्स के और बाकी चीजों के फ्रैगमेंट होते हैं, उनकी आर्म्स नहीं होती. But the moment they are activated, they are like fragment, they are like octopus, they hold each other's hand and they make a platelet thrombus. And that's why we have to use antiplatelets to prevent this phenomena. This is anistemi. And this is a mesh work which I was talking. That happens, this is electron microscopy along with Role formation, which is entrapped RBCs. So the moment you do fibrinolysis, RBC gets released and flow is restored, and it applies to common sense. Anything which does it fast will be better, whether you do mechanically or you do medically. Look at this. In non-STEMI, the ST is down. In STEMI, the ST is up. That is how clinically we correlate that it is a platelet affair or a RBC affair. Is a white thrombus or a red thrombus. This is what is like this. White thrombus is usually non-occlusive. Red thrombus is occlusive, and that's why we need to do restoration of the blood flow. This is a very recent paper which talks about you have higher incidence of nighttime MI, but the myocardial injury in nighttime MI is smaller because neutrophils, which are inflammatory cells, they are hibernating because of circadian rhythm in the circulation. So neutrophilic infiltration in nighttime MI is less and the injury is less. This is one of the ways of looking that day and nighttime MIs, the quantity of muscle loss is different. This is very important timeline. Since it is a teaching institution, every patient in teaching institution in practice, you should have an ECG within 10 minutes. Our guidelines are very clear about time frames. If you have to do angioplasty, you have to do it in 120 minutes. Maximum time from STEMI diagnosis to wire is 60 minutes. Some of the countries are doing like this. We are not. Maximum time for STEMI diagnosis to bolus or reperfusion of fibrinolysis is 10 minutes. So in 20 minutes, if you are a non-PCI hospital, then you should have fibrinolysis on. So it is very, very important things timely because time is money. Time delay from start of fibrinolysis to angiography, if fibrinolysis is successful, 2 to 24 hours. So there is a patient whom you fibrinolyzed, I'll talk this concept, and then you can do angiography within 2 to 24 hours in such individual. Every patient who has had MI fibrinolyzed, we need to do angiography to see what is the background disease. So मैं अक्सर अपने मरीजों को कहता हूँ, जब हार्ट अटैक होता है तो दो चीज होती है, एक क्लॉट होता है, एक ब्लॉक होता है. जो हम दवाई देते हैं उससे क्लॉट खुलता है, एंजियोग्राफी से हमें ब्लॉक का पता चलता है. So there are patients who have more clot They will have non-occlusive atheroma on angiography, will follow medical therapy. There are patients who have more of occlusion, less of clot. They will go for angioplasty oblique revascularization. So that is how you should think about it. This is the timeline I have spoken about. And this is once again repetition that within 20 minutes, you have to do fibrinolysis. If you are not capable for PCI, if you are a non-PCI and want to send it to another hospital, should do PCI within 120 minutes. And same thing we are translating into stroke. I do not know whether in Subharti you are having acute stroke program or not, because this is also very, very rewarding, very, very rewarding. And I'll request Dr. Sondi to call one of our juniors, Dr. Vijay Sharma, who has done exceptional work in Singapore regarding TPA therapy in stroke. And we should call him sometime, and that he will motivate you that stroke is another event like MI, and it is need to be treated. You can't treat stroke 1960 way. आपने लेटा दिया, एवैरिन चलो, CT scan हो रहा है, शाम को देखेंगे. This is nonsense. So stroke has to be managed the way we manage acute MI. It is time defined, and either you do a medical reperfusion or you do thrombectomy. At least medical reperfusion should be done. Another good thing I want to let me come forward. So this is the way, if you have Q wave, already there is a scar. So MI starts with ST elevation. If you have Q wave, then it is a myocardial necrosis. ST elevation is because the current from healthy area going to the electrode, and you have ST elevation. In non-ST elevation, the injury is partial, current is going in, so there is ST depression. There are various types of ways to look how to diagnose MI in acute MI, and in LBB, what we call at Sagbosa criteria, concordant ST elevation. If you have LBB with concordant ST elevation, it is acute MI. Then you have very classical valence sign A, valence sign B. Valence B is a reperfused artery. And why valence is important? It's a very classical. The moment you start seeing it, you will start finding it. Valence means 99% proximal LAD occlusion. It's that specific. So the moment you pick up valence sign, you know it is 99% proximal. If you develop acute MI with RBB, it means proximal LAD, because the first septal is supplies the right bundle is blocked. So you have a very proximal block. If you have acute MI with right bundle branch block, prognosis is very, very bad unless you do revascularization. So there are classical patterns, and this is on top left is the classical J point elevation for ST elevation MI. There are newer criteria that 1 millimeter, we standard thing is not 1 meter, 1 millimeter, V to V3, 2.5 millimeter in young patients, more than 2 in 40 years, and 1.5 on an average is the ST elevation criteria. The enzymes. Top T is little late to come than CKMB, but CKMB goes up, comes down. Trop T comes up and stays for a longer time. So if you have to diagnose reinfarction, don't go for Trop T, because Trop T will be there. You have to go for CKMB. And once you have an ST elevation MI and clinical diagnosis of chest pain as coronary, please don't go for biomarkers. It is nonsense. Don't say, let us wait for Trop T. ST elevation MI with chest pain, 2 criteria out of 3, you are cleared the patient for acute coronary syndrome with ST elevation MI. There is no role of myoglobin. Don't do myoglobin in coronary patient. It is nonsense. If you are doing HS Trop T, high sensitivity Trop T, myoglobin should not be done. CKMB should not be done. What I see every day you have a panel where myoglobin, HS top, and CKMB all are done together. This is nonsense. This is industry is dictating you. If you are doing high sensitivity top T, there is no role of doing CKMB and myoglobin. They are far inferior biomarkers. They are class 3 as per guidelines. This is a very important thing, and I think everyone, whether he is a doctor or a non-doctor, MBBS, MD, or DM, the one thing if you carry home from my talk, I'll be more than happy that whenever you come across a ST elevation MI, you have to direct to your family and friend, bhai tenecteplase lagwa do iske. This is one thing which is life-saving. Still, in many medical colleges, including this, streptokinase is given, which is, I must say, criminal act to do. Government of UP has cleared tenecteplase free of cost in every PHC and CHC. Kerala, Andhra Pradesh, you get tenecteplase free of cost even in PHC. Government of UP has accepted that program. I do not know whether our CMO knows it or not, but you should insist upon you can get free tenecteplase from. Tenecteplase is the agent for fibrinolysis. Streptokinase is thrombolysis. Today, thrombolysis is banned, not written in any guideline. It is third world countries who are doing when they have nothing. But if you have a choice, tenecteplase is the agent and life-saving. Another thing you should remember. Tenecteplase, the printed price is 32,000 rupees. We get it for 18,000. You have to increase your net so that more patients get tenecteplase. It is as good as acute angioplasty because you restore the flow. Each day, each month, I must be seeing 25 to 30 patients who are given streptokinase in different settings, and they are coming with ejection fraction of 25, 20, it is end of journey. You do not know. If your brother gets streptokinase, what will happen? So, learn this one thing from this talk. Anybody who has an MIST elevation, MI, you have to push for tenecteplase, whatever is the circumstance. I have never given streptokinase in the last 20 years to any one of my patients. I'll choose anything, whatever in my command. मैं उनको बहकाता हूँ कि इंडियन लगवाना है या imported लगवाना है. Everybody wants imported. So I convince them for tenecteplase. I have never given streptokinase in the last 20 years. The dose of tenecteplase is very easy, half of the body weight. If you are more than 80 years, then 1/4 of your body weight. You can thrombolize a 80-year-old guy also. The dose is 1/4. Because this is fibrin specific. When you do fibrinolysis, thrombin is released. The resistance to fibrinolysis, thrombin begets more thrombin. You have platelet formation. That's why every patient of these ST elevation MI has to be loaded with antiplatelet, 300 milligram. Aspirin, 300 milligram of clopidogrel. And immediately, so the another trick is the moment you finish your tenecteplase, start IV heparin. None of us start IV heparin because we fear itna powerful injection laga hai, heparin kaise laga de. Start IV heparin and keep an ACT more than 200. If you don't do it, if it reoccludes, you have killed a patient. It will reocclude. So the moment you give tenecteplase, start IV heparin or low molecular weight. If you are giving low molecular weight, half of the dose should be given IV. Low molecular weight can be given IV. So you have to give 0.6, 0.3 IV and 0.3 subcutaneous, not commit an error that 0.6 subcutaneous because it will take time. So low molecular weight heparin can be given half dose IV in such situations so that you start working. And why we talk of tenecteplase? Because the patency is extreme right, roughly about 75% vis-a-vis streptokinase, which is roughly about 32%. So you have double gain. Immediately, these patients, Abba, you must be getting tenecteplase free of cost now. Yes, that is what I wanted to hear, because now the government of UP has accepted the program. So streptokinase, the patency is half of tenecteplase, and tenecteplase is given as a bolus. There is nothing like slow infusion like streptokinase. I have seen people giving tenecteplase in a drip. Tenecteplase is a bolus. And now we are having another where the nanoparticles tagged with TPA can specifically target the thrombus, and that will reduce further bleedings. And that is how you can see the nanoparticle tagged TPA affecting the thrombus in acute MI. Low molecular weight is the drug of choice because it works better. There is 17% additional relative risk reduction. And then clopidogrel, after cure trial, changed our concept that every patient is to be loaded. There is 36% additional risk reduction. There are another two drugs, ticagrelor and the prasugrel. So prasugrel is not a drug for medical treatment. Prasugrel is a PCI drug, P for P. So if you are doing your patient's angioplasty, then you can load the patient with prasugrel. Otherwise, prasugrel is not a medical management drug. The ticagrelor is a medical management drug. Again, ticagrelor cannot be given up to 12 to 24 hours following thrombolysis, following fibrinolysis. Don't commit an error that you load your patient with ticagrelor and do TNK, you will bleed. Once the TNK you have given, patient has been stabilized, after 12 to 24 hours, you can switch from clopidogrel to ticagrelor. And why it is important, clopidogrel has shown event reduction, not mortality reduction. The ticagrelor has shown total mortality reduction. That's why in new guidelines of ACCHA in 25, they have given ticagrelor in ST elevation MI as class 1A indication. So every patient after fibrinolysis should go on ticagrelor after 12 to 24 hours. Don't load it with fibrinolysis. This is one thing which you should carry home, that if you are in a remote area, if you are in a non-PCI area, get all these patients IV heparin. And these patients will do better subsequently, because if you give IV heparin and clopidogrel aspirin in first hour, GC trial has shown they are as effective as streptokinase, because in GC1, streptokinase was used. So it is very important intervention. You see there is a difference in MACE. This is our consensus statement, JAPI. The streptokinase is 2B because it comes in Indian guidelines, but international guidelines do not talk of streptokinase anymore anywhere. Streptokinase is washed out. Then we have an invasive and interventional era. Frostman catheterized, Sones developed coronary angiography. Favellaro, an Argentinian, he did CABG. Grunzing pioneered angioplasty. So now with time, we have started doing primary angioplasty in patient of ST elevation MI. So you can imagine one way is to do medical lysis, another way is putting a wire, ballooning it, and putting a stent to restore the blood flow. This is a concept called pharmaco-invasive therapy. Pharmaco-invasive therapy means you are in an area or where a PCI cannot be done, give these patients tenecteplase And within 12 to 24 hours, you do primary angioplasty if they know, their results are same. So it is not necessary that you have to be in a vicinity of primary PCI to save your life. The ejection fraction and mortality at 1 year is same. So this is called pharmaco-invasive approach. So in places where we are not able to do a primary angioplasty, we should start with pharmaco-invasive and subsequently invasive. I am reminded I gave this talk many years back in Roorkee, and when I talked about tenecteplase, they said, "हमारे यहाँ तो मिलता नहीं है." So I was the chairperson or the president of IMA said, "Let us have one tenecteplase in Roorkee. If one of us have it, we will use that." And they purchased tenecteplase for medical community. So tenecteplase is a very, very powerful drug. Angioplasty without losing heart muscle. This is fast MI program, the same thing, that results are almost same. You have almost non-statistically different ejection fraction over a period of year. So what we call T thrombolysis and early angiography, that is the way we look for the revascularization in acute MI. Primary PCI, class 1 indication, beta blockers, class 2A. We have no role of IV beta blockers, aldosterone inhibitors, ACE inhibitors, statin, double antiplatelet, they are all this thing. Routine thrombosuction is class 3. Facilitated PCI, full dose fluorination is harmful, class 3. PCI of totally occluded artery beyond 24 hours, there is no point in opening these arteries. All of us do it with the hope that it will improve, but medically it doesn't work. Food is very important, what kind of food you eat, because you have to have good food which is loaded with fruits and vegetables. And exercise is very important. Rehabilitation is class 1A indication. So most of us never open up with our patient that do exercise, do walking, get back to your routine, reduce your weight, because it is a very, very powerful intervention after these kind of therapies, and they are classed as class 1A. Roughly about 7,000 steps are minimum. Beyond that, you don't get much. So there is a U-shaped curve even with exercise. You can't be a marathon runner and feel you will live long. Marathon runners have severe associated CV problems. So you have to do exercise in moderation. It is not that extreme exercises, they benefit. Where are the preventive treatments? As you use multiple drugs, the mortality is going down. Beta blocker IV is out. You should start beta blocker on day 2. Day 1, the injury is settling down. You do not know infarct extension, expansion, fall in blood pressure. So we usually avoid beta blocker, that to oral on day 1. With day 2, we start with small doses. ACE inhibitors are superior. They cause 40% relative risk reduction. The IR trial has shown. Sacubitril valsartan is not used in acute After 2-3 months, if you find the EF is normal, heart rate is fine, then we really don't use much beta blockers these days. Atherosclerosis is a chronic inflammatory disease by which now we are having a low-grade 2BB recommendation for using routine colchicine in patients because inflammation. Ruptured thrombus MI, that is the sequence. Now we know it. Nitric oxide as an endothelial relaxant. We got the Nobel Prize for that. Brown and Goldstein LD receptor pathway, and that is a revolution in medical management. Load all your patients of acute MI with 80 milligram of atorvastatin or 40 milligram of rosuvastatin at the time when you are loading your patient for antiplatelet. Guidelines are not very strict on it. They say, now we say load your patient with lipid lowering therapy the way you load with antiplatelet therapy. The problem is we are facing, despite such good therapies, this is a pure study, high income group, 11.2% received no drug, while in low income group, 80.2 received no drug. So we are having a big dropout. I am almost done. Big dropout in terms of secondary prevention therapies. And I am sure if you buy these drugs from Pradhan Mantri stores and all that, it will cost hardly 25-30 rupees a day. So there is a good opportunity to give something to our patient, and that is why most of our patients are coming up, adding to our burden of handling, and full adherence on all these parameters is not seen even in 0.3% of patients. That is the challenge. That is the need of the hour, that despite having good medical secondary prevention treatment, we as a doctors having inertia and patient having ignorance, leading to 80% dropout within a year. Eat more of fruit, they are good for your heart. Do more of exercise and be a good doctor, because this slide will be read from bottom. Inferior doctor treat the full-blown disease. Mediocre doctors treat the disease before it is evident. Superior doctor prevent the disease. So ultimately, we are not here to treat STEMIs. We are here to prevent disease in the community. And this is very, very important. And these therapies work for the community. They are proven, evidence-based. They are not empirical. Thank you very much. Do I have to face a question or something? No.
Thank you so much, sir, for such an enlightening session on CAD and its aspect. Now, I would like to call on stage Dr. Saurabh Singhal, sir, Dr. Rakesh Aron, sir, Dr. Tanuraj Sirohi, sir, Dr. Amit Sharma, sir, and Dr. Abha Gupta, ma'am, for felicitation of Dr. Rajiv Agarwal, sir. Thank you so much, sir. Now I would request Dr. Saurabh Singhal, sir, to felicitate our respected chairpersons. Dr. Rakesh Aron, sir. Dr. Tanuraj Sirohi, sir. Dr. Abha Gupta, ma'am. Dr. Amit Sharma, sir. Thank you, everyone. Now, I would like to request Dr. Shefali, ma'am, to come on the stage for felicitation of Dr. Abha Gupta, ma'am. Dr. Abha Gupta, ma'am, is a professor at LLRM Medical College, Meerut, fellow of Indian College of Physicians, IACM and Diabetes, India. She is the vice chairperson, API UP chapter, and president of API Meerut branch. So we have a lucky draw over here. Now I would request Dr. Saurabh sir to pick a slip for the lucky draw winner.
So we have the first lucky draw of the conference. Those who have come here, this is lucky draw winner is.
I would request Minhas sir
Welcome,
to
sir.
please come
Sir,
on the
आपको
stage.
Those who have come here or registered for the conference, we have lucky draw at every hour of the sessions. तो जिन्होंने भी बाहर रजिस्टर करा है, they will be getting the prize. Chance of this getting this prize. Every hour we have this lucky draw.
Now I would request everyone to kindly proceed for the breakfast, after which we'll proceed with the conference further.
I would request everyone to be just back in 15 minutes. A short session. Actually, we are running late. So only for 15 minutes we will be having this breakfast session, and we will be back with our next session. With that.
Breakfast is organized at the ground floor. ये पॉइंटर चलेगा, ये कैसे चलेगा?
कैसे क्योंकि ये मुझे बड़ी वार्निंग हुई कि तुम लोगों को कभी कॉन्फ्रेंस करने नहीं आती थी, पहले क्यों नहीं लगे हुए थे ये चेयरपर्सन कहाँ बैठे? अच्छा, यहाँ बड़ा दिक्कत है कि स्पीकर यहाँ देखें ऑडियंस को या यहाँ देखें, यहाँ एक लैपटॉप होना
Now we would proceed for the next session, that is management of CKD in 2026. Can we prevent end-stage renal disease, need for dialysis, kidney transplant? Now I would like to invite Dr. Sumit sir to welcome all our chairpersons. Dr. Prashant Bendre sir, consultant nephrologist and head of department at Jaswant Rai Hospital, Meerut, as our chairperson. Dr. S.P. Sondi sir, guest faculty, Department of Medicine, Subharti Medical College, Meerut. Dr. Bhumadya Jain sir, SR1 DRDNB Nephrology, Artemis Hospital, Gurgaon. Dr. Richa ma'am, HOD Medicine Department, SIMS Hapur. And now, our speaker for the session, Dr. Vijay Kher sir, Chairman, Division of Nephrology and Transplant Medicine, Epitome Kidney and Urology Institute, New Delhi. He has established academic and clinical department of nephrology at Sher-e-Kashmir Institute of Medical Sciences in Srinagar, SGPGI Lucknow, Apollo Hospitals, New Delhi, Fortis Group of Hospitals, NCR Delhi, Medanta, New Delhi, and during his last 40 years. He has also served as past president of Indian Society of Nephrology. He has been awarded fellowships of National Academy of Medicine Sciences, India, Royal Colleges of Physicians, Edinburgh and Indian Society of Nephrology, and orations of various scientific societies.
Should we go ahead? Good afternoon, good morning, ladies and gentlemen. It's such a pleasure to be back in Meerut and in this mega institute. I'm so impressed. I just entered the gates and it looks very, very impressive. And I feel very glad and must thank Dr. Sondi for giving me this opportunity to come back to Meerut. And I've been here many, many times, many years back. It's been a long time now that I'm here. And I'm glad that, can I move these slides from here? So you can point it there. Okay. Well, Dr. Sondi had given me to talk about the renal auto regulation, and that is what may have come. But I thought that renal auto regulation, I wasn't very sure what would be the kind of audience that I would have. So I thought that this would be something which probably will interest everybody in the audience. These are my disclosures. 850 million people across the world have some form of chronic kidney disease. And in India, there are at least 138 million people with chronic kidney disease in this country. So there is an epidemic of chronic kidney disease. In 2015, chronic kidney disease was the 8th commonest cause of death in India. And in 2040, it is going to be the 5th most common cause of death in India. So how do we define chronic kidney disease? It's important to understand what we are talking about. It is any structural or biochemical or functional abnormality of the kidney which lasts for more than 3 months. It could be a small kidney and then that will be chronic kidney disease forever because he's born with a small kidney. Or chemical factors like proteinuria, hematuria, tumor or scars in the kidney with a GFR less than 60 ml per minute per 1.73 square meters. So you need to find out the cause, the GFR category, because you can calculate the GFR. We estimate GFR by serum creatinine usually, and you have an estimate calculator. Each one of you would have a calculator in your phone itself, and you can calculate the eGFR. These days, fortunately, biochemical laboratories also are giving you the eGFR. And then you can also look for albuminuria, because these two components, looking at GFR and albuminuria, become extremely important. What are the common causes? We talked about the causes. Causes of Chronic kidney disease, many studies from India. The last one is the National Registry. Diabetic kidney disease is the number one common cause. If you look at the earlier studies in 80s and 90s, our studies as well, but these were glomerulonephritis and diabetes were almost equal at that point of time. Now, diabetes has taken over as the number one reason for chronic kidney disease in this country. Small degrees of chronic kidney disease, many people feel the end result is development of chronic kidney disease and need for dialysis or transplantation. Now, what many people with chronic kidney disease, especially with diabetes, will never reach that stage. They will die many times before with cardiovascular disease, before they develop end-stage kidney disease. And the reason for that is that even small decrements of GFR are associated with higher incidences of cardiovascular mortality. Small decrease. Look at 60 to 75 to 105. Same sort of one mortality, but even slight decrement. 60 ml of GFR, the mortality is increased 1.5 times. Now, at 60 ml GFR, the serum creatinine may be within the normal range. So that's the fallacy of serum creatinine. So serum creatinine, if you don't convert it into an eGFR, you will get a false image of that you have. So cardiovascular mortality is increased many-fold in patients of chronic kidney disease. So a kidney disease is almost an equivalent to having a myocardial infarction, which Dr. Rajiv was talking about earlier. Even small increases of proteinuria or albuminuria. Albuminuria is a cardiovascular risk factor for cardiovascular mortality and cardiovascular disease. So small increments, look at up to 30 milligrams per gram is considered to be normal albuminuria. But even within that, you can see that 5 is better than 10, 10 is better than 30. So even small increments within the normal ranges of albumin is associated with, and increasing albuminuria is associated with mortality. So small increments in proteinuria increase mortality substantially. And these heat maps, you can tell you that GFR on the y-axis and albumin excretion rates in the x-axis. So increasing albuminuria and decreasing GFR from 105 to 15, less than 15, you can see. And the green is low risk, the yellow is moderate risk, orange is high risk, and reds are all high, very, very high risk. And you can see that increases in albuminuria and decrease in cardiovascular mortality for kidney failure and renal replacement therapy, heart failure, as well as for hospitalization and overall mortality. So albumin excretion and decrease in GFR are independent risk factors for all these factors. So it's extremely important to catch hold of these patients early. The reason why 2026 is very different from 2020 is that there are many drugs which have become available very, very recently. And we can change patients who are at high risk in comparison to those who are at, convert them to a lower risk, or maybe bring them even to a normal level. And I'll tell you that in 2026, there is a possibility of bringing people to a level that is almost like a normal person. See, this is what I was talking about, that out of 10 people, especially older adults with CKD, they have much higher chances of dying of cardiovascular mortality before they reach end-stage kidney disease. So many diabetic patients, especially with chronic kidney disease, even though the fear may be that they will need dialysis, but they will die before that. And we need to prevent this death in these patients. So that's important. How would you pick up these patients of chronic kidney disease early? So who are the patients at high risk of development of chronic kidney disease? Patients who are elderly, obese, who smoke, who have diabetes. I told you diabetes is number one. So somebody with obese and diabetic, family history of diabetic kidney disease, somebody in the family who has had a patient who's had diabetic kidney disease, has died of diabetic kidney disease, a young fellow now, a son or a daughter has got pre-diabetes or diabetes, that is the patient who is at a very high risk. And diabetes and hypertension, which are two common causes of chronic kidney disease, take many years to develop chronic kidney disease. Development of chronic kidney disease doesn't happen on day one. So there is usually 10 years for diabetes. So there is time period for both physicians as well as for the patient. So if you identify high-risk people, you can intervene in them early, make a diagnosis early, do albuminuria, and do an estimated GFR from serum creatinine. Simple test, not very difficult. And people with high risk factors, those who smoke, family history, obesity, cardiovascular disease, hypertension, diabetes, and dyslipidemia. These are risk factors for development of chronic kidney disease. So identify these people, intervene early in these people. Who are people? One is that you have identified the people. Now, who are people who are likely to progress very, very rapidly? So you need to also identify those people, people who have uncontrolled diabetes and uncontrolled hypertension. People, the cause of glomerulonephritis, like certain glomerulonephritis may be very, very rapidly, like crescentic glomerulonephritis, will very rapidly develop end-stage kidney disease. Diabetic kidney disease is far more rapid in comparison to a chronic membranous nephropathy also. So cause of the chronic kidney disease is also important to determine, is this patient going to progress very rapidly? Interstitial disease, very slow. Hypertension, also moderate slow. Autosomal dominant polycystic kidney, again, a slower kind of a course in comparison to diabetes. Obviously, elderly people, women, men much more rapidly than women, and race and blacks, especially with severe hypertension, are not going to do that well. Those who have uncontrolled blood sugar, uncontrolled blood pressure, those who smoke, who are obese, these are people who are likely to progress. So what are the general methods of principles of sort of managing these patients? Is to identify people early. That is one. And how do you identify them early? Again, I'm going to repeat. Just do albumin urine and quantify albuminuria. Albumin creatinine ratio is an important marker. And these days we have drugs which can reduce the severity of albuminuria. And reducing the person from overt albuminuria to microalbuminuria is going to reduce the mortality in these patients. So it's very difficult to, it is very important to quantify albumin. So doing a urine albumin creatinine ratio rather than doing a 24-hour urine protein excretion or an albumin excretion, you might be very easily doing these tests. This can be done very, very quickly, and these are very useful tests to be done. So what you do is stop smoking if you are a smoker, lose weight, extremely important. But these days we have drugs also. There is huge interest now in these weight-losing drugs which have become available, and so they may be useful also for many patients of chronic kidney disease. Diabetes control needs to be done. Dyslipidemia needs to be controlled. Exercise, Dr. Rajiv was talking about exercise preventing heart disease. We're talking of exercise trying to help other diseases. See, these are drugs. These days, diseases are mostly multi-organ involvement, diabetes, obesity, and you have cardiovascular disease and diabetes and kidney disease and strokes living together. All these are inhibiting the person very, very closely to each other. In chronic kidney disease, one thing I would like to talk about diet is protein restriction should not be done in Indian patients. Protein restriction produces severe malnutrition, and people die of malnutrition in this country than of chronic kidney disease. And I think it's very important as physicians, milk and dal should not be stopped in patients. Vegetarian people, these are the only sources of protein. So if you reduce or stop these, then these patients become severely malnourished. So avoid ongoing exposure to toxins. So blood pressure control, what should be the target? Usually less than 130/80. Reduce severity of albuminuria. What are the drugs which you are using? ACE, ARBs, which we were having for last 20 years. We didn't have any other drugs. But over the last decade or so now, 3 group of drugs have evolved which have been found to be very effective. we used to consider ourselves as not as lucky as the cardiologists, because every few years cardiologists and oncology would get new drugs. And we always looked at ACE and ARBs, and for 20 years we didn't have any drug to use for improved outcomes in patients of chronic kidney disease. So we used to always look with a lot of envy and jealousy as well, I must say, Dr. Rajiv. So now, over the last 2 decades, last decade or so, we have these drugs which have come, SGLT2, non-steroidal mineralocorticoid receptor antagonists, and now GLP-1 receptor antagonists. And these drugs are useful not only for kidney disease, these drugs are also useful for heart disease, these drugs are also used for metabolic syndrome and overall obesity and other tricks also. And that's why these are, so the historical paradigm of treating chronic kidney disease before the availability of these drugs was that we slow down the rate of progression of this kidney disease. So ultimately, what would happen to a patient of chronic kidney disease, instead of developing end-stage kidney disease, say in 5 years or 10 years' time, maybe we would slow it down with ACE and ARBs. Unfortunately, ACE and ARBs were also not very drugs which were friendly to patients, because hyperkalemia prevented their optimal utilization. And physicians, once they see a patient getting hyperkalemia, they will never give that patient ACE or ARB again, because one event of hyperkalemia, patient dying, this remains as a stark reality in the mind of a physician, and he or she gets scared of using ACE and ARB. So these are not optimally utilized in things. But the current therapies would change this, and this is what I would want to see. See, you look at, for 20 years, we have had these studies which looked at ACE and ARBs in chronic kidney disease, mostly done in diabetes. And there was one study, which was the RHINE study, which was done in non-diabetic kidney disease. And you can see that it did reduce mortality as well as the severity of chronic kidney disease, but there was a significant residual risk which remained despite the optimal use of ACE and ARBs in many of these patients. So you could see that there is still some residual risk. So you need more drugs or more interventions by which you can reduce this residual risk. So what could be the holistic kind of a management of a patient of chronic kidney disease today? Obviously, RAS inhibitors decrease efferent arteriolatone hyperfiltration, endothelial dysfunction, cardiac remodeling. And now we have SGLT2 inhibitors, then we have finerenone, and we have GLP-1. So they affect hemodynamically, they reduce inflammation and fibrosis, and therefore cause decrease in the progressive kidney disease, and also regulate the metabolic regulation is brought back. Diabetes, as I said, is the commonest cause, and in patients with diabetes, there is an intraglomerular hypertension. And that's basically because there is greater expression of SGLT2 in the proximal tubules. And what happens is that, therefore, there will be greater absorption of glucose in these patients. With glucose, sodium also gets absorbed. And so what happens is that greater sodium, greater glucose, and sodium is reabsorbed. Very little sodium goes to the distal nephron at the macula densa, the MD level, and the macula densa shrinks. The connect at the juxtaglomerular process, the afferent and the efferent arteriole, you can see that the afferent arteriole will dilate, and this is what causes increase in the intraglomerular. There is hypertrophy of the glomerulus, as well as there is increased glomerular pressure. And that is the reason for increased proteinuria and progressive decline in kidney function in this. What the SGLT2 inhibitors do is that inhibition doesn't allow this SGLT to act. Glucose is not absorbed that actively. Sodium is also not absorbed that actively along with this. So there is a greater availability of sodium at the distal convoluted tubules. The macula densa and the afferent arteriole connection reverses. The afferent arteriole shrinks. The efferent arteriole dilates. The glomerular size goes down. And that brings the autoregulation. Dr. Sondi was wanting me to talk about. This is what renal autoregulation would get involved into it, that you maintain the blood pressure even when the blood pressure is falling, the GFR and the glomerular flows are all maintained, and this is done through this autoregulatory mechanism at the glomerular-tubular balance at the juxtaglomerular apparatus. And this is what would happen in these patients. And therefore, the glomerular pressure would decrease, the glomerular size goes down, and the decrease in GFR occurs in these patients. So that's the reason when you use SGLT2 inhibitors, initially there may be a slight decrease in the GFR, and the creatinine might rise, and you will see also glucose in the urine. So you must tell your patients beforehand that there will be glucose in your urine, and because of the glucose in the urine, sometimes local fungal infections, the genital fungal infections might be common. So educate your patients about this, the hygiene, genital hygiene and all that. And also tell them that your creatinine might rise slightly, then they don't get worried. Otherwise, they get immediately worried that here I had come to Dr. Bendre and Dr. Bendre gave me this drug, the creatinine went up instead of going down. So if you tell them beforehand, then they already know that this is what it is. So these are the tubular-glomerular feedback restoration in SGLT2 and downstream effects. All group of drugs, Empareg was the first one which showed that was not a kidney-related drug, it was a cardiovascular COT trial basically, and where renal effects were found to be beneficial actually, and you had cardiovascular benefits as well. So you can see that the impact of all these trials on Canvas as well as Declare all had shown protective effects. And then there were these DAPA-CKD trial as well as EMPA-CKD trial, and you had 39% relative risk reduction in primary composite renal endpoints, which was sustained increase in decline in GFR of more than 50%, ESKD, renal or cardiovascular death. And you had, if you look at whether you had, this was all individual components of the primary composite endpoints, and you can see that almost all of them show the same benefit. And this is whether you were diabetic or this was non-diabetic. This was done in both diabetics as well as in non-diabetics. And you can see that it didn't matter. Whether you had a proteinuria of less than 1,000 milligrams or more than 1,000 milligrams still didn't matter. And whether you had a GFR less than 45 or more than 45, it still didn't matter. So it was effective in all group of patients, irrespective of albuminuria, whether you were diabetic or non-diabetic. And this was a primary kidney disease trial, more than 6,000 patients, so you could see that. And you could see that age didn't matter, male or female didn't matter, race didn't matter, whether you were an Asian or a Latin American or a South American or American, it didn't matter. And whether the blood pressure was good or the blood pressure was not controlled, it did not matter. This was a drug. And that's the reason why nephrologists, cardiologists, everything, because it produced cardiovascular benefit, all-cause mortality, decrease in everything. So a very, very impressive drug. And that's why the physicians, cardiologists, nephrologists, endocrinologists got. And this drug was taken over. It was shown to be effective in heart failure, reduced heart failure, preserved heart failure. So this became an extremely useful drug. And nephrologists, for a change, also got excited to see this drug. And the safety was very, very good. And you can see that the residual effect with losartan or the ACE and ARBs, this kept on decreasing with dapagliflozin. But there still was some residual risk. That's why you needed more drugs. And this is finerenone. There is a talk on finerenone, so I might as well skip it. And it again shows that this was a composite endpoint reduction by 14%. So further reduction of 14% would occur with finerenone at this point. I'll skip these because you have a talk later. And Fidelio and Figaro trials, about 12,000 patients, large trial. Fidelity and all shows extremely good effects. You can see the reduction in and composite endpoints as well. Dr. Raji was again talking about statins, extremely useful. SHARP trial did show that it was beneficial in patients of chronic kidney disease, especially in patients who are not on dialysis. So, but those patients who are on dialysis, if they are on statins, if they go to develop end-stage kidney disease, I would continue statins in them if they are continuing them. And those who have cardiovascular disease. And as I said, the commonest cause of death in patients of chronic kidney disease is heart disease. So it's good to prevent development of they are at high risk of development of atherosclerosis and coronary artery disease. So do use them. Now the other interesting drug which came was GLP-1 receptor, the flow trial, the semaglutide and tirzepatide, which are drugs used predominantly. The interest is for obesity and reduction in weight, but these were patients who were male, female, 67 years of age, 47 ml mean GFR, mean BMI was about 32 kgs, hemoglobin A1C 7.8, 57% diabetic, and blood pressures in this. So what did it show? Again, 24% overall kidney composite endpoints were reduced. So effective. These were patients who were with type 2 diabetes and patients of chronic kidney disease. So look at, then there were subgroup analysis also showed that the effect on the kidney was not related to weight reduction at all. So irrespective of the weight. And this is, the kidney components were contributed by, you can see, by onset of persistent reduction of GFR, initiation of chronic kidney disease, death from kidney disease and all. And you can see 22% semaglutide. This is select trial in people who had a mean BMI of more than 27 kilograms per meter square, cardiovascular disease, but not diabetic. These were non-diabetic, without diabetes. And you can see that 22% effect. So this is a drug which is likely to be effective even in non-diabetic people. Look at now select trial again without diabetes. You can see that the effects were very, very similar in patients with diabetes. There was a SMART trial in patients of chronic kidney disease and BMI more than 27, non-diabetic. Reduction in proteinuria. Flow trial as well as SMART trial. This is in patients with chronic kidney disease, similar kind of reduction in patients who are not diabetic also. And Remodel is a trial, which I'm not going to show you the data on here, is looking at the mechanisms by which semaglutide might produce benefit in patients of chronic kidney disease. They are doing MRI and biopsies and other proteomics and metabolomics studies and all. So the effects are predominantly related to natriuresis, hemodynamic effects, endothelial function recovery, anti-inflammatory actions, and also inhibition of RAS. Indirect effects are that there is better glycemic control, reduction in blood pressure, and reduction in weight. So what we are talking about in 2026 is that annual decrease in GFR in patients with, say, diabetic kidney disease is about 5 ml per minute per 1.73 meters square per year. So annual decrease is about 5 years. Can we decrease it to 1 ml? Normal reduction in GFR with age, physiological reduction in age is 1 ml. After the age of 40 years, you will have a reduction of 1 ml per minute per year. So an 80-year-old man will have a GFR of 50. So many times 80-year-old men come that because these days labs give them, so they are labeled as CKD3. In fact, they are not CKD. If they have no albuminuria, there is no CKD. It's a physiological reduction of. So our aim is, can we currently use these drugs effectively so that, and this is exactly what the residual risk calculations have been done, and you have these drugs, and you can see that, I can't show you, this pointer is not working, but look at the pink one at the top, which is RAS inhibitor, GLP-1 receptor, and the SGLT2 receptors. Look at the reduction on GFR. 2025 reduction of GFR is almost nearing that 1 ml. So ladies and gentlemen, can we prevent development of SGLT2 inhibitor or not? So let me, can we go to next slide? Got stuck? Yeah. So these days, now if we use all the RAS blockade, SGLT2, finerenone, and semaglutide, these are the 4 pillars of treatment of patients of chronic kidney disease. So So the new paradigm would be to reduce the GFR, annual reduction to almost 1 ml. And that is possible, as I showed you in the slides. So if we have a 50-year-old person with a GFR of 50 ml, 1.73 meters squares, now with 1 ml minimal decline, you will go to 20 ml at age 80. So 80 would be an average kind of a lifespan that a person will have, and he will not require dialysis at 20 ml of GFR, isn't it? So it is possible these days to have this 50-year-old man. The only thing that you have to do is to catch hold of this man at a very early stages of kidney disease, in the sense that do albuminuria and do GFR. Just these two things that you need to do and intervene early, and you will be able to get this patient without the need for dialysis. So can we prevent ESRD or need for dialysis or need for kidney transplantation in 2026? So ladies and gentlemen, I may have convinced you that with early diagnosis and effective intervention and regular follow-up of these patients, you should be able to probably prevent development of ESKD as of 26-27. Thank you very much. I'll be glad to take any questions.
Thank you, Dr. Kher. As usual, you are the masterclass speaker and you have made the subjects look so simple that I thought I knew everything about it. Anyway, you talked about screening of the high-risk population, high-risk patients, to prevent the ESRD or to prevent the CKD. Now, similarly, like a 10 years heart attack risk or a SHAD score in atrial fibrillation, do you have any scoring system yet? Quantification by which we can score the patients and plan our strategy in the aggressiveness?
There is a kidney risk assessment score, and that's been done. That what is, if you have a patient coming at a particular age and you fill in these different items into a scoring system. So there is what is the 5-year and a 10-year risk of or percentage of development of end-stage kidney disease. So there is a risk scoring system that you can do, and this is available on the net itself. So KFRE, Kidney Function Risk Estimate tool. So this is KFRE tool is available. You can do the calculation at your clinic itself, and you can calculate that what is the 5. It's like cardiovascular risk score, that at 5 years, what are the chances that this patient is going to have, and how much is the risk? Is he at high risk or is he at a low risk of development? So those can be done very easily in this patient. That one is that. But as I said, that if you have these patients, which I told you at high risk, do look for them, ask them to come regularly for checkup and follow-up, and you should be able to intervene in these patients. Use these drugs effectively. Fortunately, the cost of GLP-1, wait for March and you will see that the cost of GLP-1 is going to go down significantly, and you have India is the country where you have these cost reduction of drugs by biosimilars and similar drugs. So it's going to be a good field for patients and physicians.
So I have a question. So like you said, if there's albuminuria, we have multiple drugs which we can use for CKD. But if there's a patient with structural CKD, like one small kidney, other kidney is okay, normal side, normal congenicity, and we have ectopic kidneys, bilateral or unilateral, but there is no albuminuria. In those patients, what drugs are effective, like ACE, Nationl, and DEPA, and what are effective drugs?
So I think you will have to look at what is just structural abnormality does not necessarily mean that that patient is going to progress. There may be one person with one small kidney, the other kidney may be perfectly all right. These patients might live normally. Increasing albuminuria is an independent risk factor for progression as well as for cardiovascular mortality. So if there is little or no albuminuria, then you can be rest assured that this patient is going to live normally, fairly normally, not going to be at a high risk for development of chronic kidney disease. Albuminuria is an important factor which must be done in many patients of chronic kidney disease. And these days you can intervene. That's important. Yes, yes, why not? You have chairperson's prerogative.
Doctor, I was discussing it with Dr. Bendre when you were talking, that when we use GLP-1 for a nearly normal weight CKD patient, does he lose a lot of weight? I have no idea what happens in clinical trials. Say BMI 25. Does he become very thin? Does he lose all the muscles? And what are the side effects? I mean, that's what we were discussing.
It doesn't. It obviously, this is with every trial. Those who have the highest proteinuria are the ones who will respond the best. In SGLT2, same happened in finerenone, and same happens in GLP. Those who have very high weights or are very, very obese, they are the ones who are going to lose significant weight. Those who are may not lose that much of weight. May not lose that. And that's exactly. And reduction in weight was not correlated at all with the beneficial effect of kidney outcomes. So there were people who didn't have that much of high weight, maybe BMI of 25 or 24, and they didn't lose that much of weight. They didn't lose. Obviously, you need to advise people to take proteins and do exercise and muscle mass so that they preserve their muscle mass, because that is an adverse effect of these drugs. So you need to advise your patients. If they do well, they should be.
Thank you, sir, for that masterclass. We are feeling really blessed to hear your viewpoints on the current management of CKD. So another question which came to my mind when discussing about these GLP-1 was that there are two contradictory advices in a patient who has CKD and diabetes, is overweight, is on GLP-1. So when he's rapidly losing his muscle mass, he's being told to take excess of protein. Of course, you alluded to the fact that protein restriction is not an intervention strategy in Indian patients, but overall, looking at the literature, if the patient is overweight and if he goes along with the current scientific literature, so should he cut down his protein intake to reduce the progression of CKD or increase it to maintain his muscle mass? So that's
no, the question is predominantly that people should not reduce their protein intake. 0.6 for patients of CKD, 0.6 to 0.8 grams per kilogram body weight. That's the advice. The KDIGO gives you an advice of 0.6 to 0.8 grams per kilogram. What is the average intake of protein in India? 0.6 grams. Average Indian, you and I, take 0.6 grams per kilogram body weight. Requirement is 1 gram. We are nowhere near. So where is the question of reducing protein intake in people with kidney disease if they are taking only 0.6 grams? So recommendation is, I usually calculate 0.7 gram per kilogram body weight, or ideal body weight of a patient. If there is somebody who is obese to 120 kgs, I will not calculate for 120 kgs for his ideal body weight. So same would be for patients with, so they must get adequate proteins. So you should have adequate proteins and exercise in these patients. So that's what needs to be given to these patients. There are no studies yet which have been done yet on non-diabetic patients with kidney disease. So there are ongoing trials of finerenone as well as GLP-1 in patients with kidney disease, diabetic and non-diabetic. So you will soon hear it. But there is indirect evidence coming from many trials that finerenone as well as GLP-1 are going to be effective, even because the non-diabetic, both diabetic and non-diabetic patients with CKD also got benefit of a similar degree. But there are no direct trials. Now, trials are going on at the moment. So within a year or two, you will have evidence to show that this probably will be effective across patients like the SGLT2.
Thank you. Thank you very much, Dr. Vijay K, for coming all the way from Delhi in such a wintry morning.
And as I promised you that the renal auto regulation, we can do it for the MD class. Anytime you want me to come, I'll come.
Right. So whenever MD students are ready, Dr. Kher will come and explain you in full 1 hour the renal auto regulation and its practical implications. Yeah.
Thank you so much, Soni sir.
No,
Thank
no,
you
you
so much.
can't go
Sir,
without
it will be
a question.
pleasure.
Without a question from Dr. Rajiv.
As Dr. Kher said, that these weight loss drugs are misnomers. They should be called metabolic drugs because the vascular outcomes we are learning every day, they are independent of weight loss. And what you see with tirzepatide and dulaglutide, you have more HbA1c reduction, more weight reduction, and similar outcome benefits. So there is something more to it, which he is talking about a trial. The second about the master classes, I'll request you to do a Zoom kind of thing so that the student in other colleges can also loop in. Because these are unique opportunities where they can have an opportunity to listen to him, interact with him. So the education should be more clustered rather than a very isolated. Yeah, we can also join. So that should be the thing, that these classes should be Zoomed rather than confined to one room. Thank you very much. I am honored.
Now I would invite all our chairpersons to felicitate sir.
Thank you, sir. The next, we have a symposium on IBD, where we'll discuss the following topics: introduction and medical management of IBD, endoscopic management of IBD, imaging in IBD, and surgical management of IBD. For this, we have the following speakers: Dr. Yogesh Batra, sir, Dr. Dhruv Kant Mishra, sir, Dr. Surbhi, ma'am, Dr. Dinesh Singhal, sir. I would like to invite Dr. TVS Arya, sir, Dr. Satyarth Chaudhary, sir, Dr. Sanjay Pandey, sir, Dr. Richa, ma'am, and Dr. Anurag Vyas, sir. Our first speaker will be Dr. Yogesh Batra, sir, for the topic Introduction and Medical Management of IBD. I would request Dr. Saurabh Singhal, sir, to please felicitate our respected chairpersons. Dr. TVS Arya, sir. Dr. Sanjay Pandey, sir. Dr. Satyarth Chaudhary, sir. Dr. Anurag Vyas, sir.
Thank you, Dr. Saurabh and Team Subharti, for inviting us to this beautiful institution today. We saw about heart disease. We also heard about CKD. And as other lifestyle diseases are increasing, there are two GI diseases which have also got on the bandwagon, and NAFLD, which is part of the metabolic syndrome, and IBD. IBD is now a worldwide epidemic, and it is growing by leaps and bounds in our country also. So what is the reason of IBD? So we have heard the previous speakers talk about diet, exercise. These are very much the reasons for IBD as well. But IBD is a very strong component of nutrition as well. So as the number of junk food outlets increase in a country, the IBD incidence increases in that particular country. When I say IBD, I mean two diseases. One is ulcerative colitis, the other is Crohn's disease. Ulcerative colitis occurs in the colon and rectum, while Crohn's can occur in any part of the GI tract. Rectum is usually involved in ulcerative colitis, while in Crohn's, rectum is involved in only 10% of cases. Ulcerative colitis is more superficial. It is there only in the mucosa and submucosa. Crohn's is transmural. It involves the entire gut, and it can also extend into the peritoneum. Ulcerative colitis is a continuous pattern of injury, while Crohn's has breaks in between. Ulcerative colitis has acute onset, Crohn's has an insidious onset. This is what ulcerative colitis looks like. So you can have proctitis or proctosigmoiditis in 40 to 50%, left-sided or extensive colitis in 30 to 40%, while pancolitis in 20%. In Crohn's, you can have ileocecal disease in 40%. You can have multiple skip lesions in the small bowel in 30 to 40%. You can have Crohn's in the colon or Crohn's colitis occurring as skip lesions in 20%, or you can have just perianal disease in 10%. So we have seen in a number of patients where the diagnosis was piles for years together, they underwent surgery, and eventually it turned out to be Crohn's disease once a colonoscopy was done. This is what the endoscopic appearance looks like, and the clinical feature of ulcerative colitis are rectal bleeding, frequent small volume stools, mucus discharge from the rectum, tenesmus, urgency, and rectal pain. And Crohn's disease can be inflammatory, stricturing, or penetrating. So when we talk about inflammatory disease, it can present with abdominal pain, diarrhea, malabsorption, and bleeding. Stricturing can present as bowel obstruction. Penetrating can lead to abscess or fistulae. So IBD is not just confined to the bowel. No slides. So IBD is not just confined to the bowel. A lot of extra-intestinal manifestations can be there, as are there in any immune-mediated diseases. So we can have conjunctivitis, episcleritis in the eyes. There can be mouth ulcers. So a number of our patients present with aphthous ulcers, no cause is found. Some of them actually could be IBD. Fatty liver, liver abscesses and portal pyemia, mesenteric or portal vein thrombosis, venous thrombosis, autoimmune hepatitis, arthralgia of the large joints, erythema nodosum and pyoderma gangrenosum. That picture you see on the left is actually pyoderma gangrenosum. IBD is not an innocuous disease. It can lead to severe complications. So complications can be severe colitis, perforation, hemorrhage, toxic megacolon, fistula, and it can even lead to malignancy. These are the endoscopic pictures. Dhruv would be talking about them in the next talk, so I'll just skip over them. And these are the endoscopic pictures of Crohn's disease. Capsule endoscopy is a new modality which picks up small bowel disease, and this is available with us, which is really helpful. Dr. Surabhi would be talking about the radiology of IBD. So again, I would not be talking about this. Intestinal ultrasound is something which we have developed at our center, and we are now regularly using it for IBD. Again, Dr. Surabhi would be talking about this. Coming to the treatment of IBD. So the basic management principle is that you turn off the inflammation, you normalize the labs and the growth of the patient, and once the inflammation is turned off, you have to convert this to a stable disease, which means that the patient should be off steroids and there should not be any relapse over time. So the remission has to be maintained and you have to monitor the disease for complications. So there should not be any relapse. One should monitor the therapies, one should prevent infections, and there should be cancer prevention. IBD is not something which goes away. IBD can be controlled. It cannot be cured. This has to be explained clearly to the patient. There are various IBD assessment scores. So this is the Crohn's disease activity index, which one uses for assessment of Crohn's. And for ulcerative colitis, the most popular score is the Mayo Clinic score. So these scores should be used in every patient to decide whether the disease is progressing or regressing. Coming to the treatment, these are the various classes of drugs which are available for IBD. So the good old aminosalicylates, sulfasalazine or mesalazine, immunomodulators like thiopurine, methotrexate or cyclosporine, steroids, which can be conventional steroids or budesonides, biologics, which are the current, the newest kids on the block. So infliximab, adalimumab, vedolizumab, ustekinumab, and the newest one, mirikizumab. Small molecules like tofacitinib, and the most recent one, which is upadacitinib. Nutrition has a major role to play, and other things like psychological counseling. So this is an important slide, and one has to understand that initially the concept was of a step-up approach, which meant that you started with aminosalicylates and moved over to the immunomodulators, and if those did not work, you considered biologics. If that also did not work, you considered surgery. Over a period of time, we have had research which has told us that there is a window of opportunity in treating these patients. And if we miss these window of opportunity, we end up in complications. And these complications then can be fistula, abscesses, stricture formation, and then these patients end up in surgery. Next slide, please. Excuse me. Slide बढ़ा दो भैया. So this is what I was talking about, step up versus top down. 5-ASA I've already told you about. So 5-ASA prodrugs can be sulfasalazine, balasalazide, or osalazine. It comes as mesalamine preparations like mesocol or pentasa. Both of these are available with us. It also comes as rectal suppositories, enemas, and foams. It is recommended that along with oral, we should also use enema to cover the entire colon. There can be various adverse effects with 5-ASA preparations, but none of them are very serious. Steroids we know, so I'll skip this slide. And come straight to biologics. So biologics for IBD, biologics are newer drugs which act on different pathways of the immune system, and they block these pathways and prevent further progression of inflammation. So the commonest biologic that we use are anti-TNF, and anti-TNF blocks the progression of the TNF pathway, which then prevents further inflammation, as TNF is a predominant cytokine which is responsible for the inflammatory cascade which is occurring in IBD. So the two anti-TNF drugs are adalimumab and infliximab. Infliximab is the drug which is to be used for severe disease, for fistulizing disease, and for disease with complications. The other drugs are anti-integrin, which is ustekinumab, and vedolizumab, which is anti-P19. So these are the four biologics which are available right now. Newer drugs are coming in, like mirikizumab, which is almost here, likely to be launched next month. And so biologics can be given intravenously, like infliximab, or ustekinumab, which is part intravenous. The first part is intravenous, and thereafter it is subcutaneous. Or they can be subcutaneous, like adalimumab is subcutaneous. Biologics have very little side effects. They can be allergic reactions. It is mentioned that they can be precipitation of infections, or they can be presence of lymphomas. But in real world terms, we hardly see any of these side effects. Small molecules is another set of drugs. So tofacitinib and upadacitinib, these are the two molecules, and these are the JAK1 and 3 inhibitors. They inhibit the JAK-STAT pathway. Tofacitinib is effective only for ulcerative colitis, while upadacitinib is effective both for ulcerative colitis and Crohn's disease. It is more potent than tofacitinib. The risk with small molecules is that they can cause herpes zoster, CMV, Epstein-Barr virus infection, hepatitis, anemia, thromboembolic episodes. They also can be, they can lead to malignancy. They can cause worsening of cardiovascular disease, and they can cause URI. So this is how we treat IBD. Treatment for mild IBD can be corticosteroids, which can be used for induction, and aminosalicylates for maintenance. For severe IBD, for induction, it is steroids again. It could also be biologics, or it could be immunosuppressants. For maintenance, all of these drugs can be used. Finally, if all fails, then it is surgery. Dr. Dinesh Singhal would be talking about surgery, so I have skipped that slide. So the conclusion, due to lack of awareness, IBD presents late. IBD is not IBS. IBS is something which we see commonly. All rectal bleeding is not hemorrhoids. IBD can be treated with simple medication, but one has to have a thought process that this could actually be IBD. It is easy to treat IBD before complications set in. Hence, it is important to catch the disease early and to treat it early. Thank you very much for a patient hearing. So
Regarding the recently, there was an article regarding the use of coconut water inducing the remission in ulcerative colitis.
Various dietary therapies have been shown to cause remission. Before coconut water, it was curd and curd enemas. So one really does not know whether all this is effective. We need a proper RCT. And if that shows coconut water works, then it is excellent.
Because there was an article from the AIMS, Dr. Kedia group, they have shown
Vineet
that
has worked on that, and but just one isolated article, really, I would take it with a pinch of salt. I would not recommend coconut water to the population of IBDs.
Thank you very much, Professor Yogesh Batra. I think the other questions may be taken at the end of the discussion.
Okay.
Thank you very much.
So I think Dhruv is next. Dhruv is son of the soil. He did his MD and MBBS from here only. So he would be talking about the endoscopic management of IBD.
Can we have the slides, please?
He is Dr. Dhruv Kant Mishra, alumni of Subharti Medical College, UG from Subharti Medical College, MD from Subharti Medical College, and he has done his DNB in gastro from Apollo Delhi. So I have called especially Dr. Dhruv to represent Subharti as well.
Thank you, sir. Thank you, sir, for that kind introduction. And at the offset, a big thanks to everybody for the invitation to come here. A very special moment for me today because my MBBS teachers are here, my MD teachers are here, my super specialty guide is here. Somebody who I've respected so much as a teacher, Professor Pandey sir is here. Basically, anybody who has taught me anything after school is present in this hall today. And it is a big privilege for me to be able to give this talk here. I'll be talking very briefly about the endoscopic management of IBD. This is a very rarely discussed topic, but it is coming up in a big way. We'll be discussing the role of endoscopy in IBD, the endoscopic treatment of IBD, management of the complications of IBD via endoscopy, and the newer therapies that have come up. In brief, this is what we already know. Endoscopy is usually used to confirm the IBD, the presence of IBD, the assessment of mucosal inflammation, for prognostication to predict relapse and long-term outcomes. The new things, the newer therapies that are coming up are the therapeutic role of endoscopy, such as endoscopic balloon dilatation, stricturotomy, placement of stents, for cancer surveillance and for removal of that cancer, and most importantly, post-surgical assessment, such as the Rudgate score, which tells us the status of the mucosa after a surgical resection has been performed. We have a huge number of things in our armamentarium. We have colonoscopy, capsule endoscopy, anterograde, that is through the mouth, and retrograde through the rectum, enteroscopy. Endoscopic ultrasound is coming up in a big way. And then chromoendoscopy and NBI, which is a fancy way of saying that we spray a dye on the colonic mucosa and use digital filters at the end of the colonoscope to look for changes in the vascular pattern and changes in the mucosal pattern. And last but not the least is third space endoscopy, which creates a submucosal tunnel in the wall of the gut and is used to remove polyps or dysplasias or any malignant lesions which are limited to the mucosa or submucosa. So endoscopy in IBD used to be a purely diagnostic tool, which has now evolved into a term called IIBD, interventional IBD, which has a lot of therapeutic interventions. These can be used as upfront treatment, or they can be used as a critical bridge between us waiting for the medical therapy to work and waiting for major surgery. It has evolved in a big way and very rapidly from the late 90s, where we had simple tracheobronchial stents, to the early 2000s, where we had fully covered self-expanding metallic stents and uncovered self-expanding metallic stents. Moving on to the mid-2000s, where we had EMR and ESD, that is for removal of dysplasias and for removal of malignancies, and to recent times when we have EFTR devices, that is an endoscopic full thickness resection device, which can remove the entire lesion from its mucosa, submucosa, and even below that. When we talk of management of complications of IBD, all endoscopic measures can be used here. And first and foremost is the management of strictures, because these are very common, seen more with Crohn's disease. And endoscopic intervention is now a primary alternative to surgical therapy for symptomatic strictures, short strictures, and fibrotic strictures. That is to say that inflammatory strictures should not be treated via endoscopy. The three principles are dilatation of the stricture, cutting open the stricture, and stenting across the stricture. Balloon dilatation is the most common technique. It is used for short strictures, benefit being that it can be performed in almost any GI location. It has a high technical success rate, a high clinical success rate. The only drawback being that recurrence rates are common, especially in duodenal strictures. 30% of patients who undergo a balloon dilatation will require surgery despite a balloon dilatation. But if it is successful, it can prevent surgery. And some studies have shown that it can even delay surgery by a median of 6.5 years, which is huge. This is a case that we did recently. This is an anastomotic stricture. As we can see, the suture sites at the mid-small bowel. The scope was not able to pass through the orifice. We put in a balloon, dilated the orifice, and as we can see in the last picture, the orifice opened up significantly, allowing easy passage of the scope. Next, for strictures is endoscopic stricturotomy, which basically uses an electrocautery knife to perform radial incisions in the fibrotic tissue. This is usually used for refractory strictures where balloon dilatation as a primary therapy has failed. It has a high technical but variable clinical success rate depending on the expertise of the operator. But it offers surgery-free survival rates which are very similar. Again, this is a picture of a distal ileal stricture. We can see dense fibrosis forming around the stricture site. A small incision is placed circumferentially in all the fibrotic tissue, and we can see that the stricture has opened up remarkably, allowing easy passage of the scope across. Stenting, least commonly used, we use self-expanding metallic stents. Other types are available easily, fully covered, partially covered, and lumen-opposing metallic stents, mostly used for post-surgical strictures. Common problems that we face with stents are migration of the stent, pain after stenting, and rarely perforation. Some stents also need removal after a 4-week therapy. Multiple randomized control trials have shown us that balloon dilatation is superior to stenting for a stricture resolution, which is why stenting is not currently a primary therapy for strictures, used only for very refractory strictures. Again, as we can see in the picture, on the top left, we see a large stricture at the sigmoid colon. A stent was placed across, the stent was dilated, and we can see a large gush of stool coming out, thereby relieving the patient of his obstruction. Fistulas and abscesses are now being treated endoscopically. The first method is a fistulotomy, where the fistula is drained endoscopically. It is cut open, and sometimes a clip is applied to close the fistula from the feeding end. Injection materials can also be injected endoscopically, but there is not too much literature on this, and they have not been shown to be very effective. Some people have used glues, anal plugs, and recently stem cell injections, which is adipose-derived stem cell, which has been shown in some studies to close the fistulas more rapidly. What is coming up in a big way is endoscopic ultrasound guided drainage, EUS guided drainage. This is predominantly for lesions which are inaccessible via interventional radiology. Usually because of bowel overlay, the interventional radiologist feels that they cannot go in from the outside. So EUS guided pigtail drainage becomes a viable option. The only issue with this is that it needs anatomical accessibility. The bowel has to be within 2 centimeters of the lumen, otherwise the scope cannot access the lesion. Clinical success rates are very high, similar to interventional radiology. A small 10-second video that I will play here. This is a 38-year-old female who was on her post-operative day 8. She developed pain and fever. She had undergone a left hemicolectomy, and CT showed a 9 into 7 centimeters pelvic collection. पीछे बैक वो वीडियो प्ले करना है. Can we restart the PPT? So we go in through the colon. Sorry for the quality of the video. We see a large collection next to the bladder. The needle goes in. Yes. Now we see the picture from inside the colon. This is a dilator going in through the colon into the collection. A balloon is passed over. You can see the balloon getting inflated, and a large serosanguinous exudate coming out into the colon. A plastic stent is placed from the sigmoid colon into the collection, allowing free drainage of pus and resolution of the collection. Next slide, please. And lastly, we have endoscopic closures for fistulas and for any iatrogenic injuries that might have occurred. We have specifically designed clips called over-the-scope clips, OTSC clips, which have been designed specifically for defect closure. As we can see in the picture below, the clips are very easy to use. You grasp hold of the mucosa and submucosa, you pull it towards the scope, and with a simple movement of the endoscope, you apply a large clip which can close fistulas from the feeding site easily. Similar clips can be used for gastroduodenal fistulas, and again, a large iatrogenic sigmoid colon perforation and tract, which was closed with a OTSC clip. And as we can see in the last picture, that fistula had healed completely at 6 weeks. The last in this series would be colitis-associated neoplasia. With the rise of IBD in India, we have realized that neoplastic lesions have increased significantly. Earlier, colectomy used to be the standard approach for any grade of dysplasia. But with newer methods, with endoscopic resection, we have seen that there are comparable outcomes between a simple polypectomy, which is a daycare procedure, and a proctocolectomy, which is a huge surgery for polypoidal lesions. Although after endoscopic resection, vigilant surveillance is key. The way to do it is by narrowband imaging and chromoendoscopy, which I mentioned in brief earlier. What we basically do is we look at the mucosa using a digital filter with a simple push of a button on the colonoscope. What looks like a simple erosion in the white light image on the top, when we apply NBI to that, narrowband imaging to that, we can see a very demarcated lesion with deep blue vessels and some areas of amorphous content inside, which can tell us that this is a likely pre-malignant lesion. The way to remove these lesions is very simple. As we can see in this series of images, you locate the lesion, you mark the area around it, you go into the submucosa. Submucosal dissection is performed. The lesion is removed en bloc, fixed on a slide or block, and sent for checking the R0 status, whether we have been able to remove the lesion entirely or not. In most places, this is now being done as a daycare procedure. The patient comes with a malignancy in the morning and goes home cancer-free in 6 to 8 hours. So to summarize what I said today, interventional endoscopy in IBD has evolved from a diagnostic tool into a therapeutic tool and sometimes a bridge. It is now the primary treatment modality for strictures, fistulas, and abscesses that are refractory to medical therapy but may not yet necessitate surgery. The procedures are challenging, the procedures require specialized training, and most importantly, need a multidisciplinary approach between physicians, IBD specialists, advanced endoscopists, colorectal surgeons, and radiologists. The benefit of endoscopic treatment are the organ-sparing nature of the procedures and the simultaneous documentation of mucosal healing. At the very end, for all the surgeons present in the crowd, I would like to say that in IBD, endoscopic drainage is not a competitor to surgery, as is often thought. It is simply a bridge. This bridge allows us to preserve bowel, to control sepsis, and buy time for either the medical therapy to work or for the surgeon to step in. That was it. Thank you for the patient listening.
Thank you so much, sir.
Thank you very much, Dr. Mishra.
Now I would like to call on stage Dr. Surbhi Gupta ma'am. She is a consultant radiologist at Indraprasth Apollo, Delhi.
So, very good afternoon to everyone. So, I'll be talking about the role of imaging in IBD. Can we have the slides? Okay. So we have all seen the IBD overview. So there are two basic chronic inflammatory disorders of the GI tract, the Crohn's disease and the ulcerative colitis. So imaging is definitely not comparative, but complementary to the endoscopic findings. So what is exactly the role of imaging in IBD? So it assesses your disease extent, the activity, it detects complications, it differentiates between inflammatory versus fibrotic strictures, and we'll learn why. Monitor the treatment response, and also is helpful in the post-operative surveillance. So what is the toolkit that we have? We have the barium studies, obsolete, not going to talk about it. CT and MR enterographies. Remember, not CT and MR abdomen, but CT and MR enterographies. Then we have the upcoming intestinal ultrasound and the newer modalities such as the FDG PET and of course AI and radiomics. So when I said CT enterography and not a CT abdomen, I meant that we are going to give an oral neutral contrast, mannitol or Pegleg or methyl cellulose. Why are we doing this? We have to distend our bowel. So the better the distension of the bowel, better we are able to pick up the inflammatory bowel disease. So first we have 4 to 6 hours of fasting. Then we give oral contrast, which is neutral, for a period of 45 to 60 minutes, which allows distension of the bowel, as these are hyperosmolar agents. Then after the oral phase is complete, we give the IV iodinated contrast on table and then viewer images on the workstations. So just to understand the role of CT enterography, so the first image on the right, you see there is a CT abdomen, but you cannot really make out the different bowel loops. You cannot identify the lumen, the wall. The second image down, you can see a positive contrast in the lumen. So it's all bright and white. Distension looks adequate, but you cannot make out the bowel wall enhancement because of the bright lumen. The third one up over there is your actual CT enterography done with the mannitol. So you can see the distension of the bowel. You can also see the bowel wall very clearly, which is in contrast to the lumen, which is dark. So what we have to do for IBD is a CT or MR enterography. So your requisition forms should be very clear and should mention the word enterography rather than simply writing a CT abdomen. Don't be vague about this. Then coming to the findings, we'll see them with the help of images. So this is thickening. So anything more than 3 mm is considered pathological or abnormal. So we can see a lot of thickening in the colon, the transverse, the ascending, the descending, as well as the sigmoid colon. Next, we have to see the enhancement pattern. So you can see there is thickening as well as enhancement compared to the normal bowel wall. So this is one of the features of active inflammatory process that is happening in IBD. Then you have to look for the edema aspect. So when you see a hypodense layer in the submucosa, you're looking at submucosal edema. Again, a marker of active inflammation. Then we have the Coombs sign, which are basically engorged vasa recta. So wherever the bowel is inflamed, the mesenteric vessels around it also get engorged and dilated, and they almost look like teeth of a comb. So it's called the Coombs sign or the engorged vasa recta sign. Then we have other signs such as mesenteric fat stranding. So on the right, you can see a very hazy kind of a mesentery, whereas on the left, it's all nice and black. So that's non-inflamed. A hazy mesentery is mesenteric fat stranding, again a marker for active inflammatory process. We can also look for complications on CT. So this was a case where on the right side, you can see some enhancement, some tethering of the bowel loops together. It was an enteroenteric fistula, actually between the transverse colon, ascending colon, and ileum. So all of them were basically stuck to each other, forming a fistula. You can also look at abscesses. So this was a periphery enhancing collection with septations and stranding around, another complication of IBD, which is an abscess. And then you can look for narrowings, which are basically strictures on which you have to comment whether they are active inflammatory or fibrotic strictures. So coming to the advantage of a CT enterography, obviously widely available, quick, fast, good spatial resolution. But the biggest problem that comes with CT is ionizing radiation. And IBD is something that requires follow-up imaging, is also seen in pediatric population. So we are not very happy with this ionizing radiation part of the CT enterography. So moving on to MR enterography. So the first 2 phases remain the same. We again keep the patient fasting for 6 hours. Again give mannitol, hyperosmolar, distensive lumen. And then we take various sequences of MRI, including diffusion and post-contrast gadolinium sequences. Then view the images on our workstations. So this is the normal MR enterography. We have achieved good distension. So the first one is a T1 image, just trying to show you how the mannitol looks hypo-intense when it comes to the T1 image. And on the T2 and the GRE sequences, it is bright in the lumen. So again, we'll look at the findings with the help of images. So this is basically edema. So you can see there's this rectum. This is thickened, the wall is thickened. And there's a lot of T2 hyperintensity within the wall of the rectum. So this is mural wall edema. So T2 hyperintensity is basically suggesting edema. Again, a marker for active inflammation. Then coming to this picture. So if you see the right lower abdomen, we can see the terminal ileum. It is all thickened, it's inflamed, the mucosa is enhancing, and there is a lot of stranding, and obviously the Coombs sign positive in this case. So this was active terminal ileitis. Another important sequence in MRI is diffusion. So if you see diffusion restriction, so you can see this bright line and then it comes, drops on signal on the ADC. So diffusion restriction means that the disease is active. If you don't see diffusion restriction, looking at a fibrotic stricture or a fibrotic disease. Then you can have similar, complications such as enteroenteric fistula. This was between the terminal ileum and the sigmoid colon. And you can see a lot of enhancement on the third image. So this was an active inflammatory disease. So how do we differentiate fibrotic versus inflammatory? So if your diffusion restriction is almost nil, there is not much of T2 signal. It appears hypo-intense on T2, not much of contrast enhancement. And if you acquire cine loops, there is kind of a fixed, deformity or narrowing, which is not dynamic. Then you're looking at a fibrotic stricture, and this is where one of the reasons where the surgeon walks in, and medical management has pretty much no role. So advantages, definitely no radiation, excellent soft tissue contrast, you can get functional assessment, and it's very good for the perianal disease, which is always a blind area on both ultrasound as well as CT enterographies. Limitations, obviously very expensive, longer scan times, motion artifacts. And with CT and MR enterography, you notice there's a lot of advanced bowel preparation that needs to be done. So patient has to go through the whole process of drinking the mannitol, waiting for 45-60 minutes, which can be quite distressing. So what do we do about this? We come up with intestinal ultrasound. A very simple, non-invasive, real-time bedside imaging. We are using our probes, analyzing the small and the large bowel, looking at the mesentery, and it's excellent for repeat imaging. Okay. So why are we switching to ultrasound? Definitely cost-effective, very easily available, point of care in IBD, safe, and the biggest patient-friendly parameter that we have is you don't need an advanced bowel prep. Sometimes you don't even need 4 to 6 hours of fasting. So all the hassle of drinking the mannitol is not, seen in intestinal ultrasound. So how do we do it? So we have both linear and curvilinear probes, and we scan in a very systematic manner, both the large and the small bowel, and also the mesentery, and look for signs of inflammation or remission of the disease. So let's understand the normal. So if you see, this is the alternate black and white layer picture of a normal bowel. In the center, you have the lumen, followed by the mucosa, which is black, then the white submucosa, black muscularis propria, and the serosa. So just remember this normal pattern because that will help you identify the abnormal. So first we comment on the bowel wall thickness. Anything more than 3 mm is abnormal. So we take both longitudinal and cross-sectional measurements. Then we comment on the bowel flow by switching on the color Doppler signal. So there is this modified Limburg score. First one, normal, so grade 0. If there is thickness without flow, it is grade 1. If you see circular flows, but they are confined within the bowel wall, it's grade 2. Longer linear stretches still confined to the bowel wall is 3. And if they extend into the mesentery or bleed into the mesentery, it's a grade 4. So this is what you comment on the vascularity. Then you have to look at the stratification. So remember the normal. So wherever I put stars, you can't see the normal layered pattern. So there is break of the bowel wall stratification, suggesting a transmural disease. Then you also comment on inflammation of the mesentery. You also comment on the presence and absence of mesenteric lymph nodes, which are markers for inflammation. And you also comment on colonic hostrations. More severe the disease, there is loss of colonic hostrations. You can also look at fistulas, abscesses, and strictures, all of these which are complications of IBD. So let's see with the help of few cases. So this was the case I showed on the CT enterography. So the final report was given as active pancolitis. So we went ahead, did an ultrasound, intestinal ultrasound, blinded fashion. We can see the thickening, switching on the color, lots of color, bleeding into the mesentery. So again, the diagnosis was active pancolitis. But mind you, this was without radiation and without mannitol. And this was the endoscopic pictures. Again, MRI. So we saw this case earlier also. This was terminal ileitis. We can see the diffusion restriction. We did an ultrasound of this patient as well. So we can find the thickening of the ileum. We can see about, the color flow signal. So this was active terminal ileitis. So IUS is giving you the same information similar to CT and MR without, saving on the cost, saving all the advanced bowel prep that comes with CT and MR enterographies. Then this one is a case specifying the role of follow-up ultrasound. So you can see thickening, you can see the abscess sitting there. So we did an initial ultrasound. We could pick up the thickening. There was active inflammation as evidenced by the color flow. We can see the abscess, which was about 50 cc. After 3 weeks, instead of going ahead with a CT scan, we went ahead with an ultrasound. The thickness has come down to less than 3 mm, so normal, no color flow. The abscess is almost 7 cc. So all the information that the clinician required, we gave it on ultrasound and we saved the CT for the patient. So cost effective, no radiation, no advanced bowel prep. So what's the flip side? Everything cannot be, nice and good with IUS. So a lot of the times it depends on body habitus. It is definitely operator dependent, has a learning curve, and it is always a blind spot to image the duodenum and the rectum. And in my personal practice, I feel that it is very difficult to pick up the skip segments of small bowel, which you can commonly see in the Crohn's disease. Advancements, elastography, contrast enhanced ultrasound, I kind of do not advocate it. Let's keep it simple. Let's keep it bedside, point of care. Keep it the way it is. Role of FDG PET MRI. So it's combining both the metabolic as well as the superior soft tissue contrast of MRI. So anywhere when there is active inflammation, there will be uptake on the FDG. Okay, so it's not very cost effective, but it can pick up very early stages of inflammation. So people are going in for this, but it's a newer modality. And of course, AI and radiomics cannot be skipped in today's world. Lots of algorithms are in place. We are not using ones currently at our institution, but definitely it will pick up more what a conventional imaging picks up. So this is an area which is upcoming. So this is one of the articles that I read. Clearly, summarizes the role of each of the modalities that I have discussed. So you can go back and read for more information. And in the end, I feel it's clinician and radiologists coming together to treat IBD. And I'm happy to say that in our institute, the gastroenterologist always comes down and discusses with the radiologist what's happening and then only plans the further treatment strategies. Thank you.
Thank you, Dr. Surbhi, for an elaborate discussion and lot many things we have learned from your talk. Thank you very much.
Thank you so much, ma'am. Next on stage, I would like to invite Dr. Dinesh Singhal, sir, for the surgical management of IBD.
Good morning, friends. While they put up the presentation, let me tell you that it's a very happy moment for me to be coming back to Subharti. You may ask how. My son Siddharth did his MS from Subharti from 2016 to 2019. I have had very positive interactions with Dr. Atul Krishna, Dr. Krishnamurthy, and he was a particular fan of Dr. Sanjay Pandey here. And he spoke very highly of his surgical skills. And happy to inform you that Siddharth has shortly, just last week, completed his MCH in surgical oncology. And he's now joining the liver transplant and HPB surgery team at Amrita. And I've also noticed in the program that mine is probably the only surgical lecture supposedly in this Medicon. So I will keep it very brief and to the point and hopefully finish within the time. कौन सा वाले बटन से आगे जाएगा? अच्छा. So, inflammatory bowel disease, we know Crohn's disease and ulcerative colitis. Won't be going into the details of indeterminate colitis. So first, very briefly about the surgery for Crohn's disease. So traditional indications for surgery for Crohn's disease have been refractory or intolerant to medical therapy, symptomatic localized fibrostenotic disease, and complications such as fistulation. So this picture I have taken from Mango of 1990, which was gifted to me by my cousin. He was a professor of surgery at MAMC at that time, and I was doing my MS surgery. And this book I have preserved till date in a very good condition. And this is a picture from that book of 1990. On the left, you see a child, 16 years old, with Crohn's disease, and he's so emaciated. The surgery in him was delayed, and look at the picture 6 months later when he had surgical correction of his bowel. So my first message to you is that in the present era, no patient with IBD should have to undergo such a fulminant course of his disease that we take him from the extreme left picture to the right picture. So we have to manage the disease well enough, and nobody should suffer this fate. Now, if we delay the surgical intervention for Crohn's disease, what would happen? This is a paper that has the spectrum from surgical management from the 1990s to 2000. And then they presented that patients with perforating disease are more likely to require preoperative total parenteral nutrition, need another resection, need ileostomy, hospital stay would be longer, and they are less likely to undertake a laparoscopic procedure. So fistulation will always occur when the disease is delayed. How the disease will progress is that first it will be a stenotic lesion, then it would be a complete occlusion. Once a complete occlusion occurs, fistulation will occur most likely to a sigmoid colon, and that is what should not be done in such patients. So now, indications for surgery, we have talked about the traditional indications for surgery. Now we are moving towards predominantly active inflammation without obstruction. My medical colleagues will not agree with this. It is a controversial thing, but as always, when surgery comes in, the medical treatment ends. So I would present some studies that are supporting this contention that we are now moving towards treating the Crohn's disease surgically without obstruction in the presence of active inflammation only. Briefly, this is the so-called famous LYRIC trial that came in the Lancet Gastroenterology and Hepatology, and this is transforming the management of Crohn's disease currently. So laparoscopic resection in patients with limited, that defined as disease of terminal ileum less than 40 centimeters, non-stricturing, ileocecal Crohn's disease in whom conventional therapy has failed. Conventional therapy here means steroid therapy. The surgery could be considered as a reasonable alternative to the infliximab therapy. This was the first randomized trial that happened, and the results were published in 2017. Now see how the trial has progressed. In 2019, the same group from Amsterdam, they published their cost-effective analysis, and they reported that laparoscopic ileocecal resection is a cost-effective treatment option for ileocecal Crohn's disease as compared to infliximab. The late results of LYRIC trial, the same group published in 2020, and now they have changed the conclusion that findings further support laparoscopic ileocecal resection as a viable treatment option in Crohn's disease with limited, that is less than 40 centimeters, and predominantly inflammatory terminal ileitis in whom conventional disease treatment was not successful. We move further. A Markovian analysis was done, and Markovian analysis presented that early surgery not only was cost effective, but it was associated with better quality associated life years. So further on, a landmark article was published now in the Gastroenterology Journal, and this presented the Danish data, and you can see that the complication rates in the surgically treated group were 33% lower than the medically managed group, and as well as 50% of the surgically treated group did not receive any further treatment. So the article concluded that these data suggest that ICR, that is ileocolic resection, may have a role as first-line therapy in Crohn's disease management and challenge the current paradigm of reserving surgery for complicated Crohn's disease, refractory or intolerant to medications. So this is where we are, the paradigm slowly is shifting. So I would skip the surgical video. We presented this at the International Surgical Week in Vienna in 2020-22. This was a technique of complete mesocolic resection for the Crohn's disease patient, as we would do for cancer, because it has been reported that mesentery is one of the drivers for the disease. We had a standing ovation at this conference. So would go further and go to the surgery for ulcerative colitis. So indications for surgery for ulcerative colitis: elective, acceptable decisions, chronic intractable disease, refractory to medical therapy, dysplastic or malignant change, emergency, acute severe ulcerative colitis, bleeding, perforation, or toxic megacolon. Again, I would say that in the current era, we have very little excuse of patients landing with an emergency surgery for ulcerative colitis. It is best avoided, because emergency surgery for ulcerative colitis, even in the current era, would have a mortality of close to 30%. So management of severe UC would focus only on one aspect, that is early initiation of medical therapy. Yes, admittedly, steroid is used as the first line. And after 3 days of steroid therapy, Oxford index can be used to predict the need of colectomy during the same hospital admission. More than 8 stools or 3 to 8 stools per day, and 3 CRP more than 45 milligram predict 85% risk of colectomy. Second line rescue therapy, cyclosporin or infliximab. If there is no or partial response by day 5, total colectomy is indicated. Perforation or toxic megacolon is to be avoided at all costs, because that is where, if you intervene, mortality is really high. Now, surgery for ulcerative colitis, it can be 2-stage, that is elective. First is a total proctocolectomy with ileal pouch anastomosis and loop ileostomy, and second stage is ileostomy closure. We usually perform a 2-stage procedure. We do a ileostomy, and 3-stage, it will be done when you are doing an elective surgery in a patient who is on high doses of steroids or as emergency. So first stage would be subtotal colectomy with end ileostomy. Second would be proctectomy with IPA, and third would be that of a ileostomy closure. Surgical access can be open, laparoscopic, robotic. Laparoscopic or robotic is the preferred approach, because it maintains abdominal wall integrity. Surgical stress response is less, decreased adhesion formation, and better image. In our department with our team, now we do either laparoscopic or robotic surgery in emergency as well as elective situations. Would skip this video again. Now, what is the optimal functions outcome after IPAA? So the patient should have bowel movements of 6 plus minus 2 in 24 hours. He should be able to postpone bowel movements until a convenient time, able to distinguish between flatus and feces, and complete daytime and nighttime continence. So ileorectal anastomosis, very briefly, this is especially meant for young patients, because there is a chance of nerve injury during total proctocolectomy and sexual and urinary disturbance. So this is indicated for rectal sparing disease. Patients may have, because the rectum is preserved, may have mucus discharge, bleeding, tenesmus, or pain due to UC. Endoscopic surveillance is absolutely mandatory. Patient has to be committed for a lifetime surveillance, as there is incidence of cancer of 2% at 10 years and 18% at 30 years. Completion proctectomy may be required for dysplasia, cancer, or refractory symptoms. Coming to the closure of my presentation, management of ileocecal Crohn's disease, there is a paradigm shift from surgery for fibrostenotic disease to active inflammation without obstruction. Surgery for ileocolic Crohn's disease is minimally invasive. Crohn's disease, excellent outcomes and better quality of life. A surgical management of UC, surgery is indicated for medical refractory disease, dysplasia, or cancer. Ileal pouch anastomosis is the standard operation. It can be performed in 1, 2, or 3 stages, as well as open, robotic, or laparoscopic. We do it both robotic and laparoscopic. And ileorectal anastomosis is an alternative for select patients. Thank you, sir, for a very patient hearing.
Thank you, sir. Elaborating very nicely, I must say. And thank you for your kind words also.
No, Siddharth is a big fan of you. He always praised you to the skies.
Sir, I am elated because you have mentioned my name, Dhruv has mentioned my name, and being a teacher over here, almost 23 years, now is paying me immensely.
No, so it's well deserved.
Thank you, sir. Yes, you are absolutely correct, sir. Surgery, it's an eye-opener, I must say. Surgery in the acute inflammatory phase. Yes, definitely, it's a paradigm shift, I must say. The problem is, sir, what we observe, restorative proctocolectomy, nowadays, many people, patients, they talk of quality of life, what they are going to have, because even going 4 to 5 times for stools, they don't take it easily. That is a problem.
So I would say that in all our patients, like patients would be on long-term medical therapy, say we are talking for ulcerative colitis or Crohn's disease, they would be on long-term medical therapy, there would be exacerbations, admissions to hospital. So if you talk to the surgical patients, they would always be very happy after surgery. All the ulcerative colitis patients, yes, they do accept, and the discussion has to take place very objectively. The idea is not to reduce the frequency of stool. The idea is to reduce the medication that has been going on. So, जो भी ये medications हैं, literally दीमक की तरह शरीर को चाट जाते हैं.
Exactly. That is why
They have got a long-term consequences, and patients are very happy कि दवाई रुक गई sir. They will be willing to accept 4 to 6 tools, yes, and control is good, everything is good. So there will be periodic pouchitis that can happen. Those kind of problems will be there.
They earn their surgery, I must say. They earn their surgery. When they are fed up of all the medical treatment or complications are going on, then they ask for surgery.
So the surgical patients, usually you have a very satisfied group of patients. The paradigm shift is largely happening. What we spoke was the presence of ileocecal Crohn's disease, where one should operate quickly rather than wait for fibrostenotic disease to occur. And especially if you are doing laparoscopic work, the patient is going to go home in, say, as early as 5 days. And if 50% patients can be free of medication at the end of 5 years, then what more do you want?
I think the message is clear. Even though I'm a gastroenterologist, I must admit defeat at times. And we should be able to politely send the patients to a surgeon in time, rather than when it is too late. That's what I have learned over the last 30 years of my practice in gastroenterology. Yes, now we have got very good drugs, yet we fail sometimes. And when we fail, without wasting much time, we must surrender. That is my admission. Thank you very much.
Actually, even with the biologics also, there is a time when the patient also gets frustrated and financially drained out. And how much long you want to go? Even along with the immunomodulators, along with the biologics, you are going in the remission. But sometimes the family is fed up.
Sir, one thing we have never discussed is the cost of biologics. Dr. Yogesh can tell us better about the cost of biologics. Like I believe infliximab may not be afforded by many of our patients.
So I did not want to say anything. I was discussing with Dhruv only. उठना चाहिए या नहीं उठना चाहिए?
जरूर उठना चाहिए, symposium है.
So number one, biologics are great drugs. They are game changers. Anybody who has been on biologics, especially the current ones, which is ustekinumab and vedolizumab, will never even talk about surgery. It's out of question. There is no recommendation today which says surgery is a first line. Surgery is indicated for those who are fed up with medication, yes, or those who have a complication. Short of that, surgery is not indicated anywhere.
So, Dr.
Sir,
Yogesh,
let the
if I may
friendship between
intervene here,
surgeons
we
and
are talking of
physicians
ulcerative
continue.
colitis.
No.
Despite that, sir,
We are talking of
Sir,
ulcerative colitis.
for Crohn's surgery is, I would say, contraindicated because the risk of recurrence is extremely high in surgery.
So the literature does not say so.
So this is a 2017 study. Literature
Sir,
today
actually-
does not recommend surgery for Crohn's anywhere.
Sir, Dr. Yogesh is right. He is very well. I mean, I completely agree with you, sir. But there are certain situations. Actually, surgery is actually preserved for in case of the Crohn's disease in certain situations. Like a patient is massively bleeding, and it can be proven life-saving.
So absolutely right. So for complications, for uncontrolled disease by biologics, for complications like fistulas and abscesses where nothing else can be done, I mean, world over it is conservative management, and if you cannot improve on conservative management, then you go in for surgery.
So I would say here that laparoscopic ileocecal resection is a technically simple surgery, not associated with high risk of complications, and especially if you are doing minimally invasive, patient is going on home on day 5, and if your patient can be free of medication, 50% of them at the end of 5 years, then surgery is the treatment of choice. It is well
Very-
supported by the emerging literature on the subject.
Very true, sir, but this is a disease
I think,
which
sir, we
is...
must end with the note that
Which
we
is
are both
just
friends,
one
surgeons
point.
and physicians.
Just
And
one
when
point.
need, a surgeon should send his patient to physicians when it's not needed.
No, sir, it's
And
very
two,
simple. I mean,
sir,
it's
a
an
physician should also
immune-mediated disease,
reciprocate.
and
So
by
please shake your hands.
removing a portion of the colon, you don't decrease the immunity, number one.
I'm glad for the first time we have had a very nice and positive discussion during the
Please shake your hands. Please shake your hands.
अच्छा, the cost of... No, there's no problem. हम साथ में वापस जा रहे हैं. The cost of biologics. So the cost of biologics is coming down drastically. Adalimumab costs 4,000 per injection, and it is to be given 15 days, every 15 days. Small molecules like tofacitinib are 10 to 12 rupees a tablet. Upadacitinib is 35 rupees a tablet. Infliximab has come down from 50,000 to 17,000 for a 100 milligram vial. So again, the cost of one dose comes to about 50,000, which is to be given every 2 months. Similarly, ustekinumab is also in the same range.
But the cost of surgery is much less. If we see in the long run, it's much less. It would be. So thank you very much, both of you.
Okay.
I hope we have enjoyed this discussion quite a lot. Thank you.
We are deeply thankful to our esteemed speakers and chairpersons for their expertise and advice on IBD. Now, I would like to invite Dr. Saurabh Singhal, sir, to felicitate our respected speakers and chairperson. Dr. Yogesh Batra, sir. I would like to invite on stage Dr. Shirobi Sharma, sir. Dr. Surbhi ma'am. Dr. Dinesh Singhal, sir.
Thank you, everyone. Now we would proceed for our next session, that is Precision Medicine Plenary Lecture by Dr. S.P. Sondi, sir. I would like to invite Saurabh sir to welcome all our chairpersons, Dr. Snelata ma'am, Dr. K.C. Joshi sir, Dr. P.K. Bansal sir, and Dr. Prabhat Agarwal sir. Yes, sir.
Thank you very much, respected chairpersons, audience, and students. You know, how many students are feeling hungry? You feeling hungry? No? Oh, yes. You are kind of tuned to being in the classes for so long. I'm not. So I'm already done to do justice. Can I have the first slide, please? You give me my first slide, please. Okay, right. So this is my first slide, of course. And whenever we are going to talk about something new which is taking place in the history of medicine, we got to look back as to from where did we start. And let me take all of you to a couple of books I have. I can't. Yes. So these books are preserved in packs like this. I have two of these books, and let me open it for you. This book was written, published in 1920. So this is a handbook of medical treatment of 1920. So that means about 105-year-old, right? So let's see, where were we in 1920? This was right after the Second World War. Well, if we go into the treatment of diabetes, the only treatment of diabetes at that time, about 100 years back, 105 years back, was fasting, fasting, and more fasting. You can read that. And the only drug we have for this was opium. Opium is the drug which has maintained its reputation for best in diabetes. And if you want to give more, you can give sedatives. So this was where we were about 105 years back. So let me see another book. So this is another book which I have is around 1930, about 10 years down the line, still pretty old. And the treatment of pulmonary tuberculosis was open air and rest, artificial pneumothorax, symptomatic treatments, and nothing else. So, dear friends, we have come a long way since then. And out of the last 100 years, I have lived for at least 70 years and seen this change. Well, the change came in many medicines, but if I have to pick the top 5 medicines of the last century, I'll pick up penicillins, insulins, the first hormonal medicine in 1921, Banting Best, vaccine, which was of course discovered much earlier than this by Jenner, and then later on Salk and Sabin made polio vaccine, aspirin, which was much more than a headache medicine, and statins, of course. So we saw advent of a lot of new medicine. But dear friends, now today we are standing on the threshold of another revolution which is going to happen in medicine. Slowly it is already happening. What is this revolution? This revolution is about precision medicine in general medicine, which means one size does not fit all. Well, all of us know that each one of us is different from animals. We only have about, say, 6% different genes from dog, and how different we are from the dog. Even amongst ourselves, humans are about 99.9% genetically similar to each other. So only 0.1% difference between me and you, and all of us. And that this 0.1% difference is actually a huge difference, which is going to change the medicine. And there are a lot of evidences already there. Like the study says that how susceptible we are to flu depends on our genes. How susceptible we are to pollution and its effect on us depends on our genes, our genetic makeup. And why about 21% of us do not respond to aspirin as the others is because of our genetic variation from others. Let me take you back to this, one of the real life cases. This Anupama, of course, the name has been changed. 24-year girl was given azathioprine 50 milligram twice a day for IBD. We just talked about IBD. Luckily, I was not the person who advised azathioprine. Someone from Delhi advised the azathioprine. And the girl came back to me and saying that she has lost all her hair. She actually brought the hair in a plate and says, look at what is happening to me. This complication is known as abrupt shedding of hair from their follicles, and this is known as anagem effluvium. It was caused by the genetic predisposition in this female. She did not have enough TPMT to metabolize the drug, and so the drug level rose tremendously high. What we had to do, we had to actually check for TPMT, which are 2 ways to test genotype and enzymatic activity, which just cost today around 5,000 rupees. So we should have actually tested it before we gave it to her to prevent this complication. So why does it matter now? It matters because each one of us is made differently. Each one of us will respond to an infection or environmental assault differently. Each one of us will metabolize the medicine we are going to take differently. And so we will have different implications. So what are we going to do? Actually, there is, in the next 20 or 30 years, there is going to be a lot of talk about genomics. We already had a human genome project, which started long time back, and about 1990. We wanted to map the total genome present in a human being, and that project finished in around 2006 or something. Indian genome project has started from 2020, and we are still to finish our own project. This is still going on. This will make a lot of difference in the way we prescribe medicine. And let us take you to that. Of course, there'll be some biomarkers and other things which will come there. I talk a lot about diabetic kidney disease without proteinuria. Why? Some of us do not have proteinuria at all and directly go into decrease of AGFR. Well, it's about half of the diabetic kidney disease will be diabetic kidney disease without proteinuria. And we do not have any marker, any biomarker so far to pick a patient before his EGFR goes down below 60. When EGFR goes below 60, we say, oh, you got a diabetic kidney disease without proteinuria, though there is no protein. But how to pick this patient before? So in the years to come, for precision medicine, we will have a lot of markers. There is a lot of research going on these markers, and soon we are going to have. So biomarkers will also play a role in how precisely we tailor a medicine to a particular patient. Well, a traditional approach has been that if the patient is diabetic, all diabetics should receive metformin, this, that. And we are not making differences between each one of them because each one of them is actually genetically a different individual. And we have a broad guidelines, but these broad guidelines are not enough. So in the future, we will have precision approach. Well, there are 5 pillars of precision medicines. The most important is genomics, other are biomarkers, advanced diagnosis. Artificial intelligence is also going to make a lot of difference in it. We are already seeing artificial intelligence has made its presence in radiology and other places, but it's going to have a major presence in precision medicine as well. And targeted therapy. A lot of us who actually practice oncology are already doing targeted therapy. So it will go like this. We will have a huge amount of data collection. We'll do risk stratification and then do a targeted therapy, and then we'll do monitoring. To give you an example, like clopidogrel is a prodrug which has to be converted into an active drug, and some of us do not have this enzyme CYP2C19, and they do not respond to clopidogrel as well as others. It is almost like 20% do not respond to clopidogrel, 20% do not respond to aspirin. So the result is that we have to give both aspirin and clopidogrel in a hope that the patient will respond to either one of them. So soon we'll have markers for that. Same with warfarin, same with statin. We'll have markers that we will have to get tested before we put the patient on a particular drug. Will it be easy? No, it will not be very easy. Of course, we do genetic testing in MODI, we do phenotype recognition, and there's also how an individual person responds to a food item as far as his blood glucose is concerned. Depends on so many genes. So, if you give, say, potato to 2 persons, they will respond differently. One may have a higher rise of blood glucose than the other because you may have a different AMY gene for salivary amylase. So all these things are going to be clearer and clearer in the future. Well, when we treat hypertension, we will soon have salt sensitivity. How many of us are salt sensitive? And then those patients will be required to be very strict about salt. We will have a renin profiling and other profiling. So like today, if we advise this, from a same treatment to all the patients of hypertension, well, this is going to change. We do a lot of this in drug-resistant tuberculosis and other things. So a lot of things we are already doing. Those who work in oncology are already aware of epidermal growth factor receptor testing in lung cancer. These are the genes which control cellular proliferation, and they are, in such patients where they're EGFR positive, the cells are always on proliferation mode. And this is one of the reasons for non-small cell carcinoma patients in non-smokers. The patient was not a smoker and got a lung cancer. And some of these cancer actually EGFR positive. So once we know that, we can actually have medicines which are tuned for that. And those who treat breast cancer always, they know these receptors have to be tested. So we will see more and more of such kind. And of course, we are all aware of the BRCA genes. BRCA genes are the genes which keep the breast cancer suppressed. And we are all aware of the famous Angelina Jolie, who got a BRCA gene examined because her mother, her grandmother, her aunt, everyone had cancer. And when she tested, her BRCA1 was positive. So she had bilateral breast removal because she did not want to have a breast cancer in future, because she had, doctors told her, your chance of having breast cancer is about 87%. Your chance of having ovarian cancer is about 60%. So he got her both her breast removed prophylactically. And after 2 years, got both her ovaries removed prophylactically. And since then, a lot of people are getting their BRCA genes done. How much is that cost? I just inquired because one of my patients was asking me, the cost is around 20,000, but it is available at 7,000 rupees. So you can get a BRCA genes tested for 7,000 rupees. This is what is precision medicine. If you look at the treatment of cystic fibrosis, I mean, this is the chart, that you do all these genes testing and then decide which treatment can be given. Look at your right. It just says the white one you approve for this treatment, green one this. So this is what is going to happen very soon in future. Can you manage this? No. I think artificial intelligence will have to help you manage this, complicated system. Another thing which is going to help us in precision medicine is nanoparticle. Nanoparticle is 1 to 100 nanometers, which is almost like 1 lakh times smaller than human hair. So we are converting many medicines into nanoparticle medicines, which are more effective. To give you an example, a nano eye drop, if you use a nano eye drop, it increases the absorption by about 100 times, from 0.2% to 20%. So this is also what is going to help us in precision medicine. And of course, it's already being used to target tumors, and a lot of oncology friends are already using it. Why is AI central to all this? Because when we are going to collect a huge data, we will not be able to look at the data. And this was one question which someone asked me, that will we be competing with AI? And I answered him, I said, we have already lost it. As doctors, we have already lost it, because the only way to compete with AI was not through intelligence, not through memory, because AI will have a better memory, AI will have a better intelligence. But if you want to fight as a doctor with AI, the human touch was what was required. And we have already lost that human touch. Nobody touches the patient anymore. He just listens to the plaint and doesn't touch. So we have already kind of lost to AI in that context. So we will require a lot of AI. And I think all of us will be using AI in the next 5 years as our assistant or something. And this will be very important. AI enhanced ECG is already there. Sepsis alert, AI radiology is already there. Then wearable integration. Now, one of my patients came to me and says, I was diagnosed with atrial fibrillation. I said, why? How did you come to know? He said, no, I was wearing a ring. And that ring said your pulse is irregular. And then I went to Apollo Hospital, and then they diagnosed atrial fibrillation. So that stage has already come, that we have started wearing things which will warn us. And we are already using, continuous glucose monitors. We are already using rings. We are already using other material which is monitoring our health from day to day. and warning us that things are going on. This is what is precision medicine in preventive field. Well, of course, Japan has developed a smart toilet that analyzes your waste, your urine and stool, and warns you that you are having these issues and every day. Look at that. Japanese have somehow obsession about toilets. And if any one of you have gone to Japan, a public toilet in Japan is better than a private toilet anywhere in Europe. Anywhere in Europe. And they have a lot of things there, you know. You can play music, you can heat up, you can change the way the water comes, and then you can actually do a lot of things in a Japanese toilet. I don't know. Right. So challenges, of course, the cost will increase. Data privacy is already a challenge. I was working in a private clinic with a company as a I wanted the data of my patient and they actually blocked it a couple of times. I said, come on, this is my patient's data. This is not your data. So why are you not allowing me to totally, download my patient's data? That they had issues about it. So data privacy will be thing. They are already selling your data to medical companies. They know what are you prescribing, which brands are you prescribing, and so the other brand's medical company will come to you and say, why don't you prescribe my brand? So we talked about the genome project and everything, and I think I'll just rush through. Future of precision medicine is based on genome and gene therapies. And a lot of things has already been implemented. And even if we are a non-specialist medical practitioner, we'll be using a lot of genomes, medicine and precision medicine in the next 10 to 20 years. I think the last 30, 40 years, we were focusing outside of us. But now we'll be focusing inside each patient, because even philosophically, truth is not something outside to be discovered, it's something inside to be realized. And so to see the truth, we have to see within. Next 2 to 3 decades, we'll focus on finding out how each one of us is different from others and then applying it to provide precision medicine. Thank you.
Thank you so much, sir, for your beautiful words. It's always a treat to attend your sessions. Now, I would like to invite all our chairpersons to felicitate Sondi sir.
When we were deciding the theme of our conference, सर आप ही थे हमारी पिक्चर में कि सर सोनी सर को रख के ही एक थीम बनानी है. सर ने मुझसे पूछा ये प्रिसीजन मेडिसिन मेरे को क्या दे दिया, तुमने क्या लेक्चर दिया? मैंने कहा नहीं सर, आपको देख के ही दिया है कि आप ही बना सकते हो प्रिसीजन मेडिसिन पे कोई लेक्चर. एंड ही हैज जस्ट बिल्कुल बिल्कुल बिल्कुल. और हमने लास्ट तक टॉपिक चेंज नहीं करा सर.
Sir has deliberately delivered your talk is very nicely and it up to sir what you have done.
That the term precision is new, but we are using it from very years before. Such as in cases of the blood transfusion, we never give randomly the donor blood. We always cross-check and cross-match. This is one of the example of the precision. And we are using from many years. I think this is one of the things we are using as a precision.
According to the comorbidities the patients are having, like in case of cardio, SGLT2 inhibitors, they are given the heart failure with reduced ejection fraction patients, and GLP-1 receptor agonists in the atherosclerotic cardiovascular disease. Already we are doing in the line of this precision work.
But nowadays, nowadays the genomic is more
Right. I think what is most decisive about precision now is that how each one of us is genetically different. Which enzymes are we carrying less or more and this and that. We were doing it in the past also, but we'll do it much more frequently. And I think we'll probably require AI assistant to help us.
Thank you, sir. Our next session will be Fenrenon, a new kid in the block. For this, we'll have Dr. Sandeep Garg sir as the speaker. I would like to invite on stage Dr. Satyanand Sathi, Dr. Sathi sir, Dr. Lavi Gaur ma'am, Dr. Akash Singh sir, and Dr. Neha Jain ma'am. I would like to request Dr. Saurabh Singhal sir to felicitate our respected chairpersons. Dr. Lavi Gaur ma'am. Dr. Akash sir.
Good evening. It's been always difficult to speak before lunch. 12 बज गए. So myself, Dr. Sandeep, and I've been practicing nephrology in Meerut, Delhi NCR for last 25 years now, and we have all nephrologist colleagues over here. Respected seniors, thank you, Dr. Sondi, Dr. Saurabh Singhal. Ma'am Mukti Bhatnagar has always been a teacher to us, and I've been a regular visitor to this CME, annual CME, for last 3 years, and regular classes also. I've took some classes also. Dr. Saurabh Singhal asked me for PG students in Subharti. So since morning we have listened something about diabetes, something about kidneys, something about heart, and I'll be talking specifically on this drug, which is a new kid. And as a nephrologist, we are using it on regular basis now, especially in patients with diabetes and kidney disease. As we all know that heart and kidney are just like a married couple. And whenever we have something in heart, it ought to affect kidneys. And whenever we had something in kidneys, it ought to affect heart. And we have few beautiful drugs which have come up in last decade, like Dr. Kher has said, Dr. Previous speakers have said. Two beautiful drugs which have come up, like SGLT2 inhibitors and this Frenenon, which has changed the treatment and the response to this drug have changed the prognosis also, as far as diabetic kidney disease is concerned. So let's start. We'll be discussing something interesting regarding the unmet need which were there as far as diabetes and kidney disease is concerned. The mineralocorticoid activation, which is there in patients of diabetes and kidney disease, how to treat this mineralocorticoid activation, it is there. The relevance of Frenenon and mechanism of action in these patients. The various clinical trials, especially the trials which already been discussed, like Fidelity, Figaro, and other trials which are there with this drug. So cardiorenal protection is always important in patients who are having diabetes. Like we all know that a patient of diabetes, the
main cause of mortality and morbidity is cardiac disease or kidney disease. And cardiac disease is 2 to 3 times more common in patient with diabetes, we all know. And the patient with diabetes are associated with worsening of heart failure symptoms, quality of life is bad, and there's high rate of hospitalization in these patients because of cardiovascular disease. As far as kidney is concerned, in patient with diabetes, there is 37% more chance of getting albuminuria in these patients. And the strong association of albuminuria, as Dr. Rajiv Rogal said, the late Framingham study have proven that albuminuria is associated with LVH, and that could lead to more of CKD, heart failure, and cardiovascular mortality. The 10 times higher prevalence of kidney failure in patients with diabetes as compared to non-diabetics. So diabetes is a brunt to both in heart and kidneys. This slide tells you if a patient is having early CKD. If you can see on the right side, a woman with early CKD, the life lost in her lifespan is around 6.7 years. If she is having diabetes alone, the lifespan lost is around 11.7 years. But if that female has both diabetes and kidney disease, the lifespan loss is around 16.9 years. So whenever they both, this diabetes and kidney disease and heart disease coexist together, lifespan loss is quite huge in these patients. Now, the patient of diabetes are always at risk of losing their GFR, eGFR, and having albuminuria. And both these factors are very important while we evaluate the patient of diabetes, because either eGFR or albuminuria are not together. Together they are to be studied, and then the patient has to be prognosticated. Like if a patient is having, in the previous slide, like a patient is having albuminuria, urine albumin creatinine ratio of more than 30 milligram per gram, and he is having reduced kidney function in absence of sign and symptoms of other primary cause of kidney diseases, the risk of, well, the point is not working, but if you can see that chart, we have seen it many times. If the patient is having category G1 and G2, but he's having A3 proteinuria, the chance of getting poor prognosis and increase risk of disease is quite high. And if that patient is having G1, G2 criteria of eGFR and is having A1 albuminuria, the prognosis is not that bad. That means both eGFR as well as the albuminuria is important while we discuss patient prognosis. Now the question is, should we consider albuminuria and eGFR assessment in routine practice in all diabetic patients? Definitely yes, and this has to be done on the yearly basis. Like this slide, you can see in the lower part of the slide, a patient A with age of 69 years with creatinine of 1.3, the eGFR is around 59, and he is having stage 2, G2. So risk of progression is definitely less. But same patient with creatinine hardly 0.1 increase, 1.4 milligram per DL, his eGFR comes down to 54, and he is G3A. And the risk has increased tremendously, moderately increased. And it's same female, patient C, 69 years, female, 1.3 creatinine, similar to the patient A, the GFR is 41. So again, the risk of progression is quite high. That means that even with the shift of 0.1, the risk of progression is quite high, and it changes tremendously. So all patients of diabetes, the albuminuria as well as eGFR should be calculated on yearly basis. Now this I was talking about earlier also. If a patient is having eGFR of 62 ml and he is in the category of this G2 and green color is there, but same patient, if he is having urine albumin creatinine of just 350 milligram per gram, his risk ratio increases. He goes to that yellow one, dark yellow one thing, and the guideline recommends that one should use both eGFR and UACR properly to identify the risk and to tell the patient about the progression of disease. So as the patient of diabetes comes to you, in the preclinical stage, there's some increase in GFR, but once the incipient diabetic kidney disease starts, the GFR falls down relentlessly and the albuminuria goes up relentlessly, and the patient is having the kidney fibrosis. Now, just this slide was earlier shown by Dr. Kher also, that even small rise of UACR of 30 milligram per DL per milligram per gram and increases the cardiovascular mortality remarkably. Similarly, the all-cause mortality also increases quite high whenever the patient is having even a small rise in urine albumin creatinine ratio. So the guideline recommends that we should check the patient for EGFR as well as urine albumin creatinine ratio, and this EGFR has to be by the CKD EPI equation and not by the MDRD or the Cochran-Grove formula. So it has to be by the CKD EPI equation. Now, ADA, KDIGI on ACE guidelines all suggest that patients should undergo this EGFR and urine albumin creatinine ratio, and this UACR should be single void spot urine sample, and no need to do a 24 urine collection, and it's a cumbersome also, and some variables also. But one should always keep in mind that before giving a single void spot urine sample, one shouldn't have a fever, infection, heart failure, marked hyperglycemia, menstruation, marked hypertension. So these things has to be avoided before you give a sample for this UACR. Now, when we comes to the progression of disease, whether all the drivers of CVD and CKD are addressed, well, still we have this inflammation and fibrosis which is there in the mid. Is still was not attended till now. After the advent of this phenomenon, this thing has come up that the inflammation and the fibrosis can be taken care, and we can retard the CKD progression as well as the CVD progression in these patients. Because for hemodynamics and for the metabolic control, we have many drugs, but this fibrosis and inflammation was not addressed. So now with this drug, we can address this also. So we all know that patient has increased aldosterone, cortisol, which leads to MR overactivation. We have increased MR expression in high albuminuria, and we have increased this MR activation whenever we have oxidative stress. And this phenomenon, which is a large molecule, it causes this blockade of the MR overactivation, which leads to less of inflammation, less of fibrosis, and thereby there is decrease in kidney and heart, increase in kidney and heart protection. If you compare these two earlier aldosterone antagonist and the finerenone, the earlier aldosterone antagonists were not that specific and had, although potency was somewhat equal, but they're not selective. So because of less of selectivity, they were having not that good effect on the progression of disease. And because of this high selectivity of finerenone, it showed lesser risk of breast-related side effect. And because of short half-life and less of metabolite, there's low rate of hyperkalemia also with this drug. So hyperkalemia, which could be a complication of this drug, is very much low in this drug because of short half-life and no metabolite was associated with this drug. Now, this four pillars of diabetes management have been already talked, but since this slide was missed by Dr. Kher because of me probably, so these all drugs like RAS blockers, SGLT2 inhibitors, finerenone, and potentially GLP-1 RAs are the drugs which are being used nowadays and should be used by all physicians and physicians also, and the nephrologists also, and cardiovascular cardiologists also, because all these four drugs causes various hemodynamic perturbations, metabolic dysregulation, inflammation, fibrosis. They control all these things, and thereby the heart and kidneys can work together, and the progression is retarded in these patients. Now, we have these two trials, the RenoGastro trial and the DAPA-CKD trial. Both have shown that there is progression of diseases being decreased by these drugs, but still there was a gap, and this gap is being filled by the finerenone. Now, what is the evidence available? Now, we have a large trial among all the trials which are we talk about RenoGastro, IDNT, cadence, DAPA-CKD, EMPA-CKD. The number of patients are not that much, but in Fidelis DKD and Figaro DKD, we have around 13,000 patients. So large robust trial is there with this drug, and together with Figaro and Fidelo include sufficient number of patients to allow robust investigation, effect of finerenone on kidney and CV outcome across the spectrum of disease. So large trial is there, and it's a robust trial, and so one has to definitely believe this trial. Now, another thing is that The most of the patient, around 66.4 patients were taken up and they were having severe proteinuria. And you can see that proteinuria reduction is quite high in this patient. 40% of patients had albumin and CKD preserved kidney function. So that was a group of patients which were selected in this trial. Now, the fidelity have shown that there's composite CV endpoint, time to CV death, non-fatal MI, non-fatal stroke, hospitalization for heart failure. The relative risk reduction is on 14%, and hospitalization for heart failure was 22%. In kidney endpoints, the composite in kidney endpoint, 23% relative risk reduction for time to kidney failure, sustained more than 57% EGFR decline or kidney-related death. And dialysis was also reduced by 20%. So quite a good number of risk reduction was there whenever we use this drug. Now again, this also provide a reduced risk of first hypertension-related heart failure versus placebo. And again, the onset of heart failure was reduced by 32% whenever we use this drug. And ESC 2023 recommend class 1 indication for progression of heart failure in this patient of diabetes. Now this slide was earlier shown also, but you can see that the proteinuria reduction is around 32%, and it has been there long, for 4 years. The trial has been for 4 years, and the proteinuria reduction continued for 4 years. So definitely, and it starts very like within 3 months, and it continues for altogether 4 years. So this is another subgroup analysis of fidelity trial in which the patient was also given this SGLT2 inhibitors. And you can see in the right side, when the patient was not on SGLT2, the reduction is 31%. But when the patient were on SGLT2, the reduction is 37%. So whenever patient is getting both SGLT2 inhibitors and finerenone, the protein reduction is much higher as compared to finerenone alone. And on the right side, you can see that all the composite endpoints like kidney composite endpoints, CV composite endpoint, hypertensive heart failure, and all-cause death have shown reduction with finerenone, and the hazard ratio with the confidence interval of 95% are less than 1. Now, there's the one problem which always we think whenever we use this drug, that is hyperkalemia. But the hyperkalemia is quite low. It's hardly 0.19 millimole per liter at 4 months. So it's always very less of hyperkalemia is seen with this molecule. And another important aspect is that whenever we use this molecule along with SGLT2 inhibitor, the hyperkalemia is further low. So if you want to avoid hyperkalemia, we can add both SGLT2 inhibitors and finerenone, and the combination has less of hyperkalemia as compared to finerenone alone. Now, how to start? Now, finerenone is approved in India with same indication as of US FDA. Finerenone is indicated in adult patient with CKD associated with type 2 to reduce risk of sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure. Now, all the societies, all the guidelines have said the use of this drug, right from A, A1, 2A, 1A, 2A. So all the societies have advocated the use of this drug. And from 2021 to 2024, you can see that almost all the societies which deals about diabetes and kidney disease have advocated regarding the use of this drug. And these are the 3 pillars which we were talking about: the RAS inhibition, the NSMRA inhibition, and the SGLT2 inhibitor use. Optimize the treatment in patient of diabetes and chronic kidney disease. So they are the pillar of treatment, especially in patient of diabetes whom are prone for cardiovascular disease and kidney disease. Now coming to the dose, again very easy. If the patient is having a normal EGFR, then we can start with 20 milligram stat on the day 1. But if the patient is having less of EGFR, less than 60 ml per minute, one can start with 10 milligrams. And after the span of 3 months, there is a dose-dependent decrease in the UACR, which is seen in these patients. Now, this is a diagram which tells you when to stop finerenone whenever the patient is encountering hyperkalemia. So start with 10 milligram. The patient is having more than 5 millimole per liter of potassium. And if the patient is having less normal potassium, you can start with 20 milligram. And one has to monitor potassium at month, 1 month, 4 month, and then 4 month interval. And whenever the patient is having excessive potassium, we have to stop it, or we can reduce the dose. But if you are continuing with Frenenon, we can treat the patient with Frenenon even up to less than 15 ml GFR if the patient is not having hyperkalemia. So these are 5 takeaway with Frenenon treatment. Initiate Frenenon when the patient is having potassium of less than 5. Withhold treatment when the patient is having potassium of more than 5.5. Initiate Frenenon when the patient is having GFR of more than 25. Frenenon reduce the risk of ESKD by 1/5 and hypertensive heart failure by again 1:5 ratio. So both this trial fidelity and the Figaro has tells you about the beauty of this product, and definitely it helps in progression of the disease. So the key takeaways are the guideline recommends both eGFR as well as urine hemoglobin creatinine ratio has to be checked annually in all patients with diabetes. Early CKD management is often missed, and we should try to slow the progression of disease by using appropriate drugs. Despite RAS blockade and SGLT2 inhibition, patients are at the risk of CKD progression. The mineralocorticoid receptor overactivation, which contributes to inflammation and fibrosis, is potential treatment target to slow CKD protection. The Frenenon targets MR overactivation and slows the heart and kidney disease progression in patients with type 2 diabetes. Frenenon slows down CKD progression and prevents CV events, and was well tolerated in early and late stage CKD. In real world studies, treatment discontinuation and hyperkalemia appears to be very low. So basically, Frenenon is a new drug, and we are using it, and we should again emphasize regarding its usage because it causes a tremendous amount of benefit to the patients of diabetes. So if you want to keep your both kidney and the heart happy, the family happy, you should use this drug. Thank you. And if there are any questions, definitely we'll be discussing those.
Thank you, sir, for excellent presentation. Sir, both the trial Figaro and Fidelio, they included type 2 DM patients, and they excluded type 1 DM. My question is, can we use Frenenon in diabetic kidney disease of type 1 DM patients?
There is no trial as such regarding if we can advocate in type 1 patients, but I think there are some ongoing trials also. And once the results are out, definitely we can even be used in those patients also. But till date, there's no trial available which tells you that we can use it in type 1 also.
Sir, as you showed the staging of diabetic nephropathy, the basic, it is based on the type 1 diabetes studies.
No, you are very true. Same, the pathophysiology always same. Because when we talk, definitely we can, as a human, I can say we can use it. But there is no trial available, and there is no recommendation till date. Because we all know that kidney has 4 part, you can say, vasculature, the glomerulus, the interstitium, and the tubules. And all these are being taken care by this drug. So definitely it can be used, but there are no trial available and no recommendation till date.
Even studies are going on non-diabetic CKD.
Even in non-diabetic kidney disease, the trials are there for Frenenon, but results are not, recommendations are not there till date.
So it was a very good presentation. I have just one question. As we see, as a nephrologist, BP is very hard to control in our patients. So when we can combine ARBs with the Frenenon, then how much the incidence you see with the hyperkalemia? How often it is there?
There's always a problem. Whenever we get the patient of diabetes, we always get them late. So we are not able to use even the IRBs, and even this Frenenon is not been. So it's basically a drug which has to be started very early in patient of diabetes. So whenever you get getting a patient, so it's a drug for the physicians and the internists which are there, which are here. So whenever you get a patient of diabetes, always check them for urine albumin creatinine ratio on yearly basis. And whenever you see that urine albumin creatinine ratio is going high, so you have to start it. Because we get the patient usually with the creatinine is 2.5, 3, 4. So at that time, Finenon is probably cannot be used. But if the patient is having high albuminuria, I have tried this drug, and what I do is I try to reduce the dose of ACRB and add this drug and watch potassium. But sometimes, most of the times, what the problem is that patient gets hyperkalemia. So in advanced renal failure or moderate renal failure, it's very difficult to use. But definitely for the postgraduates, for the internists, for the physician, for diabetologist, it should be used very early because the lifespan lost because of diabetic kidney disease or diabetic heart disease is quite high. So we have to intervene early in these patients so that we don't get hyperkalemia in our patient at least.
Now we have semaglutide coming in. So now how we will sequence all these four pillars?
Semaglutide is a drug and that can be used even in, what I was thinking was that it has to be used in patient with high BMI, but Dr. Kher has just pointed out that it can be used in normal BMI also. So semaglutide is a good drug, and definitely if the fourth pillar is being discussed about, especially it reduces the inflammation, the fibrosis, the weight loss. So definitely all these four drugs, whenever you get a patient of diabetes, one should consider. I had one question for Dr. Kher, but I couldn't ask him whether these drugs should be started sequentially or they can be started. Dr. Sondi, can you have comments on this? Should we start these drugs sequentially, or we do have to start them on day one whenever we get a patient of diabetes?
Happy to use at least SGLT2 and Finenon together. I mean, there is no reason why I should wait one for the other. The only problem I face, I'm a physician, I'm not a nephrologist. The problem I face is that a lot of nephrologists in Meerut are not starting SGLT2 in time. And they say, no, and sometime when you start, of course, the EGFR goes down a little bit transiently, and then it stabilizes. So they are afraid of, that transient dip in the EGFR, which will happen with either ARBs or because they decrease the intraglomerular pressure. So I will start anytime these two together and maybe then add ARBs, because these two are almost complementary to each other. The major problem we face in all these drugs is hyperkalemia. So I don't know. Nephrologists are sitting across and they may answer.
Because in cardiology, they talk of always in sequential starting of drugs. Like cardiology, they talk of all the sequential starting of drugs. So in nephrology, I don't know.
Can I answer?
Can
Can
I
I
add a
little bit? The earliest management of CKD actually involved the usage of ACE inhibitors and ARB. So when the earliest trials regarding SGLT2 inhibitors were done, majority patients were already on ACE inhibitors and ARBs. So then they will start, the SGLT provided benefit over and above the benefit provided by the ACE inhibitors and ARBs. So when the trials, when we move to the next step, the trials regarding Finenon, that was the time when the SGLT2 inhibitors were in the phase of getting approval one by one by the FDA. So if I'm not wrong, I believe 11% patients in Figaro were already on SGLT2 inhibitors in addition to ACE inhibitors and ARBs. Likewise, when we go with the flow trial, majority patients were already on ACE inhibitors and SGLT2 inhibitors. The numbers of patients on Finerenol were a little lower, again for the same reason in the semiology of how the FDA approvals took place. So, but considering a common factor that the GFR decline, a normal rate of GFR decline, some decline is seen with all of these agents, maybe it wouldn't be prudent to start all of these drugs together. Rather, maybe start optimize the usage of RAS blockers, then maybe add SGLT2 inhibitors, maybe consider adding Finerenol, and the last would be GLP-1 RAs. And I think Dr. Sandeep
I
had
think
more idea about
probably this is the
regarding
right
practical
thing.
benefits.
We should add the drugs gradually, not on the first go. Because sometimes when the patient comes to us, just because of the pharma-driven thing which we have in mind, a patient comes to us, we start with all four drugs. So I think we should check the potassium, check the creatinine, and add them gradually. That is a better strategy, I think.
I think so. One recent article, very new, I think a year back or so, published in CJSN. And now they have defined three approaches. You go for conventional, where they took 18 months total to start all four. Then there was a rapid sequence approach. That was a fast approach. Within 3 months, they have taken on all. And there was one accelerated approach, where around 6 to 9 months they have taken to start therapy. Depending on where the patient has come, what is the proteinuria based on creatinine levels, whether it is requirement to start immediately in the gap of 2 weeks or 3 weeks, depending on the creatinine level. So I think that was a beautiful paper that we can go through.
Yeah, sure. Thank you.
Thank you, sir, for an excellent presentation on Finrenon. Your clear insights into its role in renal care were both informative as well as clinically relevant. Now, I would like to welcome Professor Dr. Mahesh Kumar Mittal, sir, Principal and Dean, Subharti Medical College. I would like to invite on stage Dr. Sumit, sir, for felicitation of Dr. Sandeep Garg, sir. Thank you, sir. Thank you, ma'am.
Next, we will proceed for the next session, that is on poisoning and envenomation induced AKI by Dr. Saif Kausar, sir. I would like to invite Saurabh, sir, for welcoming our chairpersons, Dr. Shadab Hussain, sir, Dr. Arjun Agarwal, sir, Dr. Pankaj Puri, sir, Dr. Sandhya, ma'am, and Dr. S.K. Malik, sir.
Can I start? Thank you, the organizers. A good afternoon to all of you and the audience here, and invited me for this lecture. So, this morning we have been listening about gastroenterology, chronic kidney disease in particular. So, I'll be talking something about acute kidney injury. So, this is a topic which is very much close to nephrologists, and how we can improve the quality of life of patients who present with AKI of any etiology. And the topic given to me, that is poisoning and envenomation associated AKI. This topic is very, very important for, especially for our settings like our country, tropical countries, where the poisonings and sometimes innovation like snake bites are very much common. Uh, at the outset, I would like to define the learning objectives, how to define uh, AKI, what is the epidemiology, what are the common poisons and venoms which cause AKI, what is how to approach these patients, and what about extracorporeal therapies, and what are the recent advances, and what are the future trends in diagnosing and managing patients with poisoning-related AKI. So this was 500 years when Paracelsus, you can see on the slide, he defined poisons as, that is one of the very famous quotes about poison, that all things are poisons, for there is nothing without poison's quality. It is only the dose which makes it in poison. And this holds true still 500 years later also. And on the bottom of the slides, right side, this is how your residents in forensics, how they decide what is a poison, that is the definition of poison according to toxicology medicines. And why this topic is important, because it is a major global health problem. India, because of widespread agriculture, pesticide use, and endemic snake bites, the numbers of poison-related AKI is very much high. And most of the patients, even in this part of the country, hasn't made it. I come from Aligarh, so there's very many of the patients come late to the centers with, say, snake bite or commonly like ognophosphorus or paraquat. And it has been seen that patients who can come early and they are managed well, the mortality and the mortality can be decreased even by 1/4. And the definition of acute kidney injury in poisons is also the same as in other conditions, like as KDIGO has defined it roughly 13 years back, 2012 definition holds true for poison-related AKI also. The urine output, or you can go by the serum creatinine, going by more than 0.3 milligram per deciliter from the baseline within 48 hours, or 1.5 times the baseline within 7 days. So the definition of AKI in poisoning is the same. This is a global health problem. So you can see roughly 30 million patients worldwide, and India contributes to a sizable chunk of these patients. And you can see more than 50,000 patients die because of snake bite in our country. This is very much common in our part of the country, specifically in the rainy seasons. And as you are very much aware, the residents are very much aware that the ognophosphorus poisoning, it comprises a sizable chunk, but paraquat nowadays it has come up, and it is, you can see the numbers are less, but the mortality and the morbidity, especially because of the respiratory alveolitis and the interstitial lung disease, is very much more in paraquat compared to other poisons. And in the recent studies, I've seen that it also constitutes to a sizable number of the ICU admissions. The poison, it might be drug intake, or it might be some poisons or any venoms. And this is a paper we published this year in the Indian Journal of Nephrology. This is one of the first studies from North India, which looked into last 3 years admissions, roughly 400 admissions. And you can see the AKI was seen roughly 15% patients. The most common cause was paraquat, followed by methanol poisoning. And you can see the hemodialysis requirement was close to 50%, 60%. And there was not any complete renal recovery was not seen. So you can see the numbers, 65% recovered the renal functions at the end of 3 months. And the mortality was roughly 28% in this cohort of patients. And what contributed to the mortality, you can see the late presentation to the hospital in our part also, and presented with shock. That was a major contributory factor. And most common cause of death was septic shock in our cohort of patients also. And what is the pathogenesis, how these patients land into AKIs? You can have, as in all teachings, the pre-renal, intrinsic, and the post-renal causes. You can have vasoconstriction, you can have direct damage, or you can have obstructive damage, as in patients with rhabdomyolysis. You can have formation of cast leading to obstructive stress, oxidative stress, and AKI. And this is a wonderful slide, a cartoon from Dr. Preeti Meena. So she has wonderfully elaborated how snake bites, that is snake bites, especially vipers, the vascular toxic, and the AKI has been seen to 30 to 40% patients with vascular toxic snake bite. And you see what is the mechanism. So you can all have release of proteases leading to venom-induced consumptive coagulopathy. They can present as thrombotic microangiopathy, or what you say as atypical HUS also. You can have, because of phospholized AP2, you can have patients presenting with cola-colored urine. You can have release of bradykinin and patients presenting with pre-renal hypotension, circulatory collapse, and you can also have patients with immune liver damage leading to acute interstitial nephritis. So all things are possible in this case. And this is a slide showing, but this is a biopsy slide code from Dr. Korean's group showing how the kidney biopsy looks in patients with snake bite AKI. So on the left side, you can see that is a you can have a past state side. You can have dilatation of tubules. You can the second B part. You can see what is called as acute interstitial nephritis, in which you can have increased eosinophils as well as the neutrophils. And also in the bottom half, you can see what is a pigmented cast in patients with rhabdomyolysis. We reported this patients with snake bite AKI, which we used plasmapheresis, in which the whole blood clotting time. So mind you, the whole blood clotting time is the method in vascular toxic snake bite. It should be less than 20 minutes. So if it is more than that, despite giving ASV, that is the antidote. So extracorporeal therapy does not snake bite. It is only in a very rare scenario in which you can use plasmapheresis to treat vascular toxic snake bite. So the primary management is early and timely giving of anti-snake venom. What about how VAS and B? There's also toxins who can cause AKI. So you can have AKI as tune of 50%. The commonly melatonin has been used, pathogenesis, and you can have most commonly is acute tubular necrosis. You can have also acute cortical necrosis, in which patients can present with sudden onset anuria, or rarely also patients can have acute interstitial nephritis. And the severity correlates with the sting count. The number of more stings, you can have much more AKI, and they can present with, you can use plasmapheresis or CRT in these patients. And nowadays, you can also, there's some trials or some case reports using phospholipase A2 inhibitor, that is the varosplevin, used in some case reports for VAS and B induced AKI. This was scorpion bite also, common teaching. They cause cardiotoxicity and autonomic dysfunction. So you can have local sting site. You can have systemic features of innervation like DIC, microangiopathies, and pigment-induced kidney injuries. And it has been common teaching to use prazosin in these patients who present with cardiac dysfunctions, autonomic dysfunctions, arrhythmias. And the Razi polyvalent scorpion is available in Iran, so it is not available in our country. That you have an antidote for this. And really, some case reports have used plasmapheresis for scorpion-induced snake bite. What about organophosphorus? Very, very commonly teaching for medicine residents. So the incidence of AKI is less in organophosphorus. The mechanisms, you can have diet nephrotoxicity, or you can have rhabdomyolysis. And the presentation, common teaching, you have nicotinic and muscarinic dumbbells. The mnemonics very commonly used in teachings for medicine residents. So the cornerstone of therapy is anticholinergic treatment in this early time, atropine and pyridoxine. If despite that the patient is not improving, the urine output is not well, then you can use extracorporeal therapy. But in this case, anticholinergic therapy is the treatment choice. Or cell-phos poisoning or aluminum phosphide, the generic name. So very, very common in this part of the world. The lethal dose is very less, even half a tablet. Patients presenting with ventricular fibrillation, arrhythmias, hypertension. Many of you must have seen cell-phos poisoning in your residency. Very tough to manage these patients. And gastric lavage nowadays, people using coconut oil or potassium permanganate and magnesium sulfate in the early. This might be life-saving, but it is the most having the most mortality. This poison in this part of the world, cell-phos or the aluminum phosphide, because of the phosphine gland release. And methanol poisonings very commonly because of adulterated alcohol. 40% patients can have AKI. Very commonly teaching, you can have something like patients turning suddenly blind, and you can having fundus, you get finding a Sandel's scotoma. That's very, very important. And when you do a ABG analysis, you can find high osmolar gap and high anion gap metabolic acidosis. That is very, very important to diagnose in time. And the antidote in this case is ethanol or fomepizole. And extracorporeal therapy may be used if the levels are more than 50 milligram per deciliter, or there's severe metabolic acidosis. So this case also, and you have an antidote, you can give it in time, provided you diagnose it in time. So a good history is very, very important. Salicylates, it is the aspirin prototype, the acetyl salicylic acid. So you can have classically patients can present with tinnitus. You can have mixed picture on the ABG respiratory alkalosis with high anion gap metabolic acidosis, pulmonedema, and you can use alkylation in these patients. And based on, you can see based on the serum levels, the clinical scenario, you can have different symptoms. Barbiturate, it is a sedative, hypnotic, so all the depressive signs we will say, they have respiratory depression, sedation, hypothermia. And there's a photograph showing what is known as barbiturate blisters, and your treatment is supportive. You can use multi-dose activated charcoal or immunization, or rarely you can use extracorporeal therapy, intermittent hemodialysis. Copper sulfate, blue vitriol, common teaching, especially from our part of the country where I did my post DM training. Copper sulfate is very, very important for your viva voce. Many times asked patients having blue colored vomiters. Liver is a major organ affected. You can have patients presenting with cola colored urine. That is what is when you have hemoglobinuria. And in this case, chelation with penicillamine is contraindicated when you have AKI. Hemodialysis may be tried in this scenario. And you can see the mortality is close to 1/3 of patients, even with the best of care, if you don't diagnose in time. Paraquat, this part of very, very lethal toxin. You have free radical injury, very cheaply available over the counter, and very common herbicide. You can have corrosive burns, AKI, even pancreatitis. And you can, I want to, for the residents, all the class, the don'ts are very important in this slide. So there's no role of gastric lavage, no giving, ऐसा नहीं है कोई भी patient है सबको oxygen लगा देनी है. So in this case, if you give oxygen, the free radical and the redox cycling goes up. So the alveolitis, the patients die of lung injury rather than kidney injury in this patient, even if they recover their kidney functions. So these patients, very, very important. Early hemoperfusion, if you can do it, if you have at your center within 4 hours, is life-saving. And this, how to approach a patient, the slide shows how to approach a patients who are present with poisoning, with or without AKI. So is all teachings, all our teachers, we have history taking is the most important. So many times you ask if you stress upon the patient's attendant, whether kya liya tha ya kya, most of the times they can produce that, and you can see what is the chemical composition of that. Sometimes even we have seen farmers taking out a dead or even a live snake, isne kaata tha. So you can make out the history based on that. You can have, or even a teacher's viper ke aise fangs hote hain, ya marks aise hote hain, versus you can have krath or cobra for that. That is very important to identify what is the inciting agent for AKI, as in all cases. Very important to, like in CKD for the basic disease. So it is very, very important. And all poisonings like eye signs, whether patients having meiosis, mydriasis, or organophosphasis, like on peristalsis, patients having diarrhea or increased sweating, that is very important. The mental status, you can identify whether it's a stimulant poisoning or a hypnotic identification of toxicity, and do a ECG like in patients with say sulfose poisoning. The ECG is very, very important. Patients having VT or VF, very, very important. You diagnose in time. Blood gas analysis for, especially for alcohol, ethylene glycol, and blood glucose levels for might be having hypoglycemia. You can use main poisons you are having, like in AIMS is running a toxicology screen program. You can send serum samples. They do it screen for free of cost. Some poisons, the serum sampling is levels of urine, still it is not validated for many poisons, but serum samples, some serum levels, you can monitor that, like in patients with methanol poisoning very commonly. So as in all cases with AKI, initial management starts with fluids. That is the most important thing. Many patients are having pre-renal complaints, so maintaining the MAP more than 65 is very, very important. Avoid nephrotoxic drugs, as all nephrologists very much keen to write this line in our notes. So it holds true here also. Early initiation of RRT within 24 hours has been seen to be beneficial, and use of activated charcoal not to be missed, and early administration of antidote if you are having it. So identifying the poison is very, very important rather than jumping on to right to plasmapheresis or intermittent hemodialysis or other fancy things. So these are antidotes. So you can having ogonophosphorus as all, you must be knowing it, atropine and pyridoxine. Giving it in time is very, very important. Ethylene glycol, snake venom, you're having a polyvalent anti-snake venom, and copper sulfate, you're having chelating agents which are not to be used in patients with AKI. Rather, you can see paraquat, other things, you're not having any proven antidote. Mind you, scorpion, you don't have it in India, the Razi polyvalent. So this is from Brenner Rector. So you have the corporeal treatments, you can have use even sodium polyphylline sulfonate, like the K-bind, they commonly use it, even in patients with lithium, you can, and what are the factors to decide in which you can do a urinary alkylation? Should be a weak acid, significant unchanged renal excretion, the dissociation coefficient will be low, and low protein binding, and they should be having a normal GFR. That is the precursors for deciding. So commonly we use it for salicylates and barbiturates poisoning. So this slide is one of the most important part of this lecture. So how to decide whether which patients to subject to extracorporeal therapy. So if the patient is having poisoning, is having serious mortality and morbidity risk, not having any antidote, not having any other method of elimination, and the endogenous clearance is less than 4 ml per kg. You are having a website that is an extrip that, like in ADA or AHA, the extrip TRIP, that is the body which gives guidelines and how to manage and do extracorporeal therapy in all poisons. That is the international body which you can go and you can have the poisons endogenous clearance mentioned there, and volume of distribution is less. These patients can be used for extracorporeal therapy, and based on the protein binding capacity of the poison, you can choose between hemoperfusion, plasma exchange, or intermittent hemodialysis, and the molecular weight of the toxin. That decides which therapy you use. It is not for all poisons. So dialyzable toxins, so having a small molecular weight, low protein binding, and small volume distribution. They are water soluble. So these are the dialyzable toxins. Not all toxins are dialyzable. Just because you have a facility in your center, not to subject all the patients for dialysis. This is the extra group growing guidelines for how you can do prophylactic. So despite so you can see the methanol levels. If you have more than 50, without, if you don't have fomepizole or ethanol, you can do it if the levels, serum levels are more than 50. So this is the international guidelines. You can go it, look into that, free of full papers, free, and latest it was updated up to 2023. These are non-dialyzable lists. So many times we subject patients to say phenytoin or organophosphate upfront. So for organophosphate upfront, extracorporeal therapy is not indicated. This is a slide from the Brenner and Rector kidney book. So this is the choices of extracorporeal therapy available. You can see based on the molecular weight, protein binding, and in our part of the world, cost is also very, very deterrent. So not to subject all patients to say plasmapheresis or CRT, which may be costly. Intermittent hemodialysis acts faster, available most of our centers, cheaper, corrects even the what is called as hyperkalemia and metabolic acidosis faster. So it is very important to keep, and you can see the molecular weight cutoffs for different for other extracorporeal therapies available. So what about hemoperfusion? You have just the dialysis machine, though you can change the filter. You are having a hemoperfusion filter, which is costing 10 times, roughly 10 times a hemodialysis filter. You have to change it every 4 hours. It may be used, so it works by, you are having these beads and you are having these bind high middle molecular weight and protein bound toxins, especially paraquat and phenobarbital and mushroom poisoning. But they require much more anticoagulation. Chance of this leukopenia and thrombocytopenia much more, and it does not bind alcohol or metals. And it has to be changed every 4 hours, costing 10 times more hemodialysis. So you need to be judicious while using which extracorporeal therapy in which poisoning. This is a new thing on the block. So high volume hemofiltration, as the name suggests, you use ultraviolet much more higher rates than a standard ECRT to get much more clearance. still in trials, not recommended till now. And coupled plasma filtrate absorption, in which you use this absorption with plasmapheresis, the higher molecular weight and higher protein bound. This is also in trials, and some case series and case reports have reported some benefits in some poisons. This is a Mars used in patients with acute liver failure. As a gastro summit is also there. So you use recirculating resins and charcoal. You can use the albumin part of that, and you use this for specifically for albumin-bound toxins. There's even some mushroom poisons and paraquat. You have case reports on this Mars. As the topic for us was precision medicine. So when you don't go without nanoparticles, which specifically target small molecules, you have nano scavengers. You can have binders, antidotes delivered specifically, say to the proximal tubule or the loop, and on the left-hand side, you can see using microRNAs. So these are non-coding RNAs which code for gene expression, and they are increased in patients when you're having AKI because of tubular damage. So this paper from Shiana et al. Reported as early as 2021, which found some microRNAs increasing specifically patients with snake bite and some toxin related much before KIM1 and GAL, whatever, and interleukin 6. So these are under trials. MicroRNAs, non-invasive markers. You can decide based on the microRNA levels which patients to take up for extracorporeal therapy in time and save their lives. So the prognosis, you can see mortality is close to 20 to 50%. As in our study, 60% recovered kidney function. Sizable number of patients progressed to CKD worldwide. And what are the poor prognostic factors in our part of the world? Also delayed admission, rural residence, mechanical ventilation requirement, mods, and pre-existing comorbidities, very socioeconomic factors that there is worldwide. So what about AI, which does not finish any lecture because of AI? So this is from a paper recently published in Africa, December. You can see how they are also having a resource-limited country. So what they did, they input all the poison-related data, the machine learning, subject to machine learning and natural language processing, and they identified a pattern, and they found a risk score and a prediction and the treatment sessions. You can have a central database, and you can direct at say remote centers how to manage those patients, because you don't be having nephrologists or internists at say in the remote areas. So this and on the right side you can see the use of AI. They could predict, like in this part of the country or any part in which you can identify you are having much more pockets of paraquat or organophosphorus. You can ensure the availability of the antidote, say atropine or the ASP. At that side, you can educate people how to prevent, or what are the don'ts for snake bite related. So like binding a tonic बांधना है, या उसको बहुत सारी चीजें you can in your local language you can educate the patient so they can save lines and they can come up in time to district hospital and receive ASP rather than wasting time and coming late and losing their lives just because they don't get anti-snake venom in time. So for the preventive strategies, community awareness is very, very important. It has seen to 20%, even in countries like Africa. You have a national rabies and snake bite control program also. Pesticide regulation, over-the-counter buying is very important, and counseling of caregivers, because you have what is called as suicidal, or so that is very important. These patients can turn up multiple times with different poisons. So the counseling of the patients and the caregiver is also very, very important. So the take-home message is that poison-related AKI is a prevalent but very underreported, especially. So ours was the first study for North India for poison-related AKI. So early diagnosis and management is the key, as in cases, all other cases of AKI, and extracorporeal therapy, different modalities, but is not for all. That has to be individualized, very, very important. And prevention is an integral part of the patient care, and judicious use of technology holds promise. Thank you.
Thank you so much, sir. for such a wonderful talk. Now, please.
Hello, sir. It must have been very difficult to concise such a huge topic in one presentation. Sir, my question is related to paraquat poisoning. You said we should be using the RRT renal replacement therapy when the AKI is severe. So my question is, should we wait for the AKI to get to this severe intensity, or even if the creatinine is just 1.5 or 2, we should start with RRT? And my second part of question is, what type of RRT you think we should be using if we have HD and HDF both? Because hemoperfusion is, as you said, is very costly, sir.
For the paraquat, we still don't have that much clear-cut guidelines for that, but it has been seen that if you use hemoperfusion specifically within 4 hours, the extracorporeal removal of the paraquat is much more, and the toxicity, the most important organ which it affects is the lung. It causes the type 2 alveolar cells, and it causes alveolitis, and later it causes interstitial lung disease. So even if the kidneys recover, the patients die because of, or they are having what is called as long-term oxygen therapy, LTOT, they are saying. So it is very important if you're paraquat. So if you're having a facility with hemoperfusion, to do it early if they come in time. And the recommendation is, as per the guideline, it is within 4 hours of consumption for hemoperfusion. As per hemodialysis, for high flux dialysis, you're having much more cutoff for molecular weight. So based on the poison, like in less than 10,000 or 10,000 or 50,000 daltons, you can decide on that, because the high flux dialysis are not available at many places, or they are costly. So obviously, high flux dialysis are better, but it is not for all. So you can, based on the molecular weight, if you are having it, patient can afford it, you can use high flux dialysis for them. And the indication for dialysis in cyclinographers, it has to be for, like other conditions, for refractory hyperkalemia, metabolic acidosis, and all, and not for just extracorporeal review of all poisons.
I have a question. You have shown us the various biopsy findings in case of snake poisoning that included TMA along with the interstitial nephritis. So I wanted to ask you that whether we can give plasmapheresis if indicated in any of these cases regarding to the biopsy finding, because many of the patients, or any other immunosuppression that can be given, because many of the patients, when they present to us, they are usually in oligoanuric condition. We give 1 or 2 sessions of dialysis, and after that they become non-oliguric, but they have persistent serum creatinine of 2 to 3, and they become AKD and then finally CKD. So is there any extra medication that we can add, or therapy that we can add?
For, like in our case, we reported in a case series this year only in the International Journal of Critical Illness and Injury Science for snake bite AKI, which did not respond. We gave ASV, even we 20 units ASV. In some cases, you can, some 30 units, but used it 20 units. Despite that, the whole blood clotting time, patient had a vascular toxic snake bite. Patient continued to have DIC, and the whole blood clotting time was persistently raised. And we did a general blood picture showing schistocytes, presence of thrombocytes, so microangiopathy was there. In that case, we did a plasmapheresis and we salad, but it's not for all patients. Like in patients who are having AKD or non-resolving AKI, the classical terminology teaching is that. So if the patient is not recovering his renal functions and continues to be having a serum creatinine in the range of 3, 4, even after 3 to 4 weeks, you can subject them to kidney biopsy to look what is the etiology for that, what is interstitial nephritis, or patient having a TMA for that. And then you can use based on that. But for acute interstitial nephritis, using steroids upfront, we don't have any literature or case reports using steroids to salvage patients.
In any subjected case of poisoning, what is the role of forced alkaline diuresis? Do we do it?
No, for AKI, it is not recommended forced alkaline diuresis, and in the most of the conditions when you have intermittent dialysis, so most of that is literally obsolete now. So some part of the world you can use uni-alkalization based on the commonly used for salicylates and barbiturates, but most of the conditions forced alkaline diuresis, we don't use it nowadays.
Congratulations, sir, for covering all the aspect of the poisoning and related AKI related complications. Sir, I want to ask only one question. You have mentioned that the sulfas is also a cause of AKI in patients. But usually we have seen that the sulfas patient don't survive more than 24 hours if he has taken active sulfas. Have you seen any patient who land up in the AKI and you have treated it with the hemodialysis or not?
Yes, ma'am. We reported in the Egyptian Journal of Internal Medicine in 2015 with patients presenting. Obviously, that patient, as you told, that if the patient has the exposure to the air, the phosphine if it is released in the air, and it does not before from the hydrochloric acid in the stomach. So if it reaches the lethal dose concentration, most of the patients don't survive more than 24 hours because of cardiac failure. So, but in our cases, might be the patient, the lethal dose is half a tablet. So it might be adulterated, or it might be the lethal patient must have been taking smaller. That patient had a pre-renal component, much more hypotension and pre-renal component. So that patient we salvage it, and we did a hemodialysis just for the refractory hyperkalemia and the metabolic acidosis. So hemodialysis has till date no role for removal of cell phos per se. So you can do it only for the clinical indications, as in all other cases for acute kidney injury. So only some cases you have reports for magnesium sulfate being used for membrane stabilization and nowadays even with in the southern India we have seen case reports with they are doing gastric lavage with coconut oil, and they are salvaging patients in time with cell phos poisoning or potassium permanganate. So in some case reports we have seen they have salvaged, but the literature shows that is the most lethal poison and the maximum mortality with cell phos poisoning in this part of the world and also worldwide.
Thank you, sir. Any other question?
I have a small comment to make. As far as paraquat poisoning is concerned, we have lost or we have referred many patients of paraquat because they come up with this hazy picture in their lung. So after taking paraquat 3-4 days, they develop type 1 respiratory failure, and this is very difficult to treat. Not even dialysis that doesn't help. So I usually refer these patients. So I've gone through the literature and also. So what my take on paraquat is that whenever you get a patient of paraquat, if it's late, then there's no point in treating, because ultimately you develop AKI and acute lung injury, and he won't be surviving. At that time, you can use plasmapheresis. वो भी anecdotal reports हैं, ऐसा कोई फायदा नहीं. But hemoperfusion, अगर आपका day मतलब 4 घंटे में आ रहा है patient paraquat का, then definitely I've treated. I've especially kept a filter for that. Hemofilter is hemoperfusion के लिए. So what I've used in one patient, मतलब मैं report नहीं किया, मैंने कोई literature ऐसा कुछ वो नहीं किया. But what I've seen that if you do it early, I've reused it and did 3-4 sessions on daily basis. That patient, I don't know whether he took it or not, but he survived. So what I feel is now after losing many patients, referring many patients, that in a paraquat, if a patient comes on time, do hemoperfusion, and that helps you. But plasmapheresis after getting disease doesn't help much.
Rightly said, sir. In poisoning, time is the main hero for the survivor of the patient. Okay, thank you, sir.
Thank you.
Thank you so much, sir. Now I would like to invite all our chairpersons to felicitate, sir.
For the next session, I would like to invite on stage Dr. Lavi Gaur ma'am, optimizing RRT in AKI. I would like to invite on stage Dr. Puru Tyagi sir, Dr. Vicky sir, Dr. Trehan Prashant sir, and Dr. Apur Pratap sir. I would also like to invite Dr. Saurabh Singhal sir on the stage as a chairperson.
Good afternoon, everyone. I take this opportunity to thank Dr. Saurabh Singhal, as well as Dr. Stuti Mishra, my sister from another mother, for this opportunity to attend this grand academic event. May I request now for my slides to be projected? So I would be addressing this topic, which is optimizing renal replacement therapies in acute kidney injury. Next slide, please. Okay. Okay. So I've sectioned this talk into 4 subtopics, which will be dealing with timing of initiation, the optimum modality for dialysis, what dose to be delivered using a particular modality, and the de-escalation, how to start the de-escalation process. So first, coming to the definition, I'll just flash this slide. AKI is nothing but the abrupt decline in kidney function, which has been classified into 3 stages according to the latest AKI network classification. This has a lot of drawbacks, but we are not going to delve into that territory. A wide variety of etiologies would lead to acute kidney injury. So more importantly would be to identify the underlying cause for AKI and addressing that particular cause. Then you'd start the process of renal recovery. So in cases of pre-renal and post-renal AKI, the identification of cause as well as the subsequent treatment is generally straightforward. For pre-renal AKI, you correct volume. Most of the patients would start the process of renal recovery. Likewise, for post-renal or obstructive causes, do something to address the obstruction or bypass the obstruction so that the process of renal recovery starts. There are some other causes which cause intrinsic damage to the renal parenchyma. And most of the important causes would include sepsis, drug-induced AKI, contrast-associated AKI rarely, autoimmune processes leading to glomerulonephritis. These are the patients who would more importantly and more commonly need dialysis in the setting of acute kidney injury. So why it is important to consider AKI in the current situation? It affects more than 10 million people worldwide. It complicates the stay of 20% of hospitalized patients and nearly 2/3 patients who are admitted to ICU. The implications extend to not only prolonged stay of within the ICU or hospital, but also to mortality. 40 to 50% of patients with AKI in the current era eventually die. Remaining, the people who survive an episode of AKI generally develop some sort of permanent kidney damage and stay in that category of acute kidney disease and CKD. And reduced glomerular filtration rate by itself is a predictor to develop future cardiovascular events and contributes to long-term mortality. So, what should be the timing of initiation of RRT? So, in situations, there are no-brainer indications like life-threatening hyperkalemia, metabolic acidosis, and fluid overload, in which situations you have to initiate um, some form of dialysis. So, KDIGO recommends, this is an ungraded recommendation, and for such severe life-threatening indication, there can never be a randomized trial. So, these recommendations remain ungraded. What is life threatening, what degree of hyperkalemia is life threatening, what level of pH is life threatening, what degree of fluid overload is life threatening, nobody has answer to these questions, and there can never be an evidence based answer to these questions. But what helps the clinical judgment is, if the patient is not making urine, any attempt to medically manage hyperkalemia will just lead to shift of potassium to the intracellular compartment. The body would not eventually get rid of the total potassium burden, it would just be a shift. Likewise, for metabolic acidosis, the acid load would be difficult to handle without a good kidney function. Fluid overload, if the patient has landed in AKI, more commonly than not, the patient would have obligatory fluid requirements in terms of nutrition, IV infusions. So you have to create space for that extra fluid to be infused into the patient. And this can happen only when there is RRT to take care of that extra volume. Now, these are the emergent indications for which you would need dialysis. For non-emergent indications, the evidence is what we are looking for. So the earlier observational studies, these are mainly can be called anecdotal data. They have very small sample size. So there was initially a concept of doing a prophylactic dialysis for patients who were suffering from acute kidney injury. And the anecdotal data suggested that there could be some benefit. But anecdotes do not account as evidence. So this is where the RCTs would provide the evidence. So 2016 was a good year for answering questions in that era, for this questions in this area, when we had two major trials, the Elaine and Akiki trial. So we'll look at these trials and their results one by one. So the Elaine trial came from Germany. So here they looked at starting the AKI in patients with KDIGO stage 2. So this was quite an early stage of AKI patient. The degree of renal impairment was not so severe. The patients were randomized to start dialysis early, which was defined as dialysis within 8 hours of randomization, or delayed strategy where the dialysis was either not done or it was started after 12 hours. So when we look at the graphs, so here the mortality, 90-day mortality data was indicated that mortality was much lower in patients who were started on dialysis early compared to the delayed RRT group. Other key outcomes also suggested that probably these patients had shorter KRT duration, shorter hospitalization, so this was more of a positive trial. But this had severe drawbacks. This was a single center study. This was a small study. It comprised only 200 patients. They were less sicker patients than we usually encounter in our day-to-day practice. So a part of these shortcomings were actually taken care of by the trial, which was done reported from France. So here the patients were in stage 3 AKI. These were sicker patients. 80% of them had sepsis. 80% were on ventilators, and 80% had some sort of vasopressors going on. So this is the kind of patients that we routinely see on day-to-day practice. So they were randomized to receive dialysis either early after randomization or delayed dialysis. And you can see in both the graphs that the patients who had been randomized to either early or delayed, the outcomes were not different. The overall mortality was 50% in both the groups, and it did not differ by whenever the decision was taken to initiate dialysis. The results of Akiki were supported by ideal ICU, in which also the intensive and less intensive, the delayed and the early KRT initiation groups fared similar with respect to mortality, 60-day mortality, the length of hospitalization, and length of ICU stay. Now this, we come to a bigger and better trial from comprising more than about approximately 3,000 patients. Here also, the general consensus was that the patients who were started on dialysis determined on the basis of standard indications, and those who were dialyzed a little early in the course of illness, both of them did fairly equally well when the 90-day mortality was considered.
Their hospital dependency on RRT as well as hospitalization was also not different across two groups. Now, this one was the most latest trial, which also answered the question whether delaying dialysis beyond what was done in original Akiki, that is beyond 57 hours of randomization, is that even feasible? So even within this trial, it was seen that delaying dialysis based on compelling indications was also acceptable. The outcomes are not different when you start dialysis early. So overall, what we can infer from all of these major trials is that outcome of patients with AKI who require dialysis is anyways poor. It is the mortality is between 40 to 50%, but it is not affected by choosing the time of dialysis. It doesn't, early dialysis does not help in improving the mortality outcomes. So the decision to initiate dialysis should be based on compelling indications. So, more importantly, the practice points would be the decision to dialyze would not be based on what the urine output has been, but the volume status of the patient, the potassium and acid based disorder. If the patient has hyperkalemia or fluid overload, and of course, kidney dysfunction, if the patient is making urine, go ahead and try to optimize it with diuretics. If there is ATN is already set in, diuretics are not going to help. So optimize the metabolic milieu with the help of dialysis. So when the decision is taken that the patient needs dialysis, what is the modality which should be chosen? So the KDIGO outlines that this could be some form of intermittent hemodialysis, continuous hemodialysis, or even peritoneal dialysis. In intermittent hemodialysis, this is the conventional, similar to what is done in the OPD dialysis, the dialysis carried out for 4 hours. But here what happens is the solute removal is faster, the fluid removal is faster. So continuous RRT therapies offer advantages that here the solute and fluid removal is slower. The transcompartmental fluid shifts are gradual. So this offers an advantage of better hemodynamic stability. The machines, even though they are expensive, they are generally user-friendly. However, since the blood flow is generally slow for continuous strategies, anticoagulation is almost always required. There is a risk of hypothermia. Efficiency is slower because the blood flow, dialysate flow are slower. So the efficiency of solute removal is slower. So it cannot be used in situation, or it should be a less preferred strategy in which cases the rapid removal of solutes is required. Like severe hyperkalemia, you would want the patient to be coming to the normokalemic range so that you can reduce the incidence of cardiac arrest. Rhabdomyolysis, poisoning, tumor lysis syndrome. And even though the CRRT is a very user-friendly machine, it asks for a different machine, which is expensive. Even the cost of daily treatment is also quite expensive. And it is definitely technically demanding. So what has now emerged is the emergence of hybrid therapies like sustained low efficiency dialysis, sustained low efficiency daily dialysis. Here, the existing machines can be used. Whatever machines are used for the conventional dialysis, same filters, same tubing set, same fluid, everything can be utilized, but the machine can be tweaked in a way that the fluid and solute removal can be slower, so that it is hemodynamically less demanding. It can be even done without anticoagulation if need arises, and it can be coupled with additional therapies. And same machines ensures that any hospital or any place can actually do this process within their ICU. So now looking at the objective evidence at how these two therapies compare. So I'll highlight mainly the two studies. First one is the registry data which comes from St. Michael's Hospital, Canada. They looked into their AKI registry and stratified patients into who received a SLED and who went on to receive CRRT. So when they looked at the results, the 30-day mortality was similar in both the groups. The dependence on dialysis was similar in both the groups. And early clinical deterioration, which they defined as hemodynamic worsening, which occurred within 48 hours of starting any form of dialysis, that was also similar in these two groups. But this was a registry data. This was not a randomized trial, which we are coming to next. This was reported from Germany. Here, the patients who were admitted in surgical ICU developed AKI. They were randomized to receive either SLED or continuous CRRT. Here also, the 90-day survival was similar in both the groups, and various secondary outcomes, including the hospital stay, mechanical ventilation, recovery of kidney function, that was also not different in the two groups. Now, this one is the Cochrane meta-analysis comprising all the available evidence, including the observational data as well as the randomized trials, which have also compared CRRT with intermittent form of RRT. So they also noted that the outcomes are not different with respect to in-hospital or ICU mortality, RRT dependence, hemodynamic instability, and need for pressor therapy. So based on availability, any of those two strategies are comparable. Now, there is a newer, not so newer rather, a modality called the online hemodiafiltration, in which we use the additional convection principle to remove larger middle molecular weight toxins. So this has been proven to provide some benefit for patients who are on of CKD who are on maintenance hemodialysis. But however, this has been attempted in AKI as well, but it was not found to improve any outcomes of patients with AKI. That's why I'm not going to talk much about this. How about peritoneal dialysis for AKI? So for children, peritoneal dialysis still continues to be an important modality of doing dialysis. The advantages include that you do not require a special equipment like special pediatric tubing, pediatric circuits, smaller filters. So a PD catheter can be placed very easily for kids, and doing PD is much simpler for younger kids compared to doing a dialysis. Even for adults, this is a useful strategy and was very commonly used when the penetrance of hemodialysis was not as much in the hospitals in India. In the war-afflicted areas also, this continues to be an important modality of providing on-site hemodialysis services if the need arises. But since it has fallen out of favor due to many different reasons, there are not a good quality data to compare head-on HD versus PD. And most of the data which you see in the A section are actually the observational cohort studies comprising very small sample sizes. The section B includes just 4 randomized control trials, which also the sample size has been quite small. And since these studies have been very heterogeneous in the type of dialysis they have done, so broad consensus cannot be drawn. But what can be deciphered from the forest plot is that in both the therapies, the outcomes seem to be comparable, whether the patients are chosen for HD or PD. So where do we stand? So whenever we have a patient for AKI, so what is to be understood is that look at the hemodynamic status of the patient, look at the availability of what is available for you to perform dialysis services, what kind of staff support we have, what is the training and skill set of the supporting staff, what are the lab support services, and of course the finances, which should guide that what therapy is chosen. By far, the therapy which you are comfortable, which your staff is comfortable, that should be the optimal therapy for patient with AKI. Now coming to the dose of dialysis, how much dialysis to deliver. So this is traditionally measured in terms of solute clearance, measured as KT by V urea for intermittent therapies, and as effluent flow rate, which includes a sum total of volume of dialysate, volume of ultrafiltration, and replacement fluid, if any, expressed as ml per kg per hour. So this is technically measure of solute clearance for continuous therapies. So based on these objective markers, there have been attempts to understand if we deliver more dialysis, are we causing more benefit to the patient, or it doesn't really matter. So there was this very good trial, which the ATN network trial, which was done as early as 2008, in which they looked at this question. The hemodynamically stable patients were to receive intermittent therapies 6 times a week, intermittent dialysis is 6 times a week, with a target single pool KT by V of 1.2 to 1.4 per session. Less intensive group was to receive this therapy thrice a week with a similar target per session. Hemodynamically unstable patients were to receive CRRT The intensive group, the effluent volume was targeted to a higher value, 35 ml per kg per hour. And for less intensive group, it was kept at 20 ml per kg per hour. So in this graph that we see right below that, we see that the intensive group and the less intensive group did fairly equally in terms of 60-day mortality. Even the other outcomes, when stratified by the type of dialysis, by the type of patients, outcomes are not very different. So what is inferred is that delivering more quantity of dialysis may not be necessary in terms of solute clearance to deliver to get benefits of from outcomes point of view. However, in real world situations, you must have, I think, noticed or most of the situations that the nephrologist orders dialysis for 2, 3, 4 consecutive days. So in those settings also, the dialysis is mainly done for fluid removal rather than to achieve any particular solute clearance. So in the real world situation, the decisions for daily or more frequent dialysis would be governed more by the volume status, which indirectly affects the duration of mechanical ventilation, creates space for administration of obligatory fluids than for any particular solute clearance target. Now, this is another area I just wanted to touch upon this topic, that because many a times we get call from ICU that the patient has severe metabolic acidosis, pH of 6.9 and lactates of 25, we need to start the patient on dialysis. So this is most commonly in the situations of septic shock, other important indication being CLD as well. But this is where, because of improper perfusion of peripheries, anaerobic glycolysis sets in, lactic acid production increases, but simultaneously liver is also affected by shock. The clearance of hepatic clearance generally goes down much below, so the lactates rise. But can we really remove this lactates by dialysis? Probably not. And this has been objectively assessed by this very good paper that was published, which looked at how much of lactate was cleared endogenously versus how much of it was cleared by CRRT. So when we look at this graph, only 3% of total lactates were removed by CRRT. Rest was taken care of by endogenous metabolism. So lactic acidosis, dialysis wouldn't generally help. What would help would be the treatment of underlying sepsis, removal of septic focus if possible, ensuring perfusion, giving the initial fluid bolus maybe, optimizing vasopressors, tweaking the ventilator settings to cause more of CO2 washout, which can not treat lactic acidosis, but at least correct some degree of acidemia. Now coming to when the patient has started getting better, the patient has started developing some sort of urine output, when should we start thinking about de-escalation? So unfortunately, this is one area of AKI in which there are no randomized controlled trials, but several observational studies and a meta-analysis done on the basis of that, where 16 parameters were assessed for their utility in predicting which patients could be taken off RRT. So among different markers, urine output was predicted to be the most robust marker for predicting the de-escalation from RRT. But the studies were very heterogeneous. The amount of urine output per day, which could suggest that the patient could be de-escalated, was very wide, from 171 ml per day to 2 liters per day. But the studies were so heterogeneous that they could not come to an AOC. So what we usually do in our practice mimics what is highlighted by this flowchart, which comes from Johns Hopkins. If the patient is now becoming hemodynamically stable, now in such situations, even the renal perfusion starts getting better. The ongoing mechanism of kidney injury starts getting better. So generally what happens is the patient develops ever increasing urine output every day. So in this situation, now that this patient has started making urine, now you would question that what additional benefits are you expecting from CRRT? If the patient is making 500 ml of urine per day, but you still need to give the patient 2 liters of fluid for infusions, antibiotics, nutrition, you think that the patient would again land up in for dialysis after 2 days. So you continue giving it, you give some diuretics and wait for urine output to improve a little bit more. So when the urine output starts improving, maybe you can think, if the patient is on continuous RRT, maybe you can think about de-escalating patients to intermittent form of regimen. If the patient is already on intermittent form of dialysis, now maybe you can think about increasing the gap between two dialysis sessions or decreasing the frequency, and then maybe you can think about decreasing and stopping dialysis altogether. So this brings me to the end of the presentation, and there would be some take-home points. AKI is very, very common problem, and those who require some form of RRT, eventually approximately half of these patients die during the course of the illness. However, the timing of initiation of RRT has no bearing on the mortality outcomes, the chances of renal recovery, as well as the hospitalization length. And the need of RRT therefore should be governed by the compelling indications for dialysis. The choice of modality should be guided by hemodynamic status of the patient, what is available with you, the skill set and the training that the staff has, the availability of support staff, ancillary lab services, as well as the finances. De-escalation should be generally guided by patient's volume status, obligatory fluid requirement, expected benefit if you think RRT has to be continued, and of course the urine output. So thank you for bearing with me in the to the presentation, and I'll be glad to take up questions.
Ma'am, a small question. That's at budding physicians that we frequently we encounter in the ICU, the AKI. Ma'am, what is it, ma'am? Actually, please help us, guide us for the role of N-acetylcysteine in the AKI.
N-acetylcysteine for AKI, there is no role. Even for the contrast associated AKI, it was, there's a very big trial which goes by the name of PRESERVE trial. It was conclusively demonstrated that only plain NS administration is one strategy which reduced the incidence of AKI in patients who received some form of IV contrast. But N-acetylcysteine group, and there was another arm which received the sodium bicarbonate, there was no benefit attributed to each of these drugs. So in AKI, this is one region where it has been studied in actually very much detail by number of investigators. So N-acetylcysteine actually holds no place. And logically also, the way it is supposed to work is by mitigating the free radical injury. The amount of N-acetylcysteine that actually reaches the kidney would be expected to be too low to cause any meaningful benefit. And plus, there have been many trials that have actually demonstrated that it is futile to use it. It just adds to the cost of therapy without adding any value. So, like I said, that they were initially a school of thought that doing prophylactic dialysis in any form of hospitalized patients would actually help with the metabolic milieu. This was a thought process that probably the AKI, once it sets in, it leads to a lot of metabolic abnormalities that possibly accounts for poor outcomes of the patients who develop AKI. But subsequently, the randomized trials, barring one single Elaine trial, which was the early single center study, none of the trials actually demonstrated any benefit when the rest, this was in terms of mortality also. 60-day and 90-day were generally the criteria used for most trials. It had no effect on the mortality. It had no effect on the length of hospitalization. Early dialysis also does not predict recovery and maybe de-escalation or weaning from dialysis in patients who eventually recover. So the timing does not really help with the mortality outcomes and including the hospitalization outcomes in AKI. Sir, AKI patients would be most commonly when you encounter the AKI patients like the ones requiring RRT, they would be in the situation where they would be admitted in your ICU. So you would already have a visiting nephrologist coming to you in most situations and not. But I think the moment if the RRT facilities are not available, provided the patient is safe to shift in even an ACLS ambulance, and you predict that, okay, the patient has worsening hemodynamics, the renal perfusion is expected to go down and kidneys are eventually going to take a hit. So that is the time when you should maybe start thinking that, okay, if this cannot be managed here, if I cannot start the dialysis here, maybe I should start referring the patient wherever these services are available.
Thank you so much. Thank you, Dr. Lavi, for such a nice and brief insight about AKI. We are dealing with many patients of dialysis. We are having more than 500 dialysis in a month in Subharti Medical College. Yes, Dr. Akash, we have a budding nephrologist with us. Yes, Dr. Akash. तो हम बहुत अच्छा काम कर रहे हैं. अब हम ट्रांसप्लांट की तरफ भी जा रहे हैं. डॉक्टर संदीप गर्ग already in Meerut City doing the renal transplants. So we are also looking forward to the renal transplants. We have one recent joining, Dr. Ankur Sharma, who has done 6 years job in renal transplant. He has joined Subharti now.
So in that situation, you would not be required to refer. You would actually ask for referrals to your hospital.
Yeah, thank you so much.
I would like to invite all the chairpersons for felicitating Dr. Lavi Gaur ma'am. Thank you, sir. Thank you, ma'am.
Actually, we are running very late. So we will be having a brief lunch in between of 15 minutes duration only. Then we will be starting the next session. Yes, before going for the lunch, we have a next lucky draw of the day. So who is the... Yes, MBBS 21 batch, Atirek. Is here? Yes. Thank you so much. We'll be back after 15 minutes. Announce the date.
We'll be back after 15 minutes for the next session. Thank you.
Talk. This is a very important topic, and I see the audience is a mix of very seasoned gastroenterologists and some young students. So I'll try to keep it simple, and this is a very vast topic, and I'll try my best to complete it within time. So fatty liver basically is deposition of fat within liver. Whenever you have fat deposition in more than 5% of hepatocytes, this is termed as fatty liver, and the initial concept was that there should be an absence of significant alcohol intake, more than 21 drinks per week for males and more than 14 drinks per week for females. So recently, as all of you must be aware, that there has been a change in nomenclature. What was the problem? The problem with non-alcoholic fat, the term non-alcoholic fatty liver disease, was that this was a diagnosis of exclusion. The key pathogenic factors were not included here, and there was a stigma. It was thought that there is a stigma associated with this, so this was changed. And initially, this change was the nomenclature was revised to the term metabolism-associated fatty liver disease. However, this change lasted for not more than a year, and it was subsequently changed to metabolic-associated steatotic liver disease. So this was a consensus meeting in 2022, and a broad umbrella term of steatotic liver disease was given, and under that broad head there were 5 terms. So anybody whom you would have in whom you would see a fatty liver on ultrasound would be termed as steatotic liver disease, and these patients would be subsequently categorized into either metabolism associated fatty liver steatotic liver disease, and this new term of MET-ALD was introduced, where you see very frequently that people are obese and they also consume alcohol. So to accommodate this MET-ALD was incorporated, where it was either MASLD predominant MET-ALD or ALD predominant MET-ALD, depending on the quantity of alcohol consumed. Pure alcoholic liver disease, where there is no metabolic risk factor and you have only alcohol consumption. Specific etiology SLD, in which certain drugs like amiodarone, monogenic diseases and other drugs, and cryptogenic SLD, where you would not find any cause. And for the criteria of MASLD, once you have fat in the liver on ultrasound, and even if one of these 5 criteria is present, these 5 criteria of metabolic syndrome is present. So the earlier problem with MAFLD was that it required HOMA to be done, and from this HOMA was removed, so it leads to a lot of simplification. It is very easy to categorize these patients now. So in this, the metabolic descriptor provides an affirmative non-stigmatizing description. That is why this term. The introduction of separate MET-ALD, this is another new thing which has happened here. The proposed nomenclature also improves on the non-alcoholic, and appropriately assigns a metabolic basis for the liver disease. This is one of the key drivers for this change. It is not required to calculate HOMA. So this is an important study which tells you about the burden of the disease. This is a study by a very eminent researcher, Zubair Yunusi, and this has been published recently, which shows you the global prevalence. If you see, the global burden is around 38%, and it is across the world. Lean FLD is another thing, but if you see the all-cause mortality, cardiac-specific mortality, extrahepatic cancer, liver-specific mortality, so there are a lot of downstream effects associated with this fatty liver disease. In India, there has been a recent study by at AIMS, where they have shown that these figures are actually staggering. Nearly 38% in adults, 35% in children, they have fatty liver disease, and in high-risk patients like patients who are obese or overweight or have type 2 diabetes, this figure crosses the 50% mark. So you can understand the gravity of the situation. And why it becomes very important once we see this natural history progression, that 1 in 5 patients with steatosis will progress to inflammation, that is MASH, and subsequently it is thought that it takes 7 years for one stage fibrosis progression, and then 1 out of 5 patients will progress to liver cirrhosis, and once you have liver cirrhosis, then it leads to compensated cirrhosis, to decompensated, a shortened survival, and a risk of hepatocellular carcinoma. And MASLD, in many of the recent Indian studies and worldwide, has replaced hepatitis B, see, and even alcohol as the most important cause of liver cirrhosis and hepatocellular carcinoma. So this is the importance. Very briefly about the pathogenesis, there are different steps. In first step, you have the fat deposition in liver, and this stage is driven by insulin resistance. Subsequently, you have inflammation, where lipid peroxidation and a number of inflammatory mediators start playing on. I'm not going in the details of this. And subsequently, you have fibrosis, where hepatic stellate cells play a key role, and this leads to fibrosis. And in this whole paradigm, initially this was a double hit theory, but now what we call this as a multiple parallel hits. And the new insights are the genes like PNPLA3, TMF, TM6SF2, and MBOT, and gut microbiome. I'll just briefly allude to these key points. Metabolic syndrome, as medicine people, you all are aware, I need not go into these details. Insulin resistance is the key driver. It is driven by central obesity and overeating. So overeating, central obesity, visceral fat leads to insulin resistance. That leads to deposition of fat in the liver. Something happens in between which triggers inflammation, and subsequently it is followed by fibrosis. So this is in a nutshell the entire spectrum of pathogenesis and subsequent clinical features. Approximately 90% of the patients will have more than one metabolic syndrome, and nearly 1/3 will have complete. So genetic factors in NASH, at every step of pathogenesis of NASH, there are a number of genes which are involved. However, there are two genes which are very important. These are PNPLA3 and TM6SF2. PNPLA3, I am specifically stressing because a lot of people now are getting this gene because the trials, the small interfering RNA trials, these are in phase 2 trials, and in the next 2 to 3 years, we are expected to get this drug for the treatment of NASH and maybe other liver disease. This is basically this gene was identified long back in the Dallas Heart Study, and it encodes a protein which is known as adiponutrin, and there are different genotypes. The CC genotype is protective, and the other two genotypes predisposed to alcoholic liver disease, and it is known to induce fat and fibrosis across the spectrum, not only in NAFLD, in all the other diseases, it is known to do this. And this is another gene. We do not have a specific treatment target here, but this is again an important driver of the disease. Microbiome is being recognized more and more importantly. Dysbiosis is a broad term, and whenever there is dysbiosis, it is associated with increased intestinal permeability. This leads to this endotoxemia and Kupffer cell activation, and this subsequently TNF activation, and this drives fibrosis. So interventions changing at gut microbiome are again important in treating NAFLD, and there is data to suggest that. Now, having understood the pathogenesis, the burden of the disease, what are the clinical features? Till the stage of steatosis, there are hardly any symptoms. This is usually an incidentally detected disease. In MASH, you can have some fatigue, weakness, and once you reach the stage of cirrhosis, so all the clinical presentations of cirrhosis might be there. So fatty liver is essentially asymptomatic disease, and it's usually detected on a routine ultrasound examination. On ultrasound, there are different grades, and when the liver appears more bright in comparison to kidney, that is grade 1. When you have loss of deep echoes, the vessels, you can't see the vessels properly, it is grade 2. And when you can't see the diaphragm through the liver, it is grade 3 fatty liver. It is non-invasive, inexpensive, and it has got good sensitivity and specificity for detection. So once you see a patient who is incidentally detected with fatty liver disease, what are the things you are concerned about? There are two very important things. As hepatologist, as a general physician also, you are interested in seeing what is the stage of the liver disease and what are the liver related risks in the short term and the long term. And one of the very important points which as physicians all of us must remember, that cardiovascular risks and other risks need to be assessed in these patients, because MASLD is a part of a broader disease spectrum where cardiovascular risks are very important. So significant fibrosis is the most important determinant of the outcome. So how do we detect this significant fibrosis? So in other words, what is the risk stratification? So there are two terms fibrosis and inflammation. So which is more important? Fibrosis is more important. You see, this is a very elegant study which shows that as the fibrosis stage increases, the risk of all things like all-cause mortality, liver-related mortality, need for liver transplant, and all liver-related events increase. And at the same time, if there is no fibrosis, then the presence of NASH, that is the inflammatory activity, does not affect the outcome of the progression of the disease. So how do we assess the significant fibrosis? Liver biopsy is the gold standard. However, it has got a number of limitations. So what we are relying on, what is known as non-invasive tests, and this has been recently named as NILDAs, with their serum-based biomarkers, and then there are elastographic techniques. This is very important because as a medicine people, as a physician, you are the first point of contact. So how do you triage these patients to refer them further to the hepatologist for a further gastroenterology care? So conventional NINDAs, they have either a blood-based, there are usually these blood-based simple tests, or there are complex proprietary tests. FIB4 is very important, and many labs now give automated FIB4 assessment along with your routine reports, and this is very helpful. ELF and FibroSure, Fibrometer, all these are patented tests. The important thing to remember here is that these tests have high negative predicting value. That is, they are good at ruling out advanced fibrosis in MASLD, and they do not predict the presence of advanced fibrosis. So once these tests are normal, you are sure that there is no advanced fibrosis, but the presence of advanced fibrosis cannot be predicted by these tests. So this is the chart which shows you the recent tests we have for predicting advanced fibrosis, or there is a new term known as at-risk MASH. So these tests are very, you see this is Agile test, Agile 4. Again, this combines the FibroScan, that is the VCTE, the LSM, and ALT-AST ratio, platelet, gender status, and diabetes. You have Agile 3, where you just add age to Agile 4, and NIS, NIS2, which includes some molecular markers. SAFE, ADAPT is again a very good score. And then you have simple tests like FAST, which is just adding LSM and CAP and AST. And then you have tests like MAST, MEFIB, which are good at predicting fibrosis. And these are some metabolomic-based predictors for fatty liver disease. So most of these tests are designed to detect at-risk MASH or advanced fibrosis. So imaging-based NILDAs, again, due to want of time, I'll just touch them very briefly. There are 3 types. You can have ultrasound-guided RF or shear wave elastography, transient elastography, FibroScan, and then we have MR elastography and MR proton density fat fraction. FibroScan, a value of more than 8, has got significant sensitivity for predicting F2 fibrosis, and a cap of more than 275 denotes steatosis, and then again it can be graded according to S1, S2, and S3, and again this has been there has been a grading around according to the weight of the patient also. So having this information in the background, now how do we know that which patient, given the disease burden, the disease, 40% of the patient in general population have fatty liver disease. So how do you go about it? So any patient who have 2 or more metabolic risk factors, anybody who has diabetes, this is very important, that anybody who has diabetes and anybody who has steatosis and associated transaminitis, they all should undergo a assessment of FIB4, initially by a FIB4, and then patients who are low risk, they can again go a repeat testing in 2 to 3 years. Patients who have indeterminate risk in FIB4, they can go by liver fibrosis assessment by LSM, and if these patients again show a low, then they follow this paradigm of reassessment at 2 weeks. Higher risk patients go to hepatologists. In indeterminate risk factors, again, the current thought process is to subject them to liver biopsy. So this is how you can triage your patients for a care pathway and their follow-up. So this is again a new paper coming by the Arun Sanyal group, where they have added presence of diabetes. So what they say that if a patient has got diabetic, So even if the patient, a diabetic, has got a FIB-4 less than 1.3, you should subject them to the second non-invasive test, and depending on these value, if the risk is low, then they should be reassessed at 2 years. If the risk is indeterminate, they have proposed a follow-up of these patients at 1 year interval. So these are ways and mean of refining our approach to these patients to pick up fibrosis at early stage and to initiate drug therapy as and when it is indicated. So these extra hepatic associations of MAFLD, MASLD are very important for physicians. MASLD is associated with many extra hepatic diseases, CVD, type 2 diabetes, sleep apnea, osteoporosis, psoriasis, and PCOD. They all come as usually in the cluster, and association of obesity with different malignancies are already known. So these patients, since they share a common pathogenic pathway, the risk of malignancy is also high. And you see, there are studies which show that patients who have steatosis have got higher incidence of hypertension, and the arrhythmias and different cardiac events are also higher. And the Indian National Society of Study of Liver, INASL, it recommends that CVD evaluation should be done in all patients who are old, who have metabolic risk factors and advanced fibrosis. So advanced fibrosis, assessing for patients for more than F2 fibrosis, is central to the theme of triaging, and it is also important in the institution of treatment. You cannot treat all these patients with drug therapy. So now once you have diagnosed, you have to do a non-invasive assessment or biopsy. Mostly the world is moving on non-invasive assessment because doing a biopsy is not mandatory outside the clinical study settings. So what do you do? In very brief terms, if you have simple steatosis, no fibrosis, just lifestyle changes and looking for management of cardiovascular risk factors, patients who have less than F2 fibrosis, lifestyle changes, cardiovascular risk assessment, and maybe these patients can be treated in clinical trials. Patients who have NASH and have got significant fibrosis, then they are eligible for different drug treatments. And I'll just within next 5 to 7 minutes share very briefly about what are the drug options which we have now and what are the results. So lifestyle recommendation, people with MASH, this is a very important slide where you see if you are able to achieve more than 5% of body weight, there will be reduction in liver fat. If you are able to achieve 7 to 10%, then inflammation improves. And if there is reduction of more than 10% of body weight, then there is improvement in fibrosis. And diet, the general principles of calorie restriction, they are the most important thing, that you have to achieve a negative calorie deficit of around 750 calories per day in order to achieve a weight loss of at least 3 to 4 kgs per week. Exercise is very important, but again, as we know, that exercise alone does not lead to weight reduction, but this is very important. And you also prescribe exercise according to the recommendations, at least 150 minutes per week, and which can be both aerobic and resistance exercises. Now coming to the drugs. You see, what do we expect from a drug which we are going to use to treat NASH? It should lead to reduction in inflammation. It should induce a regression in fibrosis. It should have a favorable cardiovascular profile. And since these drugs are going to be used for long term, these should have a long term safety in cardiovascular profile and otherwise also. The FDA prerequisite for giving conditional approval is that the 2 histologic endpoints should be achieved: improvement in liver fibrosis without worsening of NASH, or resolution of NASH without worsening of fibrosis. And I'll show you the results of different drugs which have been granted approval later. And full approval, none of the drugs as of now has got full approval because the long-term goal of showing a prevention of progression to cirrhosis, death, and liver transplant need has not been shown. So this is a diagram which shows you the current drugs. There have been a lot of drugs, but currently these are the focused drugs. So currently, what are the drugs? Drugs which affect fatty acid oxidation, THR beta agonist, resmetirom, pan-PPAR agonist, lanfibranor, and FGF21 analogs, this fructifermin and pegozafermin. These are very promising drugs. Drugs which decrease novel lipogenesis, again, FGF is important, but a new class of drugs, this fatty acid synthase inhibitors, which is denfinstat. This is a very important drug, still in phase 2 trial. And again, as we know that drugs, subsequently drugs which act on stellate cell inflammation, inflammatory activation, these are again pan-PPAR agonists, and then various kinds of, initially we started with GLP agonists, then combined GLP GP1 agonists, and then triple agonists, that is GLP1, GP1, and glucagon agonists. These are the drugs which act at various levels, including from delayed gastric emptying to targeting insulin resistance to increasing the fat utilization. And this is the landscape, how it looks. You see, post 2016, there has been a spate of drugs which have entered into these trials, and many old antifibrotic drugs like Seniviroc and many others have gone out of favor. And now you have two drugs which are FDA approved. Resmetirom got approval in March 2024, and this semaglutide. Semaglutide is an old drug, but for NASH, specifically for MASH, it has got approval in August 2025. So these are two FDA approved drugs for NASH as of now. Now, once we talk of pharmacotherapy of NASH, it is very important that drugs like statins should not be used. Only if there is a CVD indication, they should be used. Metformin, PUFA, UDCA, pentoxifylline, these drugs have got no role in treatment of NASH. In Indian scenario, this is a slide from the INASL guidelines. Vitamin E, this is a 2010 trial, vitamin E, pioglitazone, still it has got a role. Saroglitazar has been approved by DGCI, but it has got its own shortcomings. We all use it right, left, and center, but you must remember that this drug still does not have US FDA approval because the data is not as robust, because there is no pre and post liver biopsy data to show that there are only tests using the NITs to show the improvement. Apart from saroglitazar, the drug which is most promising today is probably lanfibranor, but the landscape is changing so fast that despite being a good drug, it leads only reduction in NASH. It does not affect fibrosis, so it will be probably pushed by the GLP-1 agonists or other drugs which are there because it does not have any effect on fibrosis. Now, very briefly about these two drugs which have actually got approval. Resmetirom, you all must be aware that this thyroid has got two receptors for action, THR alpha and THR beta. THR beta is present only in liver, THR alpha is present all across the body, and resmetirom is basically a liver-directed, orally active thyroid hormone receptor. So it is a THR beta agonist, and what does it do? Once it is activated, it promotes mitochondrial oxidation, promotes autophagy, and reduces triglycerides and cholesterol. So it ticks all the boxes for the treatment of Nationl, and this is the phase 3 trial on the basis of which this FDA approval was granted. This was a multi-center, multi-continental study where there were 3 treatment arms, and what it shows, these are the brief results, that it led to NASH resolution with no worsening of fibrosis. This 80 milligram and 100 milligram almost had similar over the placebo. There is a significant improvement and fibrosis improvement by more than one stage without worsening of NAFLD. So this was the first drug which showed tick both the boxes, and that's why it got FDA approval. And the side effects, diarrhea is one effect, and predominantly there is no liver-related, thyroid-related effect with this. So today, resmetirom is available, and if you have to use it, the indications are that if you have an imaging-based NILDA, if you have a LSM value of 8 to 15, if you are using MRE, then 3.1 to 4.1 kilopascals, and if you have a liver biopsy, then F2, F3 fibrosis patients, these can be offered treatment with resmetirom. And once you start treatment, you assess the response of treatment at 12 weeks. If you have worsening of the NILDA or no decrease in AST, ALT, then you stop. If you have an improvement in LSM, which is more than 25% at VCT and more than 20% in MRE, then you should continue resmetirom. We do not know till how long, but there is the extension trial of this which is continuing, and probably 4 to 5 years is the timeline which they are looking at. Probably then they will be able to, then they are recruiting cirrhotics also in that study. Probably that will lead to the full approval of this drug. And if there is a reduction which is in between, then we have to imagine that. Now, before we'll go to GLP-1 agonist, then we are all aware of this, and this is the entire gamut of drugs which we have: semaglutide, tirzepatide, which is there, approved for obesity, and I'm sure that soon it will get approval for MASH also. This triple agonist survodutide, this is again in a phase 2 trial right now. And DPP-4 inhibitors, again as an anti-diabetic drug, it is very useful to add these drugs. You do not have structured data, but there is still a lot of data for these drugs in MASH. So this is the phase 3 trial published in 2025. This is the key trial on the basis of which this approval has been given. And if you look at the improvement, semaglutide 2.4 milligram per week for 72 weeks. This is an ongoing trial, and this is an interim analysis at 72 weeks. So what it shows, that significant improvement in steatosis, 62% versus 34%, significant improvement in fibrosis, 36% versus 22%. You see, the placebo arms also are getting the same lifestyle and dietary measures, so they also show. So that should impress upon you the importance of simple lifestyle measures. That also leads to significant benefit. Semaglutide acts over and above that, and here it led to nearly 10% of weight loss as compared to 2% weight loss in the placebo arm. And these are the drugs. I won't go into the details. Tirzepatide and survodutide, these are the other drugs. Retatrutide, there are a lot of other drugs. Orogliflozin is another drug. All these are now oral drugs which are available for there. And again, in this whole gamut, SGLT2 inhibitors also need to be kept in the loop, because a lot of these patients would be diabetics, and there is data, there is no to suggest that patients with diabetes, and you look at this, nearly 500 patients, non-diabetics, treated with SGLT2 for fatty liver, because a lot of these patients would already be on SGLT2 inhibitors, or for control of diabetes, or for MACE benefits, you will require to add SGLT2 inhibitors to them. So in the end, you have this is a algorithm which I have taken from a JAPI article by one of my colleagues, Dr. Ashish. And what it says is essentially that you divide these patients into non-diabetics or diabetics. In diabetics, if you have less than F2 fibrosis, lifestyle measures goes across the board, but in less than F1 fibrosis, semaglutide, tirzepatide, SGLT2 inhibitors, and pioglitazone. Again, this would probably, if you add obesity, then you will have able to presence of obesity, because using pioglitazone in obese people is not a very good idea. In patients who have more than F2 fibrosis, semaglutide, resmetirom, and all these gamut of drugs can be added. And these are the drugs which we use, but they are not really very strongly recommended. So to conclude, MSLD has got a high disease burden in India. Insulin resistance or metabolic syndrome is the key central pathogenic mechanism. MASLD has got a benign prognosis, but in this stage also, these patients should be taken care of for their extrahepatic risks, that is cardiovascular risk, and for assessment of different malignancy. Once this progresses to the stage of NASH, the chances of developing cirrhosis and HCC are high. Weight management and lifestyle changes are very important. And this is very important, that pharmacotherapy should only be considered in patients who have more than F2 fibrosis. Do not prescribe drugs in patients who have got F1 fibrosis. That is, broadly speaking, FibroScan values of less than 8. Resmetirom and semaglutide are 2 FDA-approved drugs. Both of them are available in India. And other drugs which are hot on the heels, PPR agonists, GLP agonists, FGF21, again, because of lack of time, I did not show this data, but efruxifermin is a very promising drug, and it will find its place in the algorithm of management. Thank you so much.
To know your views about, of course, in the last few years, there has been a frequent change in the nomenclature, but we have got a subset where MSLD in lean individuals who are non-diabetic and have almost normal triglycerides and almost normal, small fatty acids as LDL and VLDL. So what should be your approach in this subset of?
So if you look carefully at this group, sir, this initially we thought that lean NASH comprises of nearly 1/4. Now we know that it is less than 10%, but they have the same cardiometabolic risk factors. And if you look carefully at them, visceral fat. So bioimpedance studies, or if you do a CT scan, you will find a lot of visceral fat in these patients. So the distribution of fat in subcutaneous areas versus the visceral area. This visceral area is an inflammatory fat. And in these patients, what it is required that even a 3 to 4% reduction in weight, they are not overweight by conventional standards. We know the recent articles are there that BMI is not the best categorizer of weight. So they might be obese. If you look at the waist circumference is a better reflector of visceral obesity. That is the visceral fat, waist circumference better reflects that. So basically they have the same risk factors according to these yardsticks.
And one more, as far as the investigation and workup is concerned, we rely on the FibroScan. It's a good modality, but nevertheless, it's not available everywhere, and cost is also a factor. So we compare the FibroScan or a similar strategies versus those scoring systems like 5-4, and we have got other scoring system. What is the comparison, difference in sensitivity, diagnostic efficacy between the two groups?
So, the diagnostic performance of any test, the easiest parameter to see is OROC, the area under receiver operating curve. So, FIB4, if you look at FIB4, it has an OROC of around 0.8. FibroScan has an OROC of around 0.9. So, it is not very different. And all these ASLD, ACG, what they tell you that you first do not do FibroScan, you first do a FIB4. So you do a FIB4, FIB4 is age dependent. So for people less than 60 years of age, if you have a FIB4 of less than 1.3, and as I told you, it has got a very good negative predictive value. It has not got a very good positive predictive value. So a FIB4 of less than 1.3 in more than 65 years, a FIB4 of less than 2 very effectively rules out this thing. And there are other things. There is APRI also. This APRI is also very, then you can have this, now these ultrasound machines, they are enabled with this shear wave elastography. So in obese patients where you are unable to do FibroScan, it is very easy to do a RFE or a shear wave elastography on an ultrasound, routine ultrasound machine. And the new machines are also equipped with the software which they give you a liver fat fraction also.
I think excellent talk, Dr. Piyush, and just to emphasize that, every patient at HIV we are referring to are getting ultrasound reports showing fatty liver, grade 1, grade 2, grade 3, invariably with or without symptoms. So I think it is epidemic, and you already said 30%. I think it's more than 38% prevalence in our country right now. So I think the diet actually should be emphasized more than drugs, because we have the drugs like resmetirom is recently available. We have semaglutide. The Essence trial have done has shown that the reduction of fibrosis is with semaglutide, and all the other drugs, phase 2 trials are there with all the drugs. But I think diet, we should give more emphasis diet, as you rightly said, that 5 to 7% would reduce the fatty liver, then 7 to 10% would reduce inflammation, and more than 10% would actually reduce fibrosis in some aspect. And the semaglutide is a wonderful drug for patients living with diabetes with this method. So I think excellent overview, Dr. Piyush, and I think if any questions are there from the audience, we can take one or two. Thank you.
So that I showed you, there is a separate category known as MET-ALD. So if you are consuming less than 14 drinks per week for females, less than 21 drinks per week for males, and the person is obese, that has got metabolic, this is MASLD predominant MET-ALD. And if it is more than 350 grams per week for males, and then more than 450 grams per females, more than 450 for males, it is predominantly ALD. In between, it is an overlap. It is very common. Obesity is very common, and the this National Health Survey data 2020 shows that 20% alcoholism is there. Absolutely. So we always knew this, but definite values have been attached to this. And one standard drink, according to the easel definition, 10 grams of alcohol is one standard drink. According to US values, one standard drink is 14 grams of alcohol, but the European thing is easier to use. 1 gram is, one standard drink is 10 grams of alcohol.
So I think for residents, it's very simple formula 10, 20, and 40, 50. Right? For 10, 20, 10 grams in 10 grams in females and 20 grams in males per day of
Yes.
consumption of alcohol, it is mastered. Right? And 40, 50 is 14 females and 15 males. It is met-LD. And between that, 30, this 20 and 40, it is overlap. That this is a simple formula that actually we have in our OPD clinic basis.
In fact, it also depends upon whether there are slow acetylers and fast, rapid acetylers, and they can have some degree of alcohol metabolism derangement. So in that case, there is an overlap between NFLD and alcoholic.
So that is a complex issue, sir. There can be endogenous alcohol production because of gut microbiome. So there are a lot of factors there.
So thank you very much. It was a wonderful presentation.
Thank you so much, sir, for an amazing session on MASLD. Now, I would like to invite Dr. Sumit, sir, for felicitating Dr. Piyush Ranjan, sir. I would request all the chairpersons to felicitate him too.
In between the session, we conducted the prelims round of our quiz. We were expecting more teams, but still we had 7 teams. So I am announcing the results. There are 20 questions, and we had all the batches from our MBBS. 23, 20, 21, 22 interns as well. So the 3 teams scored 16. One is Santosh Medical College, LLRM Medical College, and Subharti final year PG, MD 23 batch. Surprisingly, the interns were on the 4th position with 14 marks. Then our MD 24 batch and final year MBBS 21, they scored 11. And MBBS 22 batch scored 10. Initially, we had thought that 5 teams will come on the stage, but keeping their enthusiasm in mind, we are having 6 teams. So the only team eliminated is MBBS 22. Rest all will have a final round after the sessions today. So Santosh Medical College, LLRM, Subharti final year, and Subharti 24 batch MD, and interns all are in the final group, and MBBS 21 batch as well.
Thank you, sir.
If you have any queries about question or answer, you can contact me.
Thank you, sir. For the next session, I would like to call on stage Dr. M.K. Maheshwari, sir, Dr. Mukul Rastogi, sir, Dr. Abhishek Yadav, sir, and Dr. Ankur Jain, sir. The topic is first week of acute pancreatitis. I would like to call on stage Dr. Vivek Saini, sir. I would like to request Dr. Saurabh Singhal, sir, to felicitate our respected chairpersons. Dr. Abhishek Yadav, sir. Dr. Mukul Rastogi, sir.
So, good evening, everyone. Today I'll be talking on the first week of acute pancreatitis. So, whenever we talk of pancreatitis, the time frame is very important. So, as per the revised Atlanta class, they have divided this time frame into early and late. Early being the first 7 days, and late being after 7 days, and it can extend up to even weeks or months. So the first 7 days is characterized by systemic inflammatory response syndrome, and that can lead to organ failure. However, the late phase is characterized by local complications and infections. Now, why these things are occurring in different phases? Why infection is not occurring in the first phase, and why organ failure is occurring in the first phase? But I'll be limiting myself to the early phase, that is the first 7 days. The answer to my question will be coming in the pathogenesis. So pathogenesis, in short, any insult, let it be any alcohol or biliary cause, that can lead to increased in the intracellular level inside the acinar cells. So that causes the activation of cathepsin B that lies inside the lysosomes, and that leads to the activation of trypsinogen in the zymogen to trypsin. So this trypsin leads to the acinar cell death and local injuries to the pancreas. So it's being long thought that trypsin is the main villain or the main culprit that drives the inflammation inside the pancreas. So is it really so? So can we kick out this trypsin and can lead to stopping this inflammation inside the pancreas? So what the researchers did, they took two groups of mice. In one was the wild type where the trypsinogen gene was intact, and the other group was in which the trypsinogen gene was knocked out. So what they found, and then they induced chemical pancreatitis, and then they took a piece of pancreas studied under the microscope for the presence of necrosis. So what they found that in the group in which the gene was knocked out, there was 50% reduction in necrosis. But point to be noted that in spite gene being knocked out, there was still the presence of necrosis. The necrosis was still there. They went a step ahead and looked for other markers of inflammation. So they looked for myeloperoxidase level in pancreas and also in the lungs, and they found that there was no significant difference between the two groups. So they inferred that trypsinogen activation is not required for progression of local and systemic inflammation during acute pancreatitis. So what are these steps that are missing? What are these parallel mechanisms that are still contributing to the inflammation inside the pancreas? So the other pathway is the activation of the NF-kB pathway that leads to the recruitment of the inflammatory cells, and that leads to the surge of cytokines, that is TNF-alphas, IL-1, IL-6, and that leads to the systemic inflammatory response syndrome. This is the answer to my question that why infection is not happening in the early stage. So in the first few days, that is in the first 2 to 3 days, there is a cytokine surge. There is an enhanced cytokine surge, enhanced inflammation, and the patient is also very toxic looking. But as the cytokine surge suppress, as it down tunes, the severity of disease also, it gets to the normal side. But here comes the issue. When the immunity is getting suppressed, when the inflammation is getting suppressed, the cytokines are getting on the lower side, gives a chance to the bacteria from the gut to leak, and they move to the pancreatic bed, and there they cause infections. So from SIRS, we have moved to MARS, that is a mixed antagonist response syndrome, to the CARS, that is compensatory anti-inflammatory response syndrome. This is why infections are not occurring in the first week, and they occur usually after 7 to 10 days. Now, how multi-organ dysfunction is happening. So the SIRs, what they cause, it cause vasodilation and it also cause the capillary leakage. So there is reduction in the intravascular volume. There is decrease in the intravascular compartment that leads to distributive shock. This result in microcirculatory dysfunction and ultimately leading to the organ failures. So the section summary for the pathogenesis is that there are multiple inflammatory pathways. The long thought notion that trypsin is the main activator, it is not so. There are other pathways like NFKB, there is a cytokine surge, and also the extracellular ATPs that are responsible for this inflammation. And secondly, it is being predominated by the SIRS, which leads to the organ dysfunction. Infection is not very common, although it can occur, but it is not so in the first week, and it is usually seen second week onwards. Coming to the diagnosis, so we still stick to the revised Atlanta class, that is from 2012, and 2 out of 3 criteria need to be satisfied, which includes the abdominal pain, the characteristic acute pancreatitis, which is the dull aching pain in the abdomen which radiates to the back. Second being the rise in the amylase or the lipase level, that should be more than 3 times the upper limit normal. And the third being the characteristic imaging findings. Although there are certain cases in which there can be falsely elevated lipase and amylase level, but I am not going in that. Coming to the severity, that is also been explained by the Atlanta classification, and it has been divided into 3 classes: the mild, the moderate, and the severe. In the mild, the patient is very just complaints of the pain abdomen and it's not having any organ failure or any local or systemic complications. In the moderate severity, patient might have organ failure, but that is usually temporary and resolves within 48 hours. Patient can have local or systemic complication without even the presence of organ failure. But in the severe category, there has to be persistent organ failure involving 1 or more organs. Coming to the etiology, almost 3/4 of the cases are still biliary and alcohol, and the rest of the miscellaneous causes comprises of only 1/4. So what are these 1/4 cases? Usually we see hypertriglyceridemia, but the level should be more than 1,000 to cause pancreatitis. Then there are certain drugs, azathioprins very commonly, valproic acid and mesalamine. Then post-KRCP, we are hearing it every now and then. Any blunt trauma to the abdomen, autoimmune pancreatitis, any viral infection, let it be any CMV, EBV or mumps, hypercalcemia due to hyperparathyroidism, or any anatomical anomalies of the pancreas. Any obstruction of the pancreatic duct, either due to tumor or cyst, can also lead to pancreatitis. Certain toxins, any scorpion bites, sphincter of Oddi dysfunction, and rarely it can be due to genetic altercations due to PRSS1 gene mutation or due to mutations of the protective gene, that is the SPINK mutation. This shot I have taken from the guideline from the American College of Gastroenterology. If a patient is more than 40 years and we are not able to establish any etiology, a pancreatic tumor should be suspected and we should search for the cause. But imaging should be done only once the inflammation has subsided, and we should wait for at least 3 to 4 months before we get any CT or MRI done. Some soft pointers how we can differentiate between the 2 main causes of pancreatitis. So whether it is biliary or alcohol, biliary is most commonly in females. The ALT is usually raised. It goes beyond 150, and there is some history of biliary colic in the past. However, alcohol is predominantly seen in males. The ALT is not so much raised, and due to chronic alcohol intake, the MCV might be raised. So these are some soft pointers that can help us to differentiate between biliary and alcohol. Now coming to the risk stratification, why is it required? One, we have to triage the patient whether to keep in the wards or whether to keep in the HDU or the ICU. One is that. Secondly, risk stratification, these scores also give us some stats that can help us to explain the patient and the relative what will be the course of the disease. So what we see that 1/3 of the cases are amongst all the pancreatitis is of severe acute pancreatitis. Out of this, 30% is a mortality. So prompt organ failure identification is very necessary in the early stage. So 1 out of every 10 patient of pancreatitis might be might not survive. So we have a buffet of scores for risk stratification at our disposal. So these are ransom score, BISAP score, Apache 2 score, SOFA, CTSIA, and latest being the TYG index. But the problem with these scores is that none of the score is gold standard. And secondly, they have a good negative predictive value. That means that they can rule out a severe course, but they can't rule in a severe course. So sticking to the score is good, but that should not supersede our clinical assessment. So if we want to choose one score, one risk assessment score, then BISAP score is good enough because it requires only 5 variables, and these 5 variables are easily available. So these are, as the name suggests, blood urea nitrogen, SIRS, impaired mental status, age should be more than 60, and pleural effusion. So if the score is more than 3, then the mortality is almost 5%, and it worsens as the score increases. Apart from that, based on individual studies, based on univariate and multivariate analysis, we have individual risk factors also, not only the scores that comprise of multiple variables. So SIRS alone is a risk factor that can lead to grave prognosis. Apart from that, patient characteristics, elderly patient with high BMI, patient having alcohol or with comorbid condition, they don't have a they usually have a gloomy prognosis. Apart from that, these individual lab parameters, rise in the hematocrit, rise in the BUN, rise in CRP more than 15, rise in the creatinine, that can also lead to poor prognosis. Apart from that, radiological findings like presence of pleural effusion or any lung infiltrates or any collection, multiple or extensive collection, that also shows poor prognosis. So coming to the point whether we should go for a CT on admission. So CT on admission is not required. CT on admission is not required for determining the severity. We should not run to get a CT done. But whenever there is no improvement in the first 48 to 72 hours of admission, or when the diagnosis is not clear, then we should go for CT. Always get an X-ray abdomen done because it helps us to rule out perforation. Sometimes a patient might be presenting with pain abdomen. There might be slight elevation of the amylase levels, but get an X-ray done. It can save us. It can rule out perforation. Coming to the management part, I'll be covering it under following headings. So first with the analgesia, then I'll be talking about the fluid resuscitation. Then the nutrition point, antibiotics, whether to give prophylactic antibiotics or not. Then endoscopy or ERCP, when to go for ERCP, and then the surgery. So coming to the analgesia, we have two options, whether to give NSAIDs or opioids, but both have their safety concerns. Talking about NSAIDs, it can affect the kidneys and it can also lead to GI blood loss. When we talk about opioids, it can lead to ileus and it also lead to sedation. So we have to choose amongst the two. So we have few studies that can help us out. The two studies from India, one was from AIMS in 2019 and the other was from PGI Chandigarh in 2020. So as per the AIMS study, they compared diclofenac 75 mg with pentazocine 30 mg and they used fentanyl as a rescue agent. If none of them was working, they used a fentanyl dose shot to rescue the pain. So in that study, pentazocine was better as compared to diclofenac. It required low dose. It had a long pain-free period. So pentazocine is better as compared to diclofenac. But when the study was done between tramadol and diclofenac, both were equally good. So you can choose either tramadol or diclofenac, but pentazocine seems to be better than diclofenac. Coming to fluid resuscitation, so the age-old notion was to give fluid as much as we can. So previously, patient used to land up in pulmonary edema and fluid overload. So this was a landmark trial that was published in NEGM in 2022 by D. Madaria, and it was named as the waterfall trial, in which they compared the patient. One was given the aggressive fluid resuscitation, and other was the moderate fluid resuscitation. In the aggressive group, they gave 3 ml per kg per hour, and whenever the patient had a fall in BP, they used to give a bolus of 20 ml per kg. In the moderate group, they gave 1.5 ml per kg per hour, And when there was hypovolemia, they gave a bolus of 10 ml per kg. So what was seen that the fluid overload was significantly less in the moderate fluid resuscitation group, in which we were giving 1.5 ml per kg per hour. So this was a landmark trial, and they concluded that among patients with acute pancreatitis, early aggressive fluid resuscitation resulted in higher incidence of fluid overload without any improvement in clinical outcome. So we can give either of it. It will not be affecting any clinical outcomes. The only benefit is that the fluid overload is less in the moderate fluid resuscitation group. So the preferred fluid is crystalloid. It can be NS or RL, but RL is preferred. In a single word, we can say that RL is anti-inflammatory. On the other hand, NS leads to hyperchloremic acidosis, so RL is preferred over normal saline. The rate is 1.5 ml per kg per hour. That has been taken from the waterfall trial. In case of hypovolemia, a bolus of 10 ml per kg can be given. But this fluid should be goal directed. Now, what is the goal? So whatever parameters that were deranged earlier, we need to correct those. So there was rise in the blood urine nitrogen. We need to see a fall in that. There was rise in the hematocrit. There need to be a fall in that. The pressures, the blood pressure should be, the mean arterial pressure should be between 65 to 85. The urine output should be good. It should be more than 0.5 ml per kg per hour. The lactate should be decreasing. So these are all goals, and a simple test we can do is the capillary refilling time. That should be less than 3 seconds. So the notion has shifted from aggressive to moderate fluid resuscitation. And what should be the frequency to assess these goals? It should be done within 6 hours of presentation, and then should be repeated at 24 to 48 hours. And the goal should be focused on blood urea nitrogen. That is in particular given in the ACG guidelines 2024. But why fluid resuscitation is so important, why it is required? So whenever pancreatitis occurs, there is increase in the there is more extravasation of fluid. So there is decrease in the intravascular volume. So that leads to decrease in the blood flow to the kidneys and decrease in the blood flow to the pancreas. So what happens, there are ischemic changes that are occurring in pancreas, and it leads to the perfusion of the gut bacteria and also leads to the necrotizing pancreatitis superseded by the infections. Coming to the nutrition, we should assess the nutrition in the first 24 hours. If the patient is having mild pain, patient is tolerating, not having any ileus, gastric outlet obstruction, no vomiting, no nausea, we can start oral feed as soon as possible, and the diet should be small, frequent, solid, fat-free diet. However, if the patient is having these symptoms, features of nausea and vomiting, then enteral nutrition should be promoted. That can be achieved either by a nasogastric or a nasojejunal tube. Trials have shown that both NG or NJ are equally good. NJ is preferred only when we are having any gastric outlet obstruction in the form of pylorus edema or duodenal edema. So NG or NJ both are good. Easier way is to go for NG. If the patient, then after putting the tube, a retrial of oral feeds should be given. However, if the patient is not taking orally and we require a longer TN treatment, then we can also go for or think of putting a feeding tube. This feeding tube is having a peg tube in place. However, if the patient is not tolerating any oral feed, not tolerating any nasoenteric feed, and not a candidate of putting a peg, then TPN is the only option that is left with us. So, summarizing the nutrition, so oral feed should be started as soon as possible within 24 hours if the patient is compliant. So that should be low fat solid diet. Enteral feed we can give if the patient is not complying to oral feed, but that has to be polymeric diet. Now, what is polymeric diet? Polymeric diet is what we are giving knowingly or unknowingly. That is polymeric diet. It comprises of proteins that are intact. It comprises of fats that are long chain triglycerides, and it comprises of proteins that are comprises of carbohydrates that are polysaccharides. So giving dal, giving milk, giving a banana shake through these tube is a polymeric diet itself. However, if patient is not compliant with this polymeric diet, we can shift to semi-elemental or elemental diet, in which the fats, proteins, and the carbs are in their basic forms. Coming to the rate of enteral feed, start very slowly, start at the rate of 20 ml per hour. But if we are suspecting any abdominal compartment syndrome, we should stop this enteral feed also. Requirements, the daily requirement should be that should be met is around 25 to 35 kilocalories per kg per day, out of which it should be predominantly carbohydrates, that should be 3 to 6 gram per kg per day. Indication of TPN, as I have already told, if the patient is not tolerating orally or via enteral feeds, or the patient is having prolonged ELS more than 5 days or having abdominal compartment syndrome, then we can shift to TPN. Coming to the infections, although not very common in the first phase, but still infection need to be addressed. 10 to 20% develop necrosis, out of which 1/3 becomes infected, and the mortality in this infected group is almost twice as high as the sterile necrosis. So infection of necrosis occurs after the first phase and not in the early case, and it is usually monomicrobial and is mainly caused by the gram-negative anaerobes. So how to look for infection? So an easy way is to look for the clinical deterioration if the patient is developing fever, if there are high CRP, high TLC, high procalcitonin, or if the patient lands up into organ dysfunction, then we should think of infection. Any positive blood culture, then infection is already proven, or we can just go for a CT, and if there is gas in the collection, then it also suggests a gas causing bacteria that also is a sign of infection. Whether to go for CT or EUS guided to take a biopsy or unconfirmed infection, no, it is not required, because by inadvertently we can introduce infection in those collections. So is there any role of prophylactic antibiotics in the first phase or in the early phase? So as per the guidelines, no, prophylactic antibiotics does not reduce infection of necrosis, but increases the risk of multi-drug resistance and fungal superinfection. How to avoid indiscriminate use of anti-infective? This is a study that was published in Lancet, and they told us that do a procalcitonin on day 0, day 4, and day 7, and then weekly. If the levels are more than 1, then we can start on the antibiotics, and then when the level goes below 1, then we can discontinue the antibiotics. This is something which is of importance to the gastroenterologist when to do ERCP in acute biliary pancreatitis. So two main indication, if the cholangitis is present, then we need to go for urgent ERCP. To define cholangitis, we can take the help of Tokyo Guidelines 2018. And if there is a persistent CBD stone or impacted stone, then we can go for ERCP up to 72 hours. Diagnostic ERCP is of no role. If CBD stone is suspected, we can go for MRCP EUS, or ultrasound from a good radiologist is also sufficient. Cholestasis alone is not an indication of ERCP. We should confirm cholangitis or presence of stone. What does the guideline says? So ACG 2024 says early ERCP is not routinely recommended without signs of cholangitis or biliary obstruction. Early ARCP within 24 hours is recommended only if the pancreatitis is complicated by cholangitis. International Association of Pancreatology 2025 says that early ERCP is not indicated in predicted mild biliary pancreatitis. Go for ERCP only if cholangitis is present. So one and the same thing, both the guidelines are saying the same things. What is the timing of coli? In mild acute biliary pancreatitis, coli should be planned before discharge only. However, if a moderate or severe course is there, then we should wait for coli up to 6 weeks. If there is a second episode of acute pancreatitis and no identifiable cause is present, irrespective of the age, then we should plan for cholecystectomy to reduce the risk of recurrent episodes of pancreatitis. This has been taken from ACG Guidelines 2024. Local complications, although not seen, usually seen after the first week, they can be acute pancreatic fluid collection or acute necrotic collection, and after 3 to 4 weeks, they get modified into either pseudocyst or walled-off necrosis. So to summarize my first phase of acute pancreatitis management, when the patient of pancreatitis present in emergency room, get a good history, get vitals done, parallelly send the investigations also, confirm the diagnosis based on the revised Atlanta class. If the 2 out of 3 criteria are being fulfilled, confirm acute pancreatitis, start fluid resuscitation as quick as possible, stick to moderate hydration and not the aggressive one. Pain is the main issue, so either we can go for diclofenac or we can go for tramadol. Pentazocine is also very good. And nutrition is something which we need to start as soon as possible. Oral is preferred. If patient is not taking orally, go for the enteral nutrition. If not enteral, go for the TPN. If there is a prolonged ileus or prolonged need of enteral nutrition is required. Plan for ERCP if biliary pancreatitis is present along with cholangitis or there is an impacted stone. So ERCP must be performed urgently in within 24 hours if cholangitis is present. However, if the stone is present, go for ERCP within 72 hours. That's all from my side. Thank you.
Uh, Dr. Saini, you have presented nicely. You have made a complex subject very simplified, understandable, and I must appreciate your talk.
Thank you.
Okay, I have one question. You said that if we have 2 episodes of acute pancreatitis and there is no cause identifiable, and ECG says that you go away and remove the gallbladder.
Yeah.
So, for the audience, what is the thought process behind that? Plain CT, if we have uncertainty in a diagnosis, rather than depending on an X-ray abdomen, which have a significant number of patients can be missed or perforation. The sensitivity of simple X-ray to detecting a pancreatitis is not what we expect. So we can, if we are in a doubt, so I think we should go for a plain NCCT abdomen rather than going for CECT abdomen in case of emergency. If we are confirmed with the diagnosis, then obviously we should be doing it next day or next day. This is, I think, should be the case. And the first one, tell me.
Yeah, coming to the first question. So the thought behind that, thought behind going for the cholecystectomy is that we are suspecting of a microlithiasis or a sludge that might be impacted at the ampulla that might have caused the pancreatitis, and now it has moved on. So if we are getting a repeated episode, we are getting a clear CBD. We are not getting any other cause. Let it be any biochemical parameters also normal. Any anatomical problem is not there. Or even we have ruled out infections. Patient might not be complaining of any fever in the past just before the episode of pancreatitis. Then we should consider for coli because that might be the reason for causing the pancreatitis.
This same event can be maybe genetic if they are not that severe. So we can't be saying that same line because the audience can be a general surgeon also, a simple PG also, which can be taking this as an indication for surgery. It has to be very practical that we have a female who is in 40s and we are not picking everything. Do not have a EUS. We do not want to pick up anything on which is not showing anything. And we are thinking that, okay, this is microlithiasis only, which is not been picked. And then only we want to get lab copy rather than every recurrent kind of event.
Point taken.
So for our residents, what is the fluid of choice that we use? I think in the emergency, the first question that we ask the resident is, what is the fluid of choice for pancreatitis patient? Like you told that we have to rush the fluids. So what is the fluid of choice that we should use?
Yeah, I have mentioned in that ringer lactate is preferred over
So
normal
any
saline.
specific reason why we prefer ringer?
Yeah, ringer lactate in short is anti-inflammatory. Secondly, normal saline can cause hyperchloremic acidosis. So ringer lactate is definitely better than normal saline. But if at all RL is not present, then we can also go for NS. It's not that we have to stick to RL only. So NS is also good. Crystalloids is the fluid of choice. Out of crystalloids, RL is better.
Thank you.
Thank you, sir. I would now like to invite Dr. Saurabh Singhal, sir, and all the chairpersons to felicitate Dr. Alok Kumar, sir. Dr. Vivek Saini, sir. Thank you, sir.
Next, we have a session on newer therapy of hypertension, including resistant hypertension in CKD by Dr. Alok Kumar, sir. And the respected chairpersons for the session are Deepak, sir, Dr. Ashutosh Jain, sir, Dr. Sahil Garg, sir, and Dr. Akash, sir. And Dr. Ankur, sir.
This is yes, this is यहाँ से and this is forward. Hand mic.
Hand mic, sir.
So very good evening to all of you. It's indeed proud privilege to be here in this town. Actually, this is my first visit in any scientific session to the Merit. I'm really thankful to the organizing committee of this conference for inviting me this and giving me opportunity of interaction with all of you. So I have mean to say, with all apologies, I have little mean to say changed the topic. I'll be talking resistant hypertension and newer therapies, because newer therapies are there because you have resistant hypertension, what I will to address. So first of all, we must understand what is resistant hypertension. So let us have idea. So resistant hypertension is actually roughly, if you have any population, you will get around 12 to 15% of the patients, depending upon the subset of the patients. If you are trying to address a population which is high risk, like if you have patient of CKD, it may go to the 30%. You have patient of sleep apnea syndrome or OSA, maybe it's for 35-40%. So depending upon the population, you have resistant hypertension. But for any place, roughly 15%. But always keep in mind that once we talk of resistant hypertension, first we talk of apparently treated resistant hypertension. That is ATRH. It will include all the cases which are referred to a person as resistant hypertension. We'll just talk what is that. But why it is important? It's important because patients with resistant hypertension will have around 32% higher risk of developing ESKD, 24% higher risk of the ischemic heart event, more of heart failure, even more chances of death in comparison to the guys who are not having resistant hypertension. The other part of story is, though BP control is associated with a lower risk of some CVD events. As we know, BP control is important. But in this subset, somehow there are studies which show that even only BP control is not giving that much advantage in this subset of patients, because there are certain other pathogenic mechanisms. We'll just begin with a case that a 45-year-old male who is having type 2 diabetes also. Patient is on nifedipine, control release 60 mg BD, losartan 100 mg, and chlorthalidone 25 mg daily. Office BP is 158 by 94 millimeter of mercury. Other drugs are atorvastatin and phenytoin also patient is taking for seizures. So with this picture, I mean to say that most of us would probably think of resistant hypertension at this point of time. But should we really think at this point of time? We'll try to answer that question. So this is the definition which AH has given about the resistant hypertension, that BP of a hypertensive patient that remains elevated, keeping in mind above goal, which may actually change. Sometimes it is 130/80, sometimes 140/90. So not at goal, despite the concurrent use of 3 antihypertensive agents, preferably long-acting CCB and either AC or ARBs and a diuretic. So in spite of that, you have uncontrolled. So let's see with our patient. So other important thing is the classes and doses. So our patient, we are talking that patient is on nifedipine, losartan, chlorothiazide. So by this definition, we have all 3 drugs which AHA has sold. So probably patient is fitting. Other important thing is we have to keep in mind about the dosages. So we have to see nifedipine control release is 120 milligram, which is by and large highest recommended dose. Losartan 100 milligram is again highest recommended dose. Chlorothiazide 25 milligram. So most of us are practicing probably higher dose, but AHA recommends that you can go up to the 50 milligram chlorothiazide actually. So there is a scope probably in this patient. Okay. Other thing is we have to keep in mind, which usually we miss, that drug interactions are equally important. Patient is on phenytoin. Patient has actually metabolism increase of the nifedipine because phenytoin is an enzyme inducer. It is well known that it actually induces nifedipine metabolism also. So many times if patient is on this, you might need to increase dose because drug will be lesser available. So keep in mind all these interactions. This is just an example actually. Other important thing is that one patient is coming to you with this, always have idea about the accurate measurement of BP. Keep in mind always because it is not being done. We'll just see the journey and always use validated BP instrument. I believe that if you are going to the wards, you will find various BP instruments. Those are actually not up to date. Various cuff is loose, sometimes mercury is leaking and all that happens. And on top of that, you are considering resistant hypertension. So we have to be very accurate. A study was done actually, which is by the Bhakhtar et al. They found that if a patient reaches emergency triage, they took blood pressure by a staff, then it was compared to the BP instrument, which is actually automatic. It has taken 6 readings. They compared that BP in quiet atmosphere was approximately 16-17 millimeter less actually. So you can see that how much difference is there. By the BP measurement, only 60 millimeter is huge number. In this study, they also found that patients, those were referred for resistant hypertension, approximately 1/3 patient had because of inaccurate BP measurement. Always keep in mind that BP measurement is very, very important. This is me to a checklist. All of us have idea, but we never give weightage. Which is an example mean to how to see BP. So this is a classical posture which has been taught me to, or each one of us knows actually, but I will just focus it. How many would be us be practicing? Just have a look at how to measure bare arm resting at heart level. And believe me, 80% BP is taken never in this posture. Patient will be on the stool, no backrest. Aajkal to bhai bahut thanda hai, very cold. How will you make patient bears BP like this? Not possible. So this is why that recent hypertension reference is to the clinic, to higher centers around 40% and turns out to be 15%. And there are studies showing that it is only single digit actually, if you truly exclude. So just see, why are we talking all these measures to be taken? Let's have a look. This is because of that. You can see that impact of each one of them is to that extent. If bladder is not empty, 10 millimeter rise. Place cuff on bare arm, you can have rise up to 50 millimeter of mercury. So all this idea tells us that if you are not taking measures, you are likely to overestimate blood pressure. Only one condition, if BP is oversized, you will measure little lower blood pressure actually. Otherwise, all these conditions will have rise of blood pressure. Okay. So other important thing we have to keep in mind that whether we are using which kind of instrument. So it is now recommended that we must use automated oscillometric BP instrument because it has advantage that patient is sitting in quiet room, patient is comfortable, and it can take BP 3-4 readings or 6 readings on its own. And it has been found that it is surrogate marker also like ABPM actually, because patient is comfortable. Though it can mean to say tackle some bias, not all of them. But very important message is that all guidelines have come from the studies, especially sprint and accord studies. And here BP was measured actually with this in classical conditions. And you are actually comparing all the blood pressure with yours where you are not following any of the guidelines actually. Believe me, most of us will not be measuring. Either a resident or a nurse will be measuring. Nobody will be taking care of that. Other important thing is white coat effect. Though white coat hypertension is, if you diagnose hypertension, white coat effect is in a patient of hypertension. So observation of repeated BP elevations in the office with controlled or significantly lower BP at home is called white coat effect. So we need to exclude that actually, if you are talking of resistant hypertension. So it is found actually, it may be present in around 1/3 of the patient. Those are referred for resistant hypertension. So for that answer is either we use ambulatory BP monitoring or we use home BP monitoring with a validated instrument. Very important that we have used validated instrument, keeping in mind that many instruments actually not validated after 3 or 4 years. So because patients will be using that. And very important thing, other is that we need to tell patient also that how will they take. If any mean to say there, can let me know that how will you advise the patient to take BP at home. It's very easy to say, how many blood pressure, how many readings, at what time. So it is very important that even पता लगा patient आया उसने कहा अपने यहाँ 2 बार लेना है, वो जल्दी में था उसने कहा यार अभी तो मैं एक्सरसाइज कर आया हूँ मैंने BP ले लिया डॉक्टर को अभी तो क्या होता है व्हाट्सएप फोटो भेज देगा यार 180/100 आ रहा है. So we need to tell the patient that how to take blood pressure. Okay. It is very important that adherence to the drugs, which is, I mean, there have been objective studies like if you measure metabolites in the urine, it has shown that across the globe, adherence is not more than 50%. Across the globe, whether it is India, it is US, anywhere. And I would like to remind you that this adherence we are talking, it is only 80%. जो इसका criteria है, that is 80% that patient is taking drugs 80% of the time, 20% तो वैसे छोड़ दिया हमने. But 80% is rough estimate. We don't have any logic why it is 80% adherence. But in spite of 80%, we have this much adherence. So there are various scenarios, maybe because of complex drug regimes, polypharmacy, medication cost, drug reaction, all that could happen because of that. Because easy to say, because I'm practicing nephrology. My patients are taking 15 drugs, 20 drugs. I mean, very difficult. I mean, to really hats off to the patients also, those are taking this amount of drugs. Sometimes I have a lot of nephrology colleagues. You will be writing drugs, you will be tired, yaar, kitna drug likhu main. Kai baar aisa hota hai, but keep on writing drugs. Okay. So monitoring is very important, but focus on the last line actually, that in a specialist setting, it has been found that if you practice directly observed therapy or you use drug screening, then you have objective measure of adherence actually. Otherwise, you cannot. You will ask patient will say, sir, I am taking the drug. And there is a study on the directly observed therapy, whether you are admitting patient or you are giving in your clinic. It was found that if you refer the patient for the resistant hypertension, approximately 25% patients improve with the directly observed therapy, which further tells you that there is problem with the compliance. This is usually forgotten that we are talking about drug, but adherence to the lifestyle modification is equally important. Salt is the main culprit. We need to tell the patient that please take less than 5 grams of the salt or less than 2 grams of the sodium. But there was a study which found that patients of resistant hypertension, those are truly resistant hypertension, सारे टेस्ट पास कर लिए. In spite of that, their 24-hour urinary level of sodium was more than 100 millicurrents. 25% patients were taking high sodium actually. Keeping in mind that amount of sodium you are treating in the urine, it is actually reflecting your amount of intake. If 100, you are taking 100, you are 200 millimole, you are taking 200 millimole. So salt intake is very high in most of the patients. There are studies which suggested that if you reduce their salt intake, many patients will actually get control of blood pressure. Similarly, alcohol intake, obviously, we need to take care. Other part is physical inactivity. A study has shown that if you introduce thrice weekly treadmill exercise, then approximately 1/3 patient would have some kind of response to your therapy. So physical inactivity is very important once we are talking of lifestyle, that if you introduce exercise, many patients of resistant hypertension do have control of that. So DASH diet, we all know, but there is no study to compare. DASH diet can really help in resistant hypertension, but with our standing, probably this may be important if we practice. Weight reduction is coming big way everywhere. So similarly here also, because obese patients have more chances of resistant hypertension. Besides that, other important thing is the sleep. A lot of studies have been done that if patient doesn't have sleep of 6 to 7 hours, patient's BP rises because of sympathetic stimulation. This is the main culprit for the obstructive sleep apnea as well, because they had not good sleep and they have more sympathetic stimulation, they have rise of blood pressure. So we have to exclude various actually drugs also, whether these are causing some kind of hypertension. So various actions are there: sympathetic action or volume retention, direct vasoconstriction. The big list of drugs, you can see that could be common drugs, bronchodilator, decongestant. I mean to say, is it EPO or is it NSAID? A lot of drugs. You need to exclude that also. Besides this, this is a group subset where there are high chances of secondary causes also. So we need to look for that also when we are talking about resistant hypertension. This is not exhaustive list. This is just give idea that always keep in mind about the secondary hypertension, especially aldosteronism, parenchymal disease and all that, because now we have a lot of data about actually hyperaldosteronism, that it is very important cause of the hypertension. So this is a chart which shows that what could be the possible causes in a patient of resistant hypertension. In resistant hypertension, you have actually these medication non-adherence. You can see approximately for 38%, but white coat effect, under treatment and inaccurate BP measurement are equally important. If you have idea, only one factor is because of patient, that is medication non-adherence. Rest here because of doctors. Inaccurate BP measurement, under treatment and white coat effect. So doctors are equally responsible for that. So this is, just to have idea about definition of that. That we have actually on one side we have controlled hypertension, on right side we have actually uncontrolled. So if it is controlled on more than 3 drugs, it is actually controlled resistant hypertension, otherwise controlled hypertension. And it is not controlled on even 5 drugs or more, it is called refractory hypertension. So there are some differences in the guidelines about resistant hypertension. AHA and BIHS, by and large, both say same, but I have marked in red. Actually, in British guideline, they say that you exclude secondary causes as well. And they also included that you must ensure there are appropriate lifestyle measures, which is not part of actually AHA, these two. So how do we manage? Already we have talked a lot of that adherence we have managed, and we have used first line drugs, that is CCB or diuretic and ARB or AS inhibitors. After that, once we have maximized this therapy, so there are suggestions actually that if PP is not controlled, we can try to substitute thiazide diuretic with a long-acting thiazide diuretic. That could be chlorothalidone or indapamide. There is a study which was done by Khosla that if you substitute that, it can provide further BP reduction. Besides this, a very good study by Dr. Agrawal, which was done in advanced CKD patients. He has found that if you use chlorothalidone drug in patients with advanced CKD, though classical teaching is you don't use in them, it gives you good control of BP actually. So I was also not using, for last few years I'm using because of that. But it is a good drug if you use thiazide-like drug. The 4th drug recommended is obviously mineralocorticoid receptor antagonist. After pathway 2 clinical trial, we are using spironolactone. But we have to keep in mind that if GFR is more than 30, only then we can use this, and potassium has to be obviously controlled. But other drug is that if you can use combination of sacubitril with valsartan rather than only ARB, it can also give you advantage of that. It can control BP a little better if you're using only ARBs with a combination of valsartan and sacubitril. If BP is still not controlled, we need to add then beta blockers, alpha blockers, whatever mean to say your choice is. And we have list of drugs. But we have to keep in mind that SGLT inhibitors do have BP lowering effect. So we can try to use them, though it is not approved for this. So this is a rough guideline. How do we do that? So for at first step, you are actually using standard drug. On second line, you are using MRAs. You're optimizing that. And step 3, you're using alpha blockers, beta blockers. And this guideline actually taken from the AJKD. So they are saying that even you can add up the non-dihydropyridine CCB also at this stage to this. And in step 4, you can either use alpha agonist or direct vasodilator. Though, but for all this, we are using actually alpha agonist quite early. So we can skip this. So some new drugs are there, mean to say this is drugs which are really mean to say cross lot of studies now. One of them is actually novel aldosterone synthase inhibitors, that is baxdrostate and londostate. Then dual endothelin receptor antagonist, that is aprocitentan. Small interfering RNA therapy, that is zilebesiran, and renal denervation therapy. We just talk a little bit about each of them. So this is a chart which is showing that where do these drugs act. On that, with the dark purple, these are new drugs. So naproxen inhibitors, we were just talking, this will be talking at the level of the heart. You combine with them with valsartan. And then you have a small interfering RNA, which will be acting at the angiotensinogen at the liver level. Then you have aldosterone synthase inhibitors, will be at the adrenal gland. Then you have non-steroidal MRA. But keeping in mind that these non-steroidal MRA are not having that much great antihypertensive effect as spironolactone has. Then also you have 12 endothelin receptor antagonists, as we have talked. So just we'll just have idea about this. Aldosterone synthase inhibitors. All of us know that this causes fibrosis, dysfunction, adverse remodeling, and all those effects. So this could be helpful in primary aldosteronism. It could be helpful in resistant hypertension and probably in CKD and heart failure as well. So this is actually one of the trial. It is phase 3 trial on the baxdrostate. We'll just have a look at this trial. Yeah. Recently published in NEJM in 2025. So there were approximately 794 patients. All of them were uncontrolled. There was some, mean to say, uncontrolled hypertension, some resistant hypertension. Mean drug requirement was 2 to 5. So you can see there are 3 groups: placebo, baxdrostate 1 milligram and 2 milligram. Each group has more than 250 patients. As you can see, control rate on this drug was approximately 40%, while placebo has around 19%. As you can see in this chart, that approximately you have advantage of 10 millimeter mercury reduction with this drug in comparison to the placebo. So it appears to be a good drug, but safety-wise, there was some hyperkalemia as expected by its physiology. But it was, they were able to tackle that. And there was some reversible dip of GFR as well, as you anticipate. And very important thing is, there was no adrenal or cortisol suppression seen with this drug. Other drug is the RenoGastro. It also had the same message. Mean to say, this is the same group of drug. Almost same message was there, only number of patients were less. Everything was same. So it is also equally effective. So next drug is the aprocitentan. This is a drug which actually has been approved in 24 by the FDA. It is orally active novel dual endothelin A and B receptor antagonist. You can use with the RAS inhibitors as well. Very few drug interactions. Dose is approximately 12.5 milligram daily, but in phase 3 trial it had been used up to the 25 milligram as maintenance dose. So with this, you had advantage that rough reduction of blood pressure was approximately 3.8 to 4 millimeter of the mercury with this drug. Side effects are edema, anemia, hepatotoxicity, and teratogenic risk. This was the trial actually, precision trial, which was the trial on. After that, there was actually, we got FDA permission. So, but it is not giving you that much great reduction of BP as aldosterone synthase inhibitors give. Only around 4 millimeter of the mercury is being given by that. So next in the group is a small interfering RNA therapy. We just, This therapy in hypertension is a cutting-edge therapeutic approach that uses synthetic RNA molecules to silence specific genes associated with the blood pressure. The main drug we have actually that is silencing angiotensinogen. We'll talk about that. So what does it do actually? It degrades target mRNA. There is no protein translation and there is a BP lowering effect because of that. So we can skip that. Yeah. So we have actually 3 targets. One is that angiotensinogen. We are talking, there is a drug for that. We have phase 2 trial with this. Then you have ENSC epithelial sodium channels, which is for the salt-sensitive hypertension. And lastly, you have mineralocorticoid receptor pathways. But we at present, there is only for the fun, that is angiotensinogen receptor. So obviously, these would be the indications, but main advantage is actually of the compliance. That is, if you give the drug only once in 6 or 12 months, then it is effective. That is the main advantage of that. So this was the trial with this Cardio-1 and Cardio-2 trial with this drug, that is the zilebesiran. This drug was in the phase 2 trial and they found the good results. As you can see that it reduces blood pressure up to the 15 millimeters of mercury, probably maximum which any drug could do that. But there are a lot of side effects. We'll just have about the side effects. These are the side effects actually. Is it? Approximately hyperkalemia 5.5%, hypotension 4.3%, and on top of that, there is acute kidney injury also in approximately 5% with this drug. So mean to say, really, we have to go forward with this drug, but this may be the future. Other thing is various interventions we can do that. One of them is, which is very popular, is renal denervation therapy. So guideline says that at present, you can use this therapy once BP is not controlled with the drugs. You have utilized all drugs, you have utilized all your, lifestyle modification, everything has been done, and still you don't control, then you can use renal denervation therapy. But at present, recommendation is that you have to use if GFR is more than 40. So mechanism of action is that it will reduce sympathetic outflow, and then renin-angiotensin system activity is also low, and sodium retention would be less. There are various trials to support that. We'll just go through that. So it gives you reduction of approximately 5 to 15 millimeters of the mercury blood pressure, and it is sustained for the 3 to 5 years. So there is good safety data now with a lot of trials has been done on the renal denervation. But the thing is, if for most cases with advanced kidney failure, we don't use much. So there is now some experience coming that there is in last year there has been subset trial of the simplicity that it can be used up to the GFR of 30. They have found that. But at our institute, we have actually used in 2 patients with GFR approximately 15 to 20. And fortunately, we had the good results. This is what probably we can also try to use. Why should we not use? Other interventions are carotid baroreceptor modulation. Earlier trial was CALM-1 study which was done, which showed good results, but it failed because of the side effects. So that CALM-2 study was there, which was cancelled. We don't have any study for that. Next is the cardiac neuromodulation therapy. If somebody is on pacemaker already for some indication, then we can use this therapy. It has shown some promise, but is still not established. So to conclude, resistant hypertension is diagnosed when BP is not controlled on 3 or more drugs, including a diuretic. We need to exclude pseudo-resistance as we have talked various factors. And we can try to replace thiazide diuretic with chlorothalidone or indapamide. We try to add MRAs, and renal denervation may be helpful in some cases, but still we have to travel a lot for these new drugs. With this, I would like to thank you very much for your patient listening.
Thank you very much, Dr. Alok. It was indeed Nice talk. You covered all the aspects of resistant hypertension. I like to say that, as you said, resistant hypertension from the beginning of the definition to the treatment, a clinician should not be in a hurry to declare it as a resistant hypertension. There are many other causes like drugs, as you tell, and incompliance. And secondly, we should not keep on adding the drugs without waiting. It should not be done hurriedly. We should give some time to the drug we are adding, and it should be a stepwise approach. So I think with this we'll conclude. Thank you very much.
Thank you so much, sir, for this wonderful talk. Now I would request all the chairpersons to felicitate Alok, sir, along with Saurabh Singhal, sir.
एक सर का सर्टिफिकेट भी होगा ना सर का आज तो सर का सर्टिफिकेट भी आज तो क्या
Now we'll proceed for the quiz. Respected teams are allowed to come and sit in the front.
I would request all the teams who have been selected from the prelim rounds to come forward. LLRM Medical College, Santosh Medical College, Subharti Medical College, MBBS 21 batch, Subharti Medical College, और कौन सी? सुभारती इंटर्न्स, फाइनल टीम सुभारती इंटर्न्स. So may the best team win. I assure there will be no partiality. We have a very brilliant quiz master with us, Dr. Sumit Kanja. वो पार्शियलिटी अलाउ नहीं करेंगे. नीचे चाहिए स्टूडेंट्स पे.
नहीं नहीं, मतलब ये डायरेक्ट कहाँ से आ रहा है? नहीं नहीं हो जाएगा. So team A is final year. Team A is intern. Right? Team A. तो सबसे साइड में जाओ. या नेक्स्ट रो पे आ जाओ. टीम बी इज कौन सा? इंटर्न. MD23 शुभारती. इंटर्न. E is संतोष. MD24 शुभारती. आ जाओ. So there will be 5 rounds. ठीक है, 2 गैस्ट्रो के राउंड हैं, 2 रीनल राउंड हैं. राउंड 1 एंड 2 में कोई पासिंग नहीं है, इसीलिए रैंडमली बिठाया है, क्योंकि पार्शियलिटी ना हो, ये ना हो कि हमने जानबूझ के किया है. राउंड 1 एंड 2 आर MCQ. अगर आप पहले अटेम्प्ट में सही आंसर देते हैं तो यू विल गेट 10 मार्क्स. इफ यू आर रॉन्ग, यू विल बी आस्क्ड वेदर यू विल ट्राई सेकेंड टाइम और नॉट. लेकिन अगर दूसरी बार अटेम्प्ट करते हैं तो गलत होने पे -5, सही होने पे +5. अगर आप वहीं छोड़ना चाहते हैं तो ही स्किप कर दो. तो फर्स्ट 4 राउंड्स, तो पहले 2 राउंड ऐसे ही हैं, मल्टीपल चॉइस. पहली बार में सही हो गया तो 10, उसके बाद गलत होता है, पहली बार नेगेटिव मार्किंग नहीं है, दूसरी बार आपके पास ऑप्शन है, अगर गलत होता है तो -5, सही होता है तो +5. राउंड 3 एंड 4 आर डायरेक्ट क्वेश्चंस. डायरेक्ट मीन्स नो ऑप्शंस अवेलेबल. इफ राइट +10, इफ रॉन्ग 0. If right 10, if wrong 0, no second attempt. And last round is buzzer और पहले हाथ उठाना है. क्वेश्चंस आएगा, अगर आपको आता है तो हाथ उठाना है. सौरभ सर विल से विच टीम जिसका हाथ, लेकिन हाथ उठाने के बाद गलत होने पे -10, प्लस होने पे +15. ज्यादा बेनिफिट भी है, ज्यादा नुकसान भी है. क्लियर? पीछे से मरमरिंग नहीं होगी, क्योंकि क्वेश्चन बहुत ज्यादा नहीं है, तो ऐसा नहीं हो कि हमें कैंसिल करना पड़े. पीछे से मरमरिंग नहीं करना है. सो टीम ए is MBBS 21, team B LLRM, team 3 Subharti final year MD 23, team 4 intern, team E Santosh, and team 6 is Subharti second year. So the round 1 starts. Question 1 please. From team A. Slide change. What is imaging modality of choice in suspected renal hematuria? Options are IVP, angiography, CT abdomen, or retrograde urography? 15 seconds. चलो पहली बार आंसर दो. Option A is wrong. You want to try again? अगर ट्राई करना हो तो करो, नहीं तो छोड़ दो. No murmuring, please. No murmuring.
Why?
CT abdomen. Right answer is so +5 to team A. Second question, team B, LLRM. Question, please. What is not a feature of pre-renal ARF? What is not a feature of pre-renal ARF? Urine plasma osmolality ratio more than 1.5.
Sir, option 4, phenol greater than 1.
Right, option 4 is right answer. Fraction extraction of sodium, it should be less than 1%. So 10 marks to team B, 5 to team A, 10 to team C. Third question to Subharti MD23 batch. Which of the following has rate of urinary excretion almost always identical to its rate of glomerular filtration in healthy individual? Glucose, sodium, creatinine, and chloride.
C.
C, creatinine, right answer, 10 marks. That's why we use creatinine clearance. 10 marks to team C. Question 4 for the interns, team D. All are causes of functional or transient proteinuria except obesity, exercise, emotional stress, and prolonged anesthesia.
Sir, A.
A is wrong answer. You want to try again?
Sir, D.
Option D is right. Prolonged anesthesia is right answer. So 5 marks to team D. Next for team E, Santosh Medical College. Which type of renal tuberculosis is associated with normal anion gap, hypocalcemia, nephrocalcinosis, and medullary cyst?
Type 1.
Pardon?
Type 1 artery.
Type 1. 1 minute. So type 1. Question. Yes, type 1 is right answer. 10 marks. Last question goes to MD24 batch. Question, please. Polycystic kidney disease 2 gene is located on which chromosome?
Sir, A, chromosome 4.
So chromosome 4 is right answer. 10 marks. I think all are on 10 except MBBS final year intern. They are on 5.
Yes. Moving on to the second round.
So second round, same pattern from GI system. Round 2. Round 2, please. First question to team A. अरे ऐसे ना करो यार.
मिस हो जाएगा कुछ.
राउंड 2 बस ओपन करो.
राउंड 2 ओपन करो. राउंड 2.
या तो आगे कुछ रख लो. क्वेश्चन सब
आगे कुछ रख के तब करो, नहीं तो फिर कुछ नहीं. इसलिए स्लाइड वो आगे रख के दिवाई की नहीं है.
हाँ ठीक.
ओके.
Question 1 to final year student. Round. Weil's disease, a common cause of jaundice, is caused by Treponema pallidum, Leptospira, Treponema whipple, or Epstein-Barr virus.
पीछे से नो काउंटिंग.
Sir, B, leptospira.
Leptospira is right answer. 10 marks to team A. Second question to team B, LLRM. Acute diarrhea is labeled when the duration of disease or diarrhea is more than,
Less than 14 days.
Pardon?
Less than 14 days.
14 days. Acute diarrhea less than 14 days. 10 marks to team B. Third for final year, Subharti. Question 3. Absence peristalsis and failure of deglutitive lower esophageal sphincter relaxation is typically seen in which disease? DES, eclasia, Skarsgården, or eosinophilic esophagitis?
Ecclesia cardia.
Ecclesia cardia, right answer. 10 marks to team C. Fourth question for interns, team D. Which of the following produces enterotoxin? Enterotoxin. All are GI bacteria. Clostridium perfringens, Vibrio cholera, Giardia, or hemorrhagic E. coli. No murmuring, please.
Sir, A.
A is wrong answer. You want to try again? No, they have skipped. Anyone from audience? B, Vibrio cholera is right answer. देख लो किसने दिया है.
जिसने दिया है वही आए और ये सोच के आए अगला क्वेश्चन भी पूछा जाएगा उससे.
Question 5 is for Santosh Medical College, team E. Which serum marker will be present in post Hep B vaccinated patient or people like us?
सर एंटी HBsAg.
कौन सा ऑप्शन बताओ?
B.
B is right answer. Anti HBs antigen antibody. 10 marks to team E. Final question for team F. Where is area prostema located? Midbrain, pons, medulla, or cribriform plate?
So, midbrain A.
No, wrong answer. Want to try again?
C, medulla.
Yeah, medulla. Area prostema is the vomiting center. Chemoreceptor trigger zone. It is located to medulla. 5 marks to team F. वहीं से बोल दो या तो तुम ही बोलो.
Final score is 15 for MBBS 21 batch. LLRM 20 marks. MD 23 20 marks. Intern 5 marks. Santosh 20 marks. And MD 24 15 marks.
So the third round is renal, no option. आपको जवाब देना है सही पे 10, गलत पे 0, लेकिन एक ही अटेम्प्ट मिलेगा.
ये कैसे होगा?
नहीं, इनके पास
टीम. अच्छा.
First question to team A. A distinctive round pinkish deposits of extracellular matrix formed in glomeruli in case of long-standing diabetes. What is this lesion called as?
Sir, Kibble-Winstall granules.
I will grant it as KW lesion, Chemistine-Wilson nodules. 10 marks to team A. Now for team B, LLRM. What is the most common cause of adult nephrotic syndrome? Nephritic syndrome, sorry.
Sir, IgA nephropathy?
Yeah, IgA nephropathy is the right answer. 10 marks to team B. Third question to MD23 batch. Flea-bitten kidney on kidney biopsy is seen in which disease? Which glomerulonephritis?
So malignant hypertension.
No. Anyone from audience?
RPGN, sir.
Endocarditis. Endocarditis associated glomerulonephritis. So 0 marks. Fourth, endocarditis. Subacute bacterial endocarditis. Fourth question to team D. Interns. Syndrome associated polyuria, polydipsia, hypophosphatemia, rickets, and type 2 renal tuberculosis. Audience?
Diabetes encephalopathy.
No. Audience? No. Fanconi syndrome, given by a faculty. The chocolate to Dr. Prashant. Fifth question to Santosh Medical College. E. coli strain O157S7 is associated with which kidney disease?
HUS.
Yeah, right answer. Hemolytic uremic syndrome. 10 marks to team E. And final for team F. Crescent shaped formation.
RPGN.
Okay, 10 marks to team F, but who told from out backward? पीछे से कौन बोल रहा था? It's RPGN. 10 marks to team F. Marks.
So after round 3, MBBS 21 at 25 marks, LLRM at 30 marks, MD 23 20 marks, intern at 5 marks, Santosh again at 30 marks, and MD 24 at 25 marks.
So not much to gap between. You can catch up any time. Round 4, GI system direct question. Now this time, first question to team F, MD 24 batch.
Akash, mic.
Question 1. What is the cause of pancreatic cholera? Watery diarrhea, hypokalemia, achlorhydria syndrome.
VIPoma.
VIPoma is right answer. It's non-beta cell pancreatic tumor. 10 marks to team F. Next question to team E, Santosh Medical College. Which chemical reaction is done to differentiate between direct and indirect bilirubin? No murmuring, please.
Ammonium chloride test.
No, wrong answer. Audience, anyone? Vanderberg test, right answer. Vanderberg.
आ जाओ आगे आ जाओ.
Name please. क्या नाम है?
नाम बोलो बेटा. साक्षी.
Third question to the interns, team D. Anti-SLA, soluble liver antigen, is associated with which type of hepatitis? No murmuring, please.
Autoimmune type 1.
Autoimmune hepatitis, right. 10 marks to interns. Fourth question to Subharti, final year. What should be the minimal score of discriminant factor in case of alcoholic hepatitis to start steroid?
So more than 32.
32 से ऊपर है तो 10 marks to team C. Next for team B, LLRM. Lennox cirrhosis is also known as or caused by which thing?
So post hepatitis.
No. Anyone from audience? Post-alcoholic micronodal sclerosis, also called as Lennox cirrhosis. So 0 marks to team B. Final question to team A, the final year students.
मुश्किल है
उनके लिए मुश्किल. That is why this is lucky one. जो practice करें उनके लिए easy है. What is the infusion rate of octreotide in acute variceal bleed? जो students के लिए ज़्यादा easy होगा. Anyway.
5 mg.
No. Anyone from audience? 50 to 100 microgram per hour. So 0 marks to team. Yeah, ऐसे PG के हिसाब से सोचा.
MBBS 21 after round 5 20 marks.
नहीं 25. अच्छा
25 sorry. 25 ये round 5 पे 0 है ना.
MBBS final year, team A is 25, team B is 30, team C is 30, team D is 15, team E is 30, and team F is 35. So now
Last round.
yeah, we have 8 questions right now. हाथ उठाना है, लेकिन हाथ उठाने के बाद you cannot back up. If right, तो रिवॉर्ड्स ज्यादा हैं, 15 मार्क्स. सही होने पे 15 नंबर, गलत होने पे 10 माइनस, 10 माइनस. और पीछे ऑडियंस जवाब मत देना. 8 क्वेश्चंस आएंगे, so you can get 120 marks in this. So question 1, ये टफ भी है थोड़ा सा. What is the name, इसके 30 seconds रखना, given to the condition of intrahepatic cholestasis associated with renal cell carcinoma? जी renal दोनों आ गए इसमें. Intrahepatic cholestasis seen in renal cell carcinoma, उसके लिए एक नाम दिया गया है, एक सिंड्रोम है. ऑडियंस, स्टॉफर सिंड्रोम.
चैट जीपीटी जल्दी चल रहा है बहुत.
आ जाओ भाई, टॉफी ले लो, बाद में ले लेना. नाम बता दो.
नाम बताओ, कौन बोला था?
सो
खड़ा हो जाए एक बार.
So stopper syndrome. The score stays at same level. Second question. Question 2. Single ulcer visible on cystoscopy in bladder pain syndrome is known as. Bladder pain syndrome एक अलग एंटिटी है, उसमें सिस्टोस्कोपी और एक अल्सर दिखता है तो उसको क्या कहते हैं?
हाँ बोलो. खड़े हो जाओ.
Hunner's ulcer.
Hunner's lesion, right. 15 marks. आप थोड़ा इधर आ जाओ भाई. आगे आ जाओ. नहीं, you just keep moving. Question 3.
आगे आ जाओ.
Jenker's diverticulum, a common cause of dysphagia.
Interns, first सबसे पहले
Is due to involvement of which muscle? Interns.
Cricopharyngeus.
Cricopharyngeus. 15 marks to team B. पीछे से मर्मरिंग नहीं करो यार.
No murmuring.
Fourth question. Lubiprostone, a novel agent. LLRM. Chronic constipation. This is secretory agent. 15 marks to LLRM, team B. Question 5. Which virus is commonly responsible for diarrheal outbreak in cruise ship? आकाश, आप उधर आओ.
हाँ इधर. अंकिता. इधर. अंकिता.
Sir,
Pardon?
norovirus, sir.
जोर से बोलो. खड़े होके बोलो.
Sir,
सही बोलो.
norovirus.
Norovirus. Right answer. Question 6. What are the components of MELD in LLRM?
Serum creatinine, bilirubin levels, and INR.
INR. Bilirubin, creatinine, INR. 15 marks to team B. 2 क्वेश्चन बचे हैं. Question 7. What are the components of FIB 4 score?
खड़े हो.
क्यों हाथ उठा? नहीं, पासिंग नहीं है, आइदर प्लस और माइनस।
खड़े हो बोलो।
AST, ALT, platelets and age.
नहीं, नो मार्क्स। फिर से क्वेश्चन पीछे से प्रॉम्प्ट नहीं करना है यार।
प्रॉम्प्ट नहीं करो भाई, कौन प्रॉम्प्ट कर रहा है पीछे? पीछे कौन है? LLRM स्टूडेंट्स नहीं, पीछे तो अपने ये MBBS के स्टूडेंट्स हैं। ये क्या
पीछे से प्रॉम्प्ट नहीं करना है।
ये क्या बताएंगे?
गलत बताएंगे।
नहीं नहीं, एज आया था।
एज आया था।
चलो एक क्वेश्चन ये कैंसिल कर दें। नेक्स्ट नेक्स्ट भी रिपीट।
कैंसिल किया।
क्वेश्चन 8, ये भी अगला करो, ये भी हो चुका है अभी। क्वेश्चन 9, व्हाट इज द क्लासिक ट्राइड इन HSP, इनॉक्सिटोन एंड परप्यूरा? चलो फाइनल ईयर
उठाया ना? उठाया नहीं उठाया। किसने और उठाया? कोई और वो उधर उठाया? MBBS।
Sir, MAHA, HUS और
राइट, 3 चीजें होनी चाहिए।
sir,
हो गया।
चलो सेकंड
चांस नहीं मिलेगा।
चांस नहीं मिलेगा।
ऑडियंस -5 -10
-10 80
80 -10
-5 है।
-10
-10 है फल राउंड में।
अभी एक क्वेश्चन और बचा है। कोई ऑडियंस है? कोई तुम लोगों में से कोई बिना मार्क्स के? परप्यूरा, आर्थराइटिस एंड पेन। एक क्वेश्चन बचा है, लास्ट क्वेश्चन। उससे पहले मार्क्स बता दें हम लोग। एक क्वेश्चन बचा है बस।
60 LLR में 60।
टीम A 15, टीम B 60, C 60, टीम D 30, टीम E 30, टीम F 35. So for the first position is you can try, or for second position as well.
Last question.
Last question, sir. हाथ देखते रहिए। Question 10. Next question. Fanconi syndrome affect which part of nephron?
फर्स्ट उन्होंने उठाया, सेकंड उन्होंने उठाया।
किसने पहले?
फर्स्ट उधर LLR में उठाया।
LLRM.
Sir, proximal tubule.
Proximal tubule is the right answer. फाइनेंस को सर आप ही बताइए।
हो गया बस, और क्वेश्चन तो नहीं ना? खत्म।
अब ऑडियंस के लिए रखे थे।
लाओ स्कोर कैलकुलेटर है। कम क्वेश्चंस आप लोग की ऑडियंस
अपने नाम बता देना। डॉक्टर ध्रुव टॉफी देंगे बाद में। टॉफी देंगे।
तुम्हारी औकात इतनी है बस भाई ध्रुव।
नहीं, मार्स भी खुला है बगल में। चलो नेक्स्ट क्वेश्चन फॉर ऑडियंस ओनली, नॉट फॉर पार्टिसिपेंट्स। चाइल्ड बुक स्कोर का कंपोनेंट फाइनल ऐसे कोई नहीं, फॉर ऑडियंस। आ जाओ बोलो।
आजा बेटा।
आकाश माइक।
Encephalopathy, ascites, PTINR, creatinine, albumin.
नो, इट्स बिलिरुबिन एंड एल्बुमिन।
Bilirubin.
4 सही हैं तो भी कंसीडर कर लो। चलो
दे दो भाई एक चॉकलेट।
ले लेना इनसे।
आकाश नाम नोट कर लेंगे। नाम नोट कर लेंगे।
एक तो गोपाल था और एक इसका नोट कर लो बेटा। गोपाल ज्यादा पॉपुलर है शायद, उसके नाम पे ही होश हो जाती है।
नेक्स्ट क्वेश्चन, कोलैप्सिंग नेफ्रोपैथी और कोलैप्सिंग ग्लोमेरुलर
सेगमेंटल
स्क्लेरोसिस किस बीमारी से एसोसिएटेड है? हाँ, HIV एंड नेफ्रोपैथी। कोलैप्सिंग इज टिपिकल हॉलमार्क ऑफ HIV नेफ्रोपैथी।
गुड। नाम? इशिता। बैठ जा बेटा।
एक क्वेरी आई है सर, एक क्वेश्चन में जो क्वेश्चन था बिटन किडनी वाला, जो था
फ्ली बिटन किडनी,
मैलिग्नेंट हाइपरटेंशन, उसमें मैलिग्नेंट हाइपरटेंशन की वजह से भी वो अपीयरेंस
सर तो मैं हमारे वालों में
डॉक्टर सुमित बताएंगे क्या था।
चलो आई मे बी रॉन्ग, मतलब
flea bitten kidney.
We can check it here. अगर सही है तो फिर दे दे मार्क्स. कहीं चेक कर लो भैया. ऐसे मुझे यहाँ पे क्या होना चाहिए.
आपने क्या दिया था आंसर?
मैंने पेंडोकार्डिटिस सोसाइटी.
अच्छा.
चेक कर लो. They are right. We will give them 10 marks.
सर ये है सर. Malignant
Okay,
hypertension.
I am wrong. दोनों में मिलते हैं. Malignant hypertension also wrong. Right answer. So 10 marks.
10 marks.
दे दो.
फिर ज़्यादा फर्क पड़ेगा नहीं.
कुछ नहीं फर्क पड़ेगा. 60, 70 हो गए. बस 10.
चलो इससे आगे करें.
70 हो गए.
What are the components of PELD? PELD.
PELD.
बच्चे पढ़ रहे होंगे. Any from PGs? PGs से
हमारे फर्स्ट ईयर PGs नए नए आए हैं बहुत सारे. LLRM चलो ये तो बैठे हुए हैं यहाँ पे 4 लोग.
चलो ये चॉकलेट मेरा हो गया. बिलिरुबिन, INR, एल्ब्यूमिन, एज एंड लेवल ऑफ ग्रोथ फेलियर. 5 चीजें आती हैं पेल्ड में. नेक्स्ट क्वेश्चन. Inherited carbonic anhydrase 2 deficiency can cause which type of RTA? Renal tubular acidosis.
बोलो खड़े होके.
No. Anyone?
No.
It's type 3, mixed type.
Type 3.
Question 15. Which renal disease is associated with accumulation of very large millimeters of VW factors? TTP,
Thrombotic thrombocytopenic purpura. चलो हो गया तुम्हारा.
What is the full form? KDIGO guidelines पूरे दिन आज सुना है. KDIGO का full form क्या है?
ये तो रेजिडेंट्स को बतानी चाहिए.
क्या बता रहे हैं?
स्टूडेंट भी बता रहा है.
Yeah, kidney disease improving global outcome. चलो
हो गया. So it's time for the results now. Very evident. We have at third position with 35 marks, residents of Subharti Medical College 24 batch. आ जाओ आगे. चलो डॉक्टर सुमित देंगे ट्रॉफी. हाँ थर्ड प्राइज वाली. वो सर्टिफिकेट. At second position, again we have MD 23 batch, Subharti Medical College, with 70 marks.
सब वो बस ये उसमें रैपिड में कुछ नहीं है.
Yes, with a huge round of applause, our winner of the quiz is a team from LLRM Medical College with 75 marks. Definitely they have done well.
All have done well. Interns.
Yeah, interns also have done very well.
Santosh, I think they missed.
वो they missed the
rapid fire
round miss कर दिया उन्होंने. अपने इंटर्न्स के लिए और एमबीबीएस स्टूडेंट्स के लिए भी हम कुछ देंगे. कल आना, ठीक है ना? छुट्टी नहीं अनाउंस करूंगा कल की. पेपर पोस्टर कर रहा है क्या कोई प्रेजेंट? ये कर रहा है, चलो बहुत बढ़िया. कल मिलते हैं पेपर पोस्टर में. सो आई थैंक ऑल द रेजिडेंट्स हु हैव कम फ्रॉम देयर कॉलेजेस फॉर दिस कॉन्फ्रेंस. We will be meeting them again tomorrow at paper and poster presentations. After this long day of scientific sessions, you might be exhausted, but we will be meeting again in the gala dinner, which we will be having in the college lawns from 8 p.m. onwards. All are invited to enjoy the gala dinner. Not MBBS students. All interns, those who have registered, all residents, those who have registered from any department are welcome to the gala dinner. जिन्होंने MBBS स्टूडेंट्स ने यहां पर बैक स्टेज हेल्प करी है, दे आर इनवाइटेड. ठीक है ना? और ये टीम भी इनवाइटेड है और ये टीम भी इनवाइटेड है. ये टीम इनवाइटेड है MBBS स्टूडेंट्स की जिन्होंने क्विज में पार्टिसिपेट करा है फॉर द गाला इवेंट. So from behalf of the Department of Medicine, I solely thank all of you to be here, especially to my MBBS students जिन्हें बांध के मैंने बिठाया यहाँ पे. Thank you for not letting me down, because आप हो तो अभी तो जोश है यहाँ पर हॉल में, नहीं तो कोई ताली भी नहीं बजा रहा है यहाँ पे. Thank you so much. Thank you. All organizers to come on the stage please for a group photo. अरे सब आ जाओ. श्रीकांत, रुद्राक्ष, त्रेयान, अपूर्व. इनको पहुंचवाने पड़ेंगे सबके. वीसी सर का, प्रिंसिपल सर का, सत्यम सर का, जो नहीं ले गए उनके पहुंचवाने पड़ेंगे. The LLRM team, you will be getting your cash prize tomorrow. You are coming for the paper poster? None of you are coming for the paper poster? So I will deliver it to Dr. Yogita. ठीक है ना?
अरे नीचे बैठो, अरे नीचे बैठो।